Good morning, everyone. We are just going live in just 10 to 20 seconds, and Prinja sir will introduce the chairs first. Thank you.
All right. Thank you very much for the patient wait. I think we are right now live streaming and very warm welcome to all the delegates who are participating in this 48th National Conference of the IAPSM. It's a great pleasure for me to invite Dr. Nishant Jain, who will chair this session along with Professor O.P. Kalra. Dr. Nishant Jain needs no introduction. So he's perhaps the most knowledgeable person, the great authority on health insurance in India, and the one who actually created the scheme for RSPY. Dr. Nishant Jain needs no introduction. So he's perhaps the most knowledgeable person, the great authority on health insurance in India, and the one who actually created the scheme for RSPY. Dr. Nishant Jain needs no introduction. So, and he's perhaps the most knowledgeable person, the great authority on health insurance in India, and the one who actually created the scheme for RSPY. Dr. Nishant Jain needs no introduction. So, and he's perhaps the most knowledgeable person, the great authority on health insurance in India, and the one who actually created the scheme for RSPY. Dr. Nishant Jain needs no introduction. So, and he's perhaps the most knowledgeable person, the great authority on health insurance in India, and the one who actually created the scheme for RSPY. Dr. Nishant Jain needs no introduction. So, and he's perhaps the most knowledgeable person, the great authority on health insurance. Is it only I who am hearing my own echo, or is it you as well?
I am hearing the same message every time.
No, it's going on a roll.
Perhaps the most knowledgeable person, I stopped in between thinking that what is happening. Is it only I who am hearing my own echo, or is it you as well?
I am hearing the same message every time.
No, it's going on a roll.
Perhaps the most
For all, it's for all.
Okay, I think it's sorted, is it?
Yes, now we can hear you live again.
Great. Thank you so much, and sincere apologies for all of this. So again, I mean, I'll try and skip the long story and cut it short. I think everybody knows Dr. Nishant Jain, who's been a thought leader in this field of health systems and finance. He's the senior advisor to the Government of India on design of implementation of the Iapsmcon Bharat Pradhan Mantri Jan Arogya Yojana, and had been the person who created the RSBY scheme earlier. He's published widely on various issues. The other chair, the second chair that we have for this session, if we can go on to the next slide, is Professor O.P. Kalra. Professor O.P. Kalra is an eminent nephrologist, a clinician, and who is an administrator right now, who's the Vice Chancellor of the Pandit B.D. Sharma University of Health Sciences in Rohtak. He is currently also holding the position of the President of the Association of the Indian Health Sciences Universities, with a teaching experience of more than 38 years as a professor of medicine for more than 25 years. So he has published very widely more than 300 scientific papers with wide national and international awards, including the prestigious Dr. B.C. Roy National Award. So without further ado, I'll hand over the session to Dr. Nishant Jain and Professor O.P. Kalra.
Thank you, Shankar. Thank you very much. And welcome to all of you for this very interesting session. And we have a set of eminent panelists, and I'm very fortunate to be co-chairing this session with Professor Kalra. So
Thank
as
you.
we all know that this topic is very important of impact of publicly funded health insurance schemes on the country. And this is something which is resonating a lot in the current time, especially with the pandemic and everything. The need for a health insurance and need for health protection is being felt much more. And as you, many of you may be aware that, government started since more than a decade, these kind of initiatives. And the most famous one started with Andhra Pradesh, where there was a scheme called Arogyashri. And then the biggest national one at that time was Rashtriya Swasthya Bima Yojana, which came in 2007-8. And then now in 2018, government launched Pradhan Mantri Jan Arogya Yojana, which is the largest government-funded health insurance scheme in the world. So these various schemes have been launched, but at the same time, it's also interesting to see that they are facing many challenges. And also, how do we make sure that the benefit of this scheme reaches the poor, and where are the gaps? So, and what could be the way ahead? Because even in spite of all that PMJ covers roughly 40-50% of the population, and there are some other schemes which cover some more, but still there are around 40% of the population which is not covered by any of these schemes, and that is something which is a huge challenge for the country. So before we go to the speaker, I would like to ask Professor Kalra if he may be allowed to give a brief introduction.
Professor Kalra, you'll need to unmute yourself.
Professor Kalra.
Thank you very much, Dr. Nishant. In fact, I fully agree with you. Until about 10 years back, there was hardly any talk about health insurance coverage in India. Although it is one of the mandates as defined by the United Nations several years ago. But we did a small study at our hospital, which is a leading hospital in Delhi, among the patients who are coming to the emergency. And 90% of the patients who are coming to the hospital are from the lower socioeconomic strata of the society. It was surprising to know that only about 1.2% of the patients had some kind of health insurance coverage or medical reimbursement facility. So this is where the need is felt. So it's very nice that the Pradhan Mantri Jan Arogya scheme has been launched across the country, and 40% of the people are going to be beneficiary. I think these are the people who require it most. But it has been now more than 2 years since the scheme was launched. It's very important for all of us to take stock of what is the progress made so far, and what are the difficulties or challenges being faced. So in this next 45 minutes, 50 minutes, we'll be discussing about what have we achieved and what is the way forward. Thank you very much, Dr. Nishant, and we can go on to the first speaker now.
Thank
Dr.
you.
Nishant, please. Yeah.
So
Dr. Nishant will introduce the first speaker.
thank you, Professor. So as we'll go to the speakers now, we have 3 eminent speakers, and I'm very happy and fortunate to introduce the first speaker, Ms. Sheena Chhabra, who is right now from the World Bank. Sheena is a long-term, from very long, she has been associated with these topics in the country, and she has 3 decades of career in this field. And she was earlier for a long time with USAID before she joined World Bank in the recent past. And she also leads the analytical and technical advisory services for Iapsmcon Bharat from the World Bank side, and also the NITI's National Annual Health Index and Uttarakhand Health System Development Project. And she has a long history. She has been working in this sector for long years, and she has very good clarity of thought on how things are, how they can be, and how actually they should be. So we are very happy that Sheena has been able to join us, and I invite Sheena, please start with your presentation. And for all the speakers, we have around 10 to 12 minutes for each presentation, so we request you to please keep within the time. Thank you very much. Sheena, please.
Okay, I'm just waiting, I'm not able to share the screen because there's, okay, now I think I can. Thank you. Good morning, everybody, and thanks, Nishant, for the introduction. Uh, I just want to check everybody can see the screen.
Yeah.
Yes,
Yeah,
we can.
yeah. Okay. So, in terms of before I get on to and talk about Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, or in short, what we call as PMJ, I thought it would be great to first talk a little bit about the context in which we are looking at the scheme. If we look at India and compare it to in terms of global comparisons, India does, it's quite close to the average for its income level on many of the health indicators, where be it maternal mortality, under 5 mortality, etc. But we do know that there are huge state variations that exist. But what is interesting is that though it is at par with other, for our income level, how we compare to other countries, on some of the aspects, it is underperforming. And one of these areas is indeed health financing and financial risk protection, on which, if we compare ourselves to the peers, we don't perform as well. In terms of India, we do look at it's being characterized by low government spending, about 1.1% of the GDP, high out-of-pocket payments, about 60% are out of pocket, heavy reliance on the private sector. A lot of what we see is supply-driven services within the government system, people who use the government system. And there are, in terms of governance issues around, absenteeism, poor quality of services, and significant oops that I talked about in terms of, within the government system. So that's the overall context. Now, to put the government-sponsored health insurance schemes and provide a little bit of a historical perspective on that, uh, uh, in terms of health insurance schemes, I think as Dr. Nishant Jain was pointing out, we did have some of the early states, Karnataka and Andhra Pradesh, being the two states which had started with uh, fully tax finance risk protection schemes as far back as a decade and a half ago. Then we saw the launch of RSBY, which was the Rashtriya Swasthya Bima Yojana, which is the federal scheme. It started off very well, but I think during the latter parts of the scheme, it did languish, with many states dropping out. And it was also because, people were waiting for the new protection scheme to come in at that point that happened. Then between 2008 to 18, we saw a decade where a lot of the other states joined Karnataka and Andhra Pradesh in terms of having their own health schemes. And a lot of these schemes, like Karnataka and Andhra Pradesh, were fully tax financed with no contributions from the beneficiaries. And they covered hospitalization, largely hospitalization services. So a lot of outpatient care is not covered in these any of these schemes. They were targeted to the poor and the vulnerable sections of the society, and looked at both engagement of public and private hospitals as they looked at the delivery of the health protection schemes. Looking at all of this experience and building on this experience, on September 23rd, 2018, there was launch of PMJ, which in a way consolidates all of these health schemes and really looks at the experience coming from RSBY and expands on that. So how does PMJ really work? PMJ works in terms of it is targeted to the bottom 40% of the population, which is identified based on the socioeconomic caste census, which was done in 2011. It covers, in terms of the eligible population, is 500 million people. All but 4 states, Delhi, Orissa, Telangana, and West Bengal are the only states that have not joined the scheme. But all other states have joined the schemes, and a lot of the states, as I mentioned, have converged their existing hospitalization-based schemes with PMJ. With PMJ, you have access to services It does not matter from which state you are eligible. If you are in any other part of the state, this is completely a portable scheme. Though we do look at that by and large, the 2.5 years of experience in PMJ has shown us that largely people do tend to seek treatment within the district, within the place where they are. But in principle, it is a portable scheme. It covers hospitalization for over 1,500 secondary and tertiary care packages. The way this is done is in terms of the treatment. These are treatment packages which cover everything, right from diagnostics to drugs to hospitalization related costs, and also follow-up for 15 days post hospitalization. That treatment is covered as part of the package, and each of these packages is then priced. And for a beneficiary, it really works cashless. When the person is hospitalized, there is pre-authorization of the treatment that is done. And after the pre-authorization of the treatment, the patient is provided with the necessary treatment. And then the hospital really bills the state health agencies which are implementing the scheme. It's overall managed by the National Health Authority at the center, implemented by the state health insurance schemes. There is an annual cover per household of 5 lakh rupees, which is quite a large cover. And very rarely will a family in a year really hit that level for hospitalization. In terms of hospitals, there's a network of over nearly 24,000 hospitals, both public and private. About half of them are private hospitals. If we look at active participation, though a large number of hospitals have enrolled, but in terms of the active participation of the hospitals will be only about half the number that I'm talking about. In terms of financing, the way it works is that the 60% is provided by the center, 40% of the state, like other centrally sponsored schemes, comes from the states. In most of the states, except smaller states have a 90-10, and UTs are almost 100%. They are 100% financed by the center. And the way this works is in terms of the states. Most state health agencies are really looking at this in terms of these are either they have formed a trust which then reimburses, which is a government agency which is autonomous and separate from the Ministry of Health. Either the claims are reimbursed by them, or these state health agencies have contracted either a public or a private insurance company for reimbursement of the claims. There are some states which actually are also using a combination of these models, where they have up to a cover of, say, 1 lakh rupees, they are using a insurance company, and beyond that, which most of the claims don't really go beyond the 1 lakh level, they use an insurance company for that purpose. And what we also see, looking at the capacity, that whether you look at the trust or the insurance model, they largely contract TPA, a third-party administrator, for claims management. This is essentially the same thing in a schematic, in terms of how the fund flows and, the disbursement is made. Now, if we really look at the building blocks of PMJ and what's new, one, it is demand side for financing. The money really follows the patient. It's only when a patient goes, seeks care at a hospital, does the payment to the hospital happen. So it's different than, say, a district hospital, which is providing both PMJ services as well as other services. On the supply side, it's a budget through which anyway the hospital would get the money. But in this case, unless the patient goes, seeks a care, and depending on what care it seeks, the hospital gets paid. There is a split between the provider as well as the purchaser, in terms of, as I mentioned, that, you have an insurance company, and that insurance company then you have pays to the empaneled hospital, and it's not money directly going from the Ministry of health to the hospital. What this also does, especially I think this is very relevant for public sector hospitals that are part of PMJ, it provides the money that comes from the revenues of the government sponsored health insurance schemes. This offers flexible resources, revenues to the government hospital to be able to use on different things. And a vast proportion of these resources, what we are seeing in terms of experience, and especially some of the earlier the states that did have long-standing experience of implementing similar kind of schemes, what they tend to do is use this money to pay incentives to the staff. They also use this money to, in terms of look at upgradation of infrastructure, etc. So it does offer over and above the regular budget which these public sector hospitals may be getting to do other things. And there is that hospital autonomy that is there. I've already talked about the explicit benefit package, which is priced, each of the 1,500 odd procedures are priced and depending on the service, there is an explicit benefit package. The IT system forms the backbone, right from identification of whether you are eligible or not under the scheme, to actually looking at the entire transaction management from pre-authorization to the entire claim management process is managed by a very strong IT system. In terms of targeting, I've already talked about how it is targeted to the bottom 40%, and I've also talked about the private sector engagement. So these are essentially the building blocks of the scheme. Now, very quickly, in terms of coming back to coverage of people, what we do see that though, the scheme is intended and targets at the bottom 40% of the population, in terms of, if you look at the figure on the right-hand side and look at the line graph, the blue one, what you do see, and this is based on the NSS 75th round of data, which is just, prior to PMJ. So it really reflects the 20 odd state schemes. What one does see in terms of targeting, it's not that only the lower socioeconomic status is being targeted, but you also see that you do have eligibility, or, people are enrolled under the scheme, both, from higher socioeconomic categories as well. But what one sees is that in terms of the eligibility is more pro-poor than what we actually see in terms of translating in terms of the hospitalization. What this also tells us that, there are, though only about 40% of the population is covered, an important aspect is that, in terms of there is the missing middle, which actually is very vulnerable to catastrophic expenses. And, if you look at average size of bill, say 20,000 rupees for hospitalization, that the, till about 80th percentile, they don't, it is catastrophic, and that group is not covered in the insurance scheme. So there are about 40 to 50% of the population without PMJ or any other formal sector.
Just 1 minute left now.
Okay. So let me cover very quickly. One of the major challenges that one sees is the beneficiary awareness, because of which the utilization is not as much. And it's also, if we look at voluntary insurance, private voluntary insurance, if you look at in terms of universal health coverage, we don't think that that's the way to go, because, in terms of when you change jobs, post-retirement, etc., it becomes very difficult to be covered under these schemes. Just a very quick comparison to, if you look at PMJ in the context of global pro-UHC reforms, one sees that in terms of the demand side programs in India are, with PMJ, either you have, as I mentioned, that you have a missing middle. You have the top, which is covered by schemes like ESIC and formal sector schemes like CGHS, which has a different benefit package compared to PMJ. Whereas there are countries, if you look at Philippines and Vietnam, which actually also have the missing middle, though now in Philippines things are changing and they're also bringing out programs for the missing middle, but they have the same program, whether it's for the bottom 40% or the top 40%. Then there are countries like Mexico and Thailand, which almost have universal coverage, with the top formal sector getting a better, a more robust program than rest of the population. And whereas there are countries like Indonesia and Turkey, which have demand side programs, the same program covers the entire population. And then there is a comparison with countries like Sri Lanka and Malaysia, which actually don't look at demand side financing programs, but instead focus on supply side programs. In terms of PMJ, the overall budget is about 6,400 crores, which is not, even if you look at the state contribution, 10,000 crores for a population that it needs to cover is not a very large budget. But I think part of it is also because of supply side, in terms of demand side issues of beneficiary awareness. Also on the supply side, given that the hospital network, etc., and especially in tier 2, tier 3 cities is limited, there is also the impending discussion of other package prices enough to really attract the private sector, and because of which the empanelment may be more limited in the private sector. And also looking at the government hospitals, or in all states are not really robustly participating in the scheme, and they may be, the budget also then reflects the offtake, and also the demographics. Given that we have a younger population in terms of hospitalization care, maybe not as much. So just to say that in terms of the low spending currently reflects the reality that currently PMJ is a foundation. I think it's a very major health sector reform of the current times, but this is not the full robust architecture at present. And it is, it's not, given the limited state capacity that is there, in terms of this is not something which it's easy to implement, because in terms of, if you look at traditional supply side systems, looking at identification of beneficiaries, the payment processes, etc., these are fairly complex and transaction intensive. And what one sees is that especially states,
Now, please try to.
yeah, I'll just take give me 30 seconds more, Nishant. So I think what one sees is that the implementation capacity is comparatively low in northern states. The offtake of the scheme is really, we're seeing in the southern states and the western states that did have a strong implementation of predecessor schemes as well. And looking at the capacity of the state health agencies, etc., there is limited capacity. And if we compare it to other middle income countries, which have a much larger capacity, we find that here, both in terms of the numbers and the skill sets is limited, and therefore there is heavy reliance on the third-party administrators. So I think the key question for PMJ is, how do you really bring, build strong, sustainable institutions that do, in terms of that do build on that help to expand the scheme. And in the end, I'll just like to say that in the short period of 2.5 years, PMJ has laid a strong foundation to become the central player in India's UHC landscape. There are very key systems that it has built, be it beneficiary identification, payment, fraud control, quality assurance, etc., but I think it still has a long way to go in terms of institutional strengthening, linkages with broader health systems, linkages with primary healthcare, and of course, expanding population coverage to the missing middle. And for all of this, what will be important is sustained political commitment and fiscal resources from government and of India, as well as state governments, for PMJ to really realize its full potential. Thank you very much.
Thank you.
Thank you, Sheena. Professor Kalra, please.
Thank you, Dr. Nishant. We'll have discussion at the end of the session when all the three speakers have given their inputs. So with that, thank you, Dr. Sheena, once again. We now pass on to the next speaker, who is Dr. Anup Karan. Dr. Anup Karan is additional professor, Indian Institute of Public Health, New Delhi. I'll request the introduction slide to be displayed. Dr. Anup holds a DPhil degree in public health, specialization in health economics from the University of Oxford, and he's completed research and advanced training in international health from Harvard School of Public Health as a Takemi Fellow. He has extensively published various research papers on issues such as inequality of payments in healthcare, poverty and catastrophic impacts of out-of-pocket expenditure, economic impact of non-communicable diseases, impact of health insurance on financial risk protection in different peer-reviewed international and national journals. He has worked as member of a subcommittee on out-of-pocket expenditure for estimating the national health accounts by National Health Resource Center, and also he's member of the expert committee on determination of methodology and fixation of national minimum wages for the Ministry of Labor and Employment, Government of India. With that, we request Dr. Anup Karan to make his presentation. Dr. Anup, you have a total of about 11-12 minutes. Thank you very much, Dr. Anup. Over to you, sir. Dr. Anup, you are muted. Yeah. Yeah.
Thank you, Professor Kalra. I'm trying to share my screen, first of all, so that I can start. Is this visible? I cannot see on my screen.
No, not yet, Arun. Not yet.
Dr. Anup, do you want us to maybe share the slides for you?
I'm doing that.
In case you have a difficulty, we can try and do it from our side, as you feel comfortable.
Yeah, certainly I would feel comfortable sharing myself, but if it doesn't work, then probably I would request you to just hold on 1 minute. Half a minute, just let me try once again. Can you see this?
Yes, yes.
Great, fantastic. So, chairs of the session, my co-panelists, friends, colleagues, and all the participants. Good morning, everybody. What I'm going to talk is about something like extended effects of publicly financed health insurance scheme. Extended means extended beyond health. Of course, the channel through will be through the health itself, the improvement in population health itself. But I'm trying to look some implications of the government-funded health insurance scheme beyond health sector. And this is not a directly assessment of PMJY, because I feel that data is not enough to really do any kind of assessment at this point of time, even after 2.5 years of time. But still, we will be drawing certain kind of lessons for PMHY. We will see that. To start with, I'm going to present some very, very basic stuff about the effects of government-funded health insurance scheme in India. My previous speaker also mentioned that India started publicly financed health insurance scheme sometime around middle of 2000s with the launch of schemes like Yashaswini in Karnataka, then Rajiv Arogyasri in Andhra Pradesh, RSPY Pan India program, and many other state government also launched their programs, health insurance scheme, publicly funded health insurance scheme subsequently. Almost all these schemes targeted poor and less advantaged population. And the stated objectives of almost all these schemes were twofold: increase in healthcare utilization by poor and reduction in out-of-pocket expenditure burden on poor. Obviously, most existing studies evaluating these schemes evaluated against these two objectives. And if you review all those studies which evaluated these schemes, you will find that most studies found increase in healthcare utilization by poor gradually, but most study indicated that there has been little impact on out-of-pocket expenditure burden. For instance, I cite here a few studies. Fan et al. 2012, which was a study of impact evaluation of Rajiv Arogyasri scheme in Andhra Pradesh. Then Prinda et al. 2017. It's a systematic review study. By that time, say it covered up to all the studies up to 2016. Studies only in India, and this also indicated that it reviewed almost 40 different studies conducted across the country, and the findings of most of the studies was there was slightly increase in the healthcare utilization by poor, but hardly any dent on the out-of-pocket expenditure burden. Then very recently, some 2-3 years back, Karan et al. Published a full-fledged evaluation of Rashtriya Swasthya Bima Yojana, and almost similar finding was there. I would also like to mention a couple of studies which also evaluated impacts of health insurance on health outcome. And one particular study I know is Sood et al. 2014, which evaluated Vajpayee Arogyasri scheme in Karnataka, and they found that it had some reduction in out-of-pocket payment, and also there was some reduction in mortality rate. Mortality rate, of course, in a very, very, very contextual way, that is mortality because of CVD. So there was some reduction who utilized the Vajpayee Arogyasri scheme. So these are the studies. Mostly, we can say that there has most studies didn't find much impact on out-of-pocket expenditure, although there are indications that earlier health insurance scheme, publicly funded health insurance scheme, helped increasing healthcare utilization by poor. However, what I want to emphasize in this talk is PHFI has implications beyond health and financial risk protection as well. Empirical studies globally reflects that such kind of schemes have implications for non-medical consumption expenditure by household, say general consumption levels of living by the households. So a kind of welfare of the household, non-medical consumption expenditure. Then school enrollment of children. There is an old study by Ip and Barwan, 2001, which evaluated effect of school health insurance scheme program, and they found that in Egypt, and they found that it actually helped increasing school enrollment. Similarly, there are a whole host of literature on the labor supply effect of the health insurance scheme. Most of these studies are related to developed countries, but we also have a few studies at least which are there for developing country. For instance, developing or middle income country, I would say. Like Atenedo et al. 2011 is a study in Mexico. Then Wagstaff and Manchot Pong 2012, which is a study in Thailand, and they found that the labor supply increased after the introduction of the publicly financed health insurance scheme in Thailand. And Liu and Zhang in China. All these studies indicated about the direct effect of health insurance in labor market in various forms. Then there are also studies which talks about the retirement decision of elderly, particularly retirement decision of elderly or aged population after having access to health insurance scheme. And there are a few studies also on the which shows the effect on wages, daily wages, particularly wages in the informal sector, particularly. It has some studies show the implications. However, we have very little or absolutely no evidence on these dimensions of health insurance scheme in India, particularly, or also for most of the developing countries. I would just briefly present what the theory tells us about labor market implications of health insurance. So I will put it like this, that health insurance improves, first of all, healthcare utilization, and also improves health. If this is true, this would increase labor supply and labor productivity, obviously because of improvement in population health. And this, in that course, it will also release some of the caregivers, primarily women, who are involved in home care making or homemaking. They could release their labor and participate in the labor market because of the improvement in the population health, improvement of family member, health of the family members. Second important point which theory tells us is that publicly funded health insurance scheme is also a form of income transfer. You can call it virtual income transfer. So that much money is available, so you need not to save. So that kind of income transfer to poor population. If this is true, and if work is considered inferior to leisure, at least at the margin, the income effect will certainly lower labor supply. And this will obviously increase the retirement rates. There are some talk about the job movement also. Since publicly funded health insurance scheme is available to population, so one need not to stick to a particular job, or might move to self-employment for convenience. A recent study actually also theorized about the risk aversion. And they told that, Shetty and Loney, 2006, I would particularly like to quote, that poor individuals pursue actually extra work, even if publicly health insurance is available to them, mainly for the survival as a survival strategy at the time of illness, particularly. So these are the main points I draw from theory, which I would like to look into, and whether this works, how this works in India. So there is some emerging evidence in India. We are conducting a study on impacts of Rashtriya Swasthya Bima Yojana, not exactly PMJAY, because as I mentioned that hardly enough data is available for conducting such kind of a study. But impacts of RSBY, Rashtriya Swasthya Bima Yojana, on rural labor market outcomes in India. This study is still in progress, although we have put out the early draft, which is available on the SSRN website, but still that is under review. And probably by middle of this year or end of this year, that might come in a published form. So still under review, but most of the results are almost finalized from our side, and we are now ready to share that. So what we do? We evaluated the effects of one of the largest PFHI, RSBY, on rural labor market and elderly labor supply. On the main outcome, labor supply, we will define as labor force participation rate, that is proportion of population reporting as part of the labor force. Then we also identified the effects of RSBY or LFPR on employment, then non-labor activity by gender and age desegregation. we used, I'm going to skip all these slides, but these are technical details. We used a whole range of data, NSSO 3 rounds of data. You know that NSSO 1 round data contains more than 100,000 households or 450,000 persons. So there are 4 rounds of different, 3 rounds of different NSSO surveys. Then RSPY administrative data we used, and then district level household survey data we used. As outcome measures, we considered labor force participation rate as the main outcome on annual recall basis. Then we also considered employment types, non-labor activities by disaggregated level, and we estimated effects in early treatment districts and late treatment, early exposure and late exposure, because you know the RSPY was rolled out in a staggered manner. So some district participated early, some district participated late. So we were able to distinguish the effect across the 2 types of exposure. This is the identification strategy. Very briefly, because we could not identify exactly which household participated in the scheme and which not. So I will call it as estimated intention to treat rather than the average treatment effect. We used difference and difference method, and also used alternatively triple difference method. Triple difference method means against rich, poor against rich. We controlled a whole range of confounders, like a district level, individual level, household level, policy interventions, whole range of confounders. We tried to control for in order to have unbiased estimate. This is the timeline which you might appreciate, which will help you understanding what we did actually. So first row is the availability of the data. Second row is the early exposure district. Third row is the late exposure district. We evaluated, the RSPY launched in 2008-9, and we evaluated the impact at the point of time of 2001-2, 2011-12, and we also distinguished between treatment 1 and treatment 2 separately.
Anup, the time is getting over now. Please try to finish.
Just very short. So this is some basic fact about the labor force participation rate. All adult male also approximately had 90% and higher participation rate. However, rural female had labor force participation rate of around 50 to 60%, and that declined over the years. This is the effect of the scheme. So dotted line is the treatment districts, and the deep line is the control district. And you can see that in the rural female case, the labor force participation rate declined slowly compared to the control. And this is the effect of the RSPY. You can see that at the end, around 2011-12, the net difference is around 5 to 6 to 7%. Why this is happening? Is this because of RSPY? And this is the detailed result. Household consumption expenditure increased by 4 to 5%. Increase in rural adult women labor force participation rate by 7 to 8%. Positive effects are stronger. 10% in early intervention district compared to late intervention. Most part of this increase in the short-term employment, most increase in the 30-59 age years, and no significant effect on male LFPR. The findings continue. Informal sector actually increased, but not at the cost of the formal sector. Formal sector remained constant, so it's a completely added worker effect, not a shifting exactly. And RSPY also reduced actually LFPR in the range of 10 to 15% for elderly population. So elderly are getting early retirement. Of course, retirement cannot be exactly measured in India in terms of age, but still they are taking off the job. Effect on non-labor, where this incremental effect coming from? It's actually women are substituting household activities with the labor market activities, and that too in the self-employment category mostly. No significant change in the participation in education by younger, that remains. So what is the implication for PMHY? We all know. Just this is the last slide. So, so what is the implication for PMHY? Of course, RSPY is a very I would say a conservative scheme. only providing 30,000 INR to population. PMHI is a much wider coverage, liberal benefit package, enrollment is automatic, hence can have a larger effect on the labor markets. Improving women LFPR particularly. Securing elderly health will encourage them to retire early and creating opportunity for the youth and adult. This is the message from the IAPSM, which I would like to highlight that my earlier speaker also mentioned about the outpatient care and missing middle. So I would just hope that in maybe PMHY may be extended to larger population also. And one last point, but not the least, is for IAPSM is request to NHA for release of household individual level data PMJY. Thank you very much.
Thank you very much, Dr. Anup, for covering various aspects of the implications of PMJ on non-health issues as well. We'll have discussion and question answer at the end of all the presentations. And now I'll request Dr. Nishant to take over the third presentation.
Thank you.
Dr. Nishant, please.
Thank you, Mr. Kalra. So without wasting time, let me invite the next panelist, Dr. Devdasan. So Deva is a good friend, and also he's an eminent person working in this field since past many years. And he has not been only working at the policy level, but also at the ground level and at the academic level. So at different levels, he has been able to work. And even though the slide has not come to introduce Devdasan yet, but I can still say that right now he has shifted to Delhi from Bangalore, where he had set up Institute of Public Health, and he's running it since many years. Right now he's based in Delhi working with HSTP, and I'm very sure that with his inputs and insights today, panelists and all the members who are attending this will be very much benefited from his knowledge and experience. So without wasting any time, let me invite Dr. Devdasan for his presentation. Thank you.
Yeah. So apparently you all are going to share the pre-recorded lecture, right? So Maninder, can you all?
Yes, sir. Yes, sir. We are just rolling there.
Yeah, right. Yeah. While we wait, yeah, I just give, yeah, okay. Good morning. First of all, I would like to thank IAPSM for inviting me for this conference and presenting my thoughts on the PMJY and primary health care. In India, we have a pluralistic health services which covers a wide range of care, starting from treatment of diarrhea all the way up to complicated cancer therapy. However, when we look at the universal health coverage, service coverage score as estimated by the WHO, one sees that most of our neighboring countries, in fact, most of the countries in the world are doing much better than us in providing healthcare services to its citizens. We are practically comparable to many of the sub-Saharan African countries. Why is this so? One of the main reasons for this is the fact that we have to most of our patients have to pay out-of-pocket expenses at the point of care. To overcome this, the government of India and the state governments have introduced the PMJY. But if you note that PMJY only covers the hospitalization expenses, while 2/3 of the out-of-pocket expenses are for ambulatory care and for primary health care. So one major chunk of out-of-pocket expenses is not being covered by our existing schemes. So this is why it is important to introduce primary health care into the PMJY so that we can expand the service coverage and thereby also reduce the out-of-pocket expenses and provide financial protection. By reducing financial barriers for outpatient care, we increase the service uptake. Because there's continuity between primary, secondary, and tertiary, there's an improved quality of care. And for the PMJY, the chances of reducing moral hazard and fraud and thereby increasing efficiency is much higher when these primary healthcare is integrated with its current package. So what are the options available for us? One is to strengthen the existing government primary healthcare services for targeting and especially targeting PMJY beneficiaries. So we all know that about 40% of the population are potential PMJY beneficiaries. So the government identifies them and make sure that these beneficiaries, these who are the most vulnerable population, people in that population, are provided the required preventive care services, the curative care services, the promotive messages, etc., so that their health is assured. The NHA, the National Health Authority, and the state health agencies can pay a certain amount of money to the state governments depending upon the population of PMJY that is being covered. So this becomes an additional fund for the primary health centers to strengthen their healthcare services. That is one option. But the problem with this is that strengthening government primary healthcare services has been tried out at various times and has not been very successful. The other option is to purchase ambulatory care from existing private practitioners. In most of our countries, there are even in tier 2, tier 3 cities, there are enough independent private practitioners, and the government purchases, empanels them and pays them, reimburses them for care provided to the PMJY beneficiaries. This could be in the form of a fee for service. So for every single consultation, the doctor is paid a certain rate, or it could be on a capitation basis, saying that if 1,000 people are registered with you, you get a flat amount of so much, and you have to provide preventive and promotive and curative care for this population. This is actually the model in most of the high-income and middle-income countries, where the government does not employ so many GPs and family medicine doctors. Rather, they purchase these services from individual private doctors. Now, the problem with this is that the government has to negotiate with hundreds and thousands of such doctors. So there's a via media which is coming up, which is you're purchasing from a group practice. So you approach a empaneled hospital. Already PMJY has a list of hospitals. So talk to them and say, if you provide primary healthcare in this population, and put the condition saying that there should be a clinic open in this population from so-and-so time to so-and-so time. I should provide these services free of cost for the PMJY beneficiaries at this quality, etc. Then we will give you an additional amount of so much as a capitation payment. So this reduces the administrative load for the government and also improves the access, because the hospitals are then forced to provide these services. The danger of this is that the hospitals can still tweak the diagnosis to suit their needs, and thereby there needs to be a strict control and monitoring in such a situation. So I have talked to three options. There are some others also, but some of the simplest ones is what I've taken. However, there are some caveats. One important, of course, is that the government needs to put in more money. And here we are hoping that the NHA, which has the funds, will be able to put in more money, either for supporting the government primary health centers or purchasing primary health care from the private sector. But more important than the money is it needs strong management and monitoring. Without that, the chances of it abuse is quite high. And of course, an IT support. It is very important that the community is involved in this entire endeavor, because unless they know where to go for treatment, which doctors to see, what is their entitlement, and what to do if there is any grievance, etc., this whole thing will fall flat on its face. So involvement of the community is paramount to the success of such a I am very cautious, and I would always recommend that we do this in a phased manner. If you remember, I started with primary healthcare and then I was ending with ambulatory care. So I would say that we start maybe with ambulatory care and in a phased manner add on the preventive services and promotive services once one level is finalized. So I think I would like to conclude by saying that expanding the PMJ services to include primary healthcare services is very important, because it improves access to primary healthcare services, which is one of the main leading causes of out-of-pocket expenses in our country. Two, it provides better quality of care because there is a continuity and integrated care. And this is probably the best way, fastest way towards India moving towards universal health coverage. Thank you for your attention.
Thanks a lot, Deva, and very clear and precise presentation on different options which are available. Now, since we have already taken a lot of time, so we don't have time for the question answer with the panelists, but taking the prerogative of the chair, what I will try to do that some of the questions which are there, I will just try to answer a couple of them in 1 or 2 minutes itself, and Professor Kalra can add, and then we can quickly close. Is this fine, Shankar, from your side? Thank you. So just 2-3 questions which are interesting. One is that any linkage between Health and Wellness Center and PMJ. So right now it's none. Right now they're both working in parallel, but now government has come out with a plan to actually link both of them. And that will be, an order was issued by Ministry of Health, but of course, any order is not as good as the implementation. So I hope that very soon the implementation will start to link these Health and Wellness Center with the PMJ. And for this purpose, in every district, Iapsmcon Bharat Counseling Center will be set up basically, which will be then helping up in linking these two. So that should happen soon. And also PMJ has impact on the public sector because it can strengthen the public sector for the simple reason, as mentioned by the presenters, that public sector earns extra money, what Sheena was presenting, for example, and they can use this flexible fund to actually improve their performance. And that is something which is very useful, though not everybody is doing it right now. That is the big challenge. And the third is that COVID pandemic. So yes, there was a huge impact on PMJ because of COVID, as with everything else. And the numbers came down to almost 50-60% of the pre-COVID numbers. But now it has started gaining again. And we have reached almost pre-COVID numbers now in terms of the number of hospitalizations per week or per month. So that has come, but again, we'll also have to see the patterns and all. So a couple of working papers have been launched by NHA, which are available on the PMJ website, which shows the impact of COVID, what kind of specialization and the packages decrease much more than others. So that all is available, and that can be seen. You can see from the website of the PMJ. And also, a couple of questions had come that what could be the best way for India to achieve UHC? I don't think anybody sitting in this panel will have one definite answer. And it's very difficult. Every country has to find its own path. And also, it's not only depends on technically what is best. It also depends on how much money you have, how much other infrastructure and facilities you have, what is the health-seeking behavior you have. A lot of things comes into picture. And that is why it's difficult to say that, insure everybody and then everything will be right. That is the most simple way to say. So I will stop here, and I will invite Professor Kalra now to share his thoughts. Thank you.
Thank you, Nishant, and thanks to all the speakers for wonderful presentations. Though we started late, I mean, we were late by about 20 minutes. Maybe if Dr. Shankar can give us some time, then we can have some questions from the audience also. But just to summarize a few points which have emerged from the discussion. Of course, the present scheme, that is PM Jan Arogya Yojana, it is a far improved scheme over the previously existing Rashtriya Bima Suraksha Yojana because it has coverage of a large population, that is nearly 40% of the population of the country, and also the coverage is enhanced from the previously 30,000 rupees, it is now to 500,000 rupees. But still, as Dr. Sheena mentioned, that more than 50% of the population is still uncovered. We need to really think as to what can be done for them. It is not that these people can easily afford a huge amount of expenditure which may have to incur at times on healthcare. Sometimes the expenditure required to be incurred is catastrophic and may push even this bracket of people below the poverty line. So they also need some kind of health insurance coverage. The second part is that, as also stated earlier, that major part of the out-of-pocket expenditure is for incurring treatment on the outpatient basis, whereas Pradhan Mantri Jan Arogya Yojana mainly covers the hospitalization costs. So the outpatient needs to be covered. Many of the states have a scheme whereby the Mukhyamantri Muft Ilaj Yojana covers, in addition to the indoor treatment, also covers the outpatient treatment. So that way, a large part of the outpatient expenditure is covered by the government scheme. And this definitely helps in reducing the out-of-pocket expenditure. But as we know, that Mukhyamantri Muft Ilaj Yojana mainly covers the government institution, and almost 60-70% of the people, they rely for their own treatment from the private healthcare providers. So therefore, that out-of-pocket expenditure still continues to be there. And of course, there is a need to strengthen the primary healthcare services under the scheme. These are the three most important points which need to be strengthened. Of course, the awareness about the Pradhan Mantri Jan Arogya scheme needs to be brought up to the masses. And since it has already been about 10 years, the scheme was based on the survey which was done in 2011. Maybe that there are some people who also require to be covered. So there is a need to look at that also, that the newer beneficiaries who are there and who have not been covered by the scheme earlier. Yes. Over to Dr. Shankar Prinja, if we can have a few questions, otherwise maybe we can close.
Thank you very much to all the chairs and the panelists. I think that we've had a wonderful discussion and Dr. Nishant has actually tried to summarize a number of questions that came in during the chat box as well. We're running really short of time, and I know that the chair and some of the panelists in the next session who are already there with us would need to leave in some time. So in the interest of time, I'll take this opportunity to thank all the chairs, Nishant and Professor Kalra, and all the panelists who have joined us and shared their wonderful experiences and knowledge with us. So thank you very much. And now I'll move over to the next session. And I'll try and make an introduction to Professor Ramesh Bhatt. In fact, the entire session is full of luminaries from the field of health economics. But I'll take this opportunity to first introduce Professor Ramesh Bhatt, who is currently the Vice Chancellor of the SVKM's Narsi Monji Institute of Management Studies in Mumbai. He had earlier been a professor of finance at the IIM Ahmedabad, where a lot of his papers, a lot of his working papers and publications is something that we actually came across while we were studying health economics. So I think I've grown up learning from a lot of readings that came authored by you. He served as an advisor to the Ministry of Human Resource Development and a member of various committees of the Ministry of Health. So without further ado, over to you, Professor Ramesh Bhatt. Thank you very much.
Well, thank you very much. Am I audible?
Yes, sir. Yes, sir.
Yeah, okay. Well, thank you very much for this introduction. And I really thank you for inviting me to this conference. And I also thank IPSM for putting this together. We are having a very important session of the conference, which is focusing on the strategic purchasing for healthcare elements and challenges. Of course, this field of work is in a very nascent stages in India and also to some extent globally. We do not know many things about the strategic purchasing, but the importance of the concept and the importance of the strategy is something very critical for the implementation of the UHC and towards achieving the UHC goals. I think for a long period of time, we have been talking about the separation or creating a separation between financing, pooling and purchasing. And I think the strategic purchasing as different from the procurement processes and the ordinary purchasing of some goods and services is really important, particularly in the context of healthcare financing framework. And it is also important that we have started using the term strategic before the purchasing, and that is what it signifies some critical role. As always, the strategies are very complex process. So therefore, the strategic purchasing is also a very complex process. In India particularly, and in many other countries where the private sector provision as well as the utilization is the most dominant in the communities and in the population, and which also has over the period resulted in the multiplicity of agencies. Now, the moment we get the multiplicity of agencies, I think it, as one of the unintended consequences of this multiplicity of agencies is the too much of fragmentation happening, and which may have its own unintended consequences in terms of the impact on the efficiency, impact on the equity, impact on the quality. Now, therefore, it is very important that amidst of the situation where so many agencies operate, particularly in health sector, and the kind of fragmentation which it creates, how do we address some of these issues? I think that is broadly the intention of the strategic purchasing. And this morning we have very eminent personalities here, some old friends. I think thanks to this conference, we are also touching base with some old friends who are going to participate and going to make their presentations. And also we have two distinguished economists as the discussants of the sessions. So I welcome all of you, and I welcome the speakers Alexo Espirito from the BMG Foundation, Professor V. Venkatraman from FMS Delhi University, and our discussants, Professor Selvaraj and Professor Muralidharan, old friends to the conference. Mr. Alexo Espirito is presently Senior Program Officer of the Health Systems Design at BMG Foundation India office. He is an economics graduate and PhD alumnus, health services research of the Johns Hopkins School of Public Health, Baltimore. And he has served as health systems consultant on health financing and delivery with the World Bank and the American Development Bank. He has also worked with the WHO, PAHO, in addition to India. Alexo has previously worked in Latin America and the Middle East countries. So I welcome him to make his presentation, and then we go forward in the deliberations of this session. Welcome, Alex.
Thank you so much, Dr. Ramesh. Let me share my video and my screen. I think you need to stop. Yeah, there you go. Okay. Let me share my screen. Can you see my screen well?
Yes, yes, yes.
Okay, great. Thank you. So thanks everyone for being here. And of course, thank you to the organizing committee of the Indian Association of Prevention for inviting me to speak about strategic purchasing. I'll give an introduction to strategic purchasing. So what it is, how it's done, and I'm going to discuss a few international examples in the 10 minutes that we have. I'd also like to give credit to Results for Development. They're one of our partners, and I stole a bunch of these slides from them. So kudos to them as well. Okay, so before we go into strategic purchasing, I wanted to discuss very briefly the three main health financing functions. There's a consensus in our field that in health financing, there's three key functions. These are first revenue raising, which means getting money for health. And it is done in two main channels. One of them is taxes, whatever types of taxes, payroll taxes, general taxes, et cetera, or in a few countries, there's very few of them, private insurance plays a big role, right? The second health financing function is pooling, which means putting all of that money, preferably in one place instead of many places, in order to pay for services. So the idea here is that single purchaser systems generally work better than multi-purchaser systems, where you have many insurers insuring different types of population. For example, some countries can have 50. There's, I was in a call yesterday with Uruguay. It's a country with 3 million people, and they have 45 different social insurance sickness funds, right? That's not good. That's inequitable. That doesn't leverage economies of scale and so on. So pooling usually refers to concentrating funds, ideally in as few places possible in order to buy services. And then the last function is purchasing. Now, purchasing here refers to something very specific. It's not buying drugs, it's not buying equipment, it's not your typical purchasing function in the Ministry of Health. It actually refers to paying facilities, mainly paying providers for the services that they provide. Anyways, these three functions together, they increase the efficiency in the equity of services, which leads to better health. And that's the right side of this slide. Okay, so health purchasing, just to reiterate, is kind of a misnomer. Most people, when they think about purchasing in our field, they think about the purchasing departments of ministries of health. That's not what we're discussing here. We're discussing about the using of payment mechanisms in order to pay providers, to pay doctors, to pay hospitals, and so on, for the services that they provide. Now, health purchasing can be passive or strategic. Passive is probably the majority of the world, actually, in which facilities get stable funds regardless of, they provide good or bad services, of whether they provide many services or just a few. This is your typical situation in many ministries of health in developing countries, where facilities just get yearly budgets adjusted for inflation. Strategic purchasing, however, refers to working with various payment systems in order to deliberately create incentives in order to steer purchasers towards desired interventions. For example, those interventions that are thought to be more cost-effective. For example, some strategic purchasers overpay for primary care because they want to prioritize primary care. They don't want their system to be hospital-centric, just to give you a very simple example. So in this sense, strategic purchasers, they're price and quality makers, and they actually try to pay not only for quantity of services, but also for quality. Okay, so just to make very clear, the difference between passive and strategic purchasing is that whereas passive purchasing is passive, facilities just get yearly funds, regardless of their production and so on. Strategic purchasing is very, very deliberate in order to use payment methods to steer purchasers towards very specific interventions. And that needs, of course, extensive use of reliable information, which is not available everywhere, as well as some skills that we're going to discuss now. Okay, so who does strategic purchasing? In the majority of countries, as you can probably imagine, strategic purchasing is done by insurers, your typical social insurance or national insurance funds. That's the case, for example, in Vietnam, Thailand, Indonesia, much of Eastern Europe, and so on. Now, there's a few exceptions where strategic purchasing is actually done inside the Ministry of Health, where one side of the ministry is the payer, and then the other side of the ministry is the providers. That would be, an example of that would be the NHS in the UK, or in Spain in some regions. For example, in Catalonia, that's the way that the system works. There is a purchaser inside the MOH that will buy services from the facilities that are also owned by the MOH. Okay, so some well-known strategic purchasing schemes around the world. Here's just a few. Thailand, Colombia, Turkey, Indonesia, and the Philippines. I'm focusing on low middle income countries. These countries all have national insurance schemes that cover between 50 to basically 100% of the population. One common feature to all of them is that they all cover both PHC and hospital services. They don't cover just hospital services. They cover PHC as well, and that's important to note. Now, all these schemes are insurance schemes. Now, their extent to which they really do strategic purchasing really varies. Right? So, for example, Thailand and Turkey have very mature strategic purchasing schemes. They're doing all the strategic purchasing functions quite well, particularly Thailand, and we're going to discuss those functions now. Other insurance schemes, for example, the Philippines, PhilHealth, has been around for 20 years, but they're still really struggling with doing real strategic purchasing. And that's not only because of technical reasons, it's also because of political reasons. And we're going to discuss that as well. Now, one key point is that, building insurance schemes and building strategic purchasing is a long-term endeavor. It takes easily 10 years. I mean, it usually takes decades to build all the skills necessary. And we're going to discuss those skills now. Okay, so strategic purchasing, there's 5 main functions that countries need to do well in order to really do strategic purchasing. The first one is financial management, right? So ensuring that the money is available and that it's well spent, right? So that entails projecting and managing revenue and expenditures. The second one is defining the benefits, right? That's often concentrated in a benefits package. In India, the PMJ benefits package covers 1,500 interventions, but it's not only just the benefits package. It also includes cost-sharing policies such as co-payment and so on, as well as setting delivery standards. The third strategic purchasing function is contracting, right? So selecting providers. Do you want to contract just public providers? Do you want to contract just private providers? Do you want to contract only tertiary services, also secondary services, also primary services, and so on? So that needs to be decided. Contracts need to be developed. And then the contracts need to be enforced, which do need dedicated personnel. The fourth one is provider payment. So that is deciding how much to pay providers and in which way. Now, there's a variety of payment methods, such as global budgets, diagnosis-related groups, package rates, which is the method used in India, bundle payments, and so on. The key here is that there's a lot of options available, and the strategic purchaser needs to work with various payment methods, or they typically work with not just one, but various payment methods in order to steer providers to the desired interventions. And then the last is monitoring evaluation. So monitoring provider performance, ensuring that people are actually getting the services that they're supposed to be getting, monitoring the quality and so on. Now, these 5 main functions are supported by 3 additional functions, which are communication, right? Ensuring that people know what insurance is and how to use it. This is often not easy because insurance products are very abstract and very confusing. The second function is information systems. So this is quite important. And it's often condensed in the health insurance information systems, which are often developed by countries themselves. And then the last function is policy development. Okay, so what skills are needed for strategic purchasing? I'm grouping the skills here based on 5 main functions that we discussed. So on the financial management front, the skills needed include budgeting, treasury, financial control, forecasting. So you need, finance people, but also actuaries who are not always available. For benefits package definition, you need a set of skills typically that we call under the rubric of health technology assessment. That includes both economists and clinicians. On the economical side, you need people that can do economic evaluations, so costing, cost effectiveness, cost benefit analysis, and so on, that can do systematic reviews and meta-analysis to assess the effectiveness of interventions, and so on. Now, on the third function, which is contracting, you need people that, you need lawyers, right? You need people that know about contracting regulations, that can draft contracts and so on. And you also need people to monitor the enforcement of the contract. So for example, in Spain, there's the purchasers come into contracts with hospitals. Those contracts include what you can call package rates, but then they include also some wider objectives at the hospital level, not at the individual provider level. So that needs to be managed adequately. So you need people that can track KPIs, manage the relationship with providers, and so on. For provider payment, you need the skills of HTA, but you also need experience. You need people who have experience with payment mechanisms and the planning of health services. You also need monitoring evaluations officers. And then obviously you need communication specialists, information system specialists, IT people. And then strategic advisors in some areas that are key. These are often benefits package revision, pharmaceutical policy, and so on. Now, a key point to note here is that these are not your typical skills in your typical Ministry of Health, and it takes years to develop these skills, which is why it takes a while. That's one of the reasons as to why it takes countries so long to develop, to really do strategic purchasing rather than just doing insurance and payment. Okay, so here you have 3 examples. This is a pretty confusing slide, but I just wanted to give you 3 quick examples of strategic purchasers around the world. And one important point in this slide is that there's a couple of points. The first one is that all these countries are using strategic purchasing to lower avoidable hospitalizations and also to increase primary care spending, right? And that's the case in Estonia, Thailand, and the United Kingdom. Now, the second point in this slide is that the main functions that we just discussed, in some countries are concentrated in just one agency. In some other countries, they can be spread across several agencies. So in Estonia and Thailand, benefits package definition, contracting, provider payment, and monitoring are all done by the National Insurance Fund, right? Whereas in the United Kingdom, it's kind of a mess, right? So you have the benefits that are being defined by local health boards, the contracts that are developed by the National Health Services, and so on. So that can induce, quite a bit of confusion. It needs, huge coordination between agencies. Okay, so what do countries really need to do? What are the preconditions for strategic purchasing? The first one is strong governance. One area that can create a lot of confusion and difficulty is the role of actors. I've been in some countries in Asia where you have a national insurance fund that is neither able to define the premiums that they get, nor are they able to decide how to pay and how much to pay providers. So it's almost in an impossible situation because you cannot control any of the financial variables that drive its sustainability. So those needs, and that's a political game. I mean, that needs to be agreed between agencies. And also at the provider level, it's important that providers have enough autonomy to arrange their services as to be able to raise insurance claims, and that they're able to use the funds that they get from the claims, which is not always the case, and it often leads to the collapse of insurance systems. Now, in order to go into strategic purchasing, strong political support is needed. A transition into strategic purchasing into an insurance model will create winners and losers, and therefore it needs strong political will. And then the third precondition is technical capacity, right? So you need the skills that we just discussed, and you need a culture of data use and decisions based on data, which is not available. Now, those things can be built over time. Okay, so conclusion. This is my last slide. The first one is that strategic purchasing refers not to your purchasing department at your MRH, but rather on paying providers in order to steer them to cost-effective or equitable interventions. And that strategic purchasing schemes, the successful ones, have been able to increase PHC spending and reduce avoidable hospitalizations. Strategic purchasing relies on 5 main functions, which are benefits package definition, contracting, provider payment, monitoring, evaluation, and financial management. And these are in turn supported by 3 additional functions, which are also important, right? Communications, IT, and policy development. The setting up of strategic purchasing schemes is a gradual process. You know, you learn and you improve as you go. It's not a big bang reform. You can start at a big bang reform, but then it will be a gradual process. In some countries that launch insurance-based reforms, such as Colombia, started as a big bang, and then this reform just became a continuous process for the last 30 years. Fourth, setting up strategic purchasing scheme is a political process as well. It will create winners and losers. It will change the way that providers are paid. And in many cases, there is provider pushback on that. And we need to be sensitive to that. And then the last one is that strategic purchasing is continuously moving target. It's not that countries set up an insurance and then they're done. No, actually, policies change all the time, and therefore and providers try to game the schemes. So countries are improving their strategic purchasing schemes all the time, particularly their payment methods and the monitoring and evaluation arrangements. Now, my last point that I wanted to mention is that in strategic purchasing, there's a lot of hype and so on, but it's still not a reality in the majority of developing countries. There's few developing countries that can do strategic purchasing well because, you know, it's a tough political journey and because you need very specialized skills that are not typically available within the Ministry of Health. Now, it shouldn't be thought just as a goal. It should be also thought as a journey. As countries gradually transition into better and better strategic purchasers, they're transparentizing their services, they're getting better cost data, and so on, that will help them manage their own services better. So, thank you. I'm done.
Well, thank you very much, Dr. Alex. So it's a great presentation. Laying down the basic elements of the purchasing, strategic purchasing system, and helping us to understand the role of the competencies required to manage the system, and also some of the imperatives of making it success. Thanks for putting up the 3 cases and some broad learnings from those 3 cases for all of us to understand. Well, we go to the next presentation, and I welcome good old friend, Professor Venkat Raman, who has been working in the health sector for a long period of time and has been having great work in this area, and has been served as a member of the global advisory group of the private sector governance of the USC WHO, and he has also been the chairperson of the National Technical Working Group on the private sector for TB control, Government of India, and we have served together on that committee for some time. And he has also extensively published on the HRD things and the health sector public-private partnerships. I welcome him to make his presentation, and then I'll be handing over to the discussants to discuss these 2 presentations. Welcome, Venkat.
Thank you. Am I audible?
Yes, you're audible.
Okay, I just to try to share my screen, and then all right, I hope this is visible.
Yes, visible, yeah. Right.
Okay, thank you so much, Professor Ramesh Bhatt. It was wonderful. It is wonderful to see you after several years now. And thanks, Alexa, for giving a wonderful, introduction to the entire concept. I don't know after what you have said, what I am likely to add on to that, which is more primarily focused on India. I hope I do justice to the previous speaker, and also the previous session. I was listening to it very keenly. And I would thank the Indian Association of Preventive and Social Medicine and Professor Shankar Prinja for giving this opportunity. And it's wonderful to, it's a privilege to actually address an august group of scholars and practitioners. Before I go into a kind of introduction to the strategic purchasing and conventional purchasing, or what we call it as passive purchasing, which Alexa had wonderfully described. I am just going to do a little bit of memory jogger for Alexa's description, and just to summarize it to the Indian context. I'm not going to really look at it from the point of view of a generic description, but more so about what is exactly the kind of purchasing strategies that we have adopted in the Indian context. The conventional purchasing model operates under the constraints of budgetary line items, which then limits the breadth and depth of the benefit package. Even then, there are problems of underspend. It is usually topped up with user fee. There is also less intense monitoring of performance or quality or outcomes. So government doesn't take a very active stewardship role here or leadership role. And there isn't much incentive for the private sector to innovate or be cost effective. On the other hand, the strategic purchasing operates under the notion of demand-driven, more flexible resource to be pooled and allocated, with a primary focus on value for money, equity, and accountability. The moment we talk about accountability, we talk about performance tracking and a better contract management system. There is strategic purchasing requires a great deal of robust contract management system built on some kind of information technology platform, which makes it easy to track adherence to various process indicators, performance indicators, or outcomes. And therefore, this makes the case for moving away from passive purchasing to strategic purchasing, because it gets more better value for money for the purchaser as well as the beneficiaries. Why is that the strategic purchasing and the private sector in India it matters so much? I think currently we all know that the private sector is the most predominant provider in Indian context in terms of outpatient as well as hospitalized services. Ad nauseum, we have been talking about that based on NSS data of 2015, and for the last 30 years, there has been a gradual increase in the number of proportion of people going to the private sector. Latest one, which is of 2015, talks about 68% of urban people and 58% in the rural people getting hospitalized in the private sector. This trend is over a 30-year period. It's not just suddenly it has come out. And the payments are all largely out of pocket, and that people have already alluded to. So therefore, I am not going to repeat what has been said already. It's also critical to understand that 63% of India's health infrastructure is accounted for in the private sector. For example, there are 43,486 hospitals with 59,264 ICU beds. Don't mistake me for I am pushing for or I am suggesting anything to do with the tertiary care alone, but the proportion or the size of private hospitals, for example, 43,000 hospitals, 59,000 ICU beds, 29,000 ventilators, and compare it with only 25,000 public hospitals and just about 35,000 ICU beds and 17,000 ventilators in the public system. So you do have a great deal of service capacity within the private sector, which is perhaps untapped till now. The reason why I say this is perhaps only about 1% of the 2,000 specialty tertiary care hospitals are stated to be under PMJY, which indicates that the current format of purchasing is not strategic enough, which means it is not based on market realities, or it doesn't incentivize the private sector to be brought on board. It's also critical to look at what is the demand for NCD care. There is a growing demand for NCD care, and which is evident from PMJY dashboard indicators. The top 5 clinical procedures are cumulatively seen. Coronary care, the PTCA and the stent, etc. Bypass surgery, orthopedic surgeries, knee replacement, and cancer. And bed usage pattern in the private sector also seem to be more than the public sector, hospitalization. So, which is an indication that there are 63. I mean, it's also another indicator that comes to here is that why PMJY is not strategic enough, at least even though if it is focused on the tertiary care, is that apparently 63% of the hospitals empaneled under PMJY has less than 50 bed capacity. So, which is an indication that we haven't really attracted, even if it is tertiary care, specialty hospitals to come on board. That tapping the private sector entirely under strategic purchasing at various levels, not just at the tertiary care level, can actually accelerate the universal coverage and widen the scope of services and perhaps reduce the out-of-pocket expenses, if that is the purpose, primary purpose. Large proportion of, it's another bottleneck here is that a large proportion of service capacity within the private sector hospitals are under the EWS economically weaker section reservation, which is mostly misused or not complied with by the private sector. Strategic purchasing may incentivize to the private sector to open up for more productive use. So I see that from that particular angle. Let's look at some of the issues concerning to the existing purchasing methods within India. Currently, besides NHA, that is for PMJY, there are multiplicity of purchases. Several states which doesn't want to really follow PMJY, CGHS, employee state insurance, public sector undertakings, corporate sector people, and of course households are purchasing on their own. There is also no visible signs of pooling at this juncture, although I guess sometime back Niti Aayog was looking for some kind of a merger of most of these, and there isn't a single purchaser or a payer. So which is a dampener for the simple reason that the benefit packages vary from purchasers to purchasers, which are in some places exclusions and some categories of inclusions. There are tariff variations. There are various varied types of empanelment criteria. Monitoring is there are no standards of monitoring in terms of forms and formats. There are no IT systems which tracks each one of these methods of contracting or payment. When the benefit packages are not aligned with the morbidity or demand based on technology assessment, the current level is that the scope of services and the tariffs are either obsolete or somewhat tend to neglect new procedures, new clinical procedures. And often you see that the beneficiaries complaining about certain exclusions, making them to pay a great deal of out-of-pocket money. The providers are happy because there are multiple empanelment and the tariff variations. But this leads to discrimination of low tariff purchasers or beneficiaries. You could see that from the CGHS. There are many private hospitals which have actually came out of CGHS, and the CGHS beneficiaries continuing to complain about certain exclusions that makes the private hospitals not to be taking care of them well. The next point I wanted to mention is that there are internal contracting that the PMJY allows, but the public sector hospitals under the internal contracting arrangement, there is very limited autonomy to them on fund retention or staff or capital expenses or expansion of services. These decisions are not easily delegated down to the public hospitals. Although you have Rogi Kalyan Samitis, but these are not very powerful enough to really overcome the the treasury or state level authorities. There is also nagging suspicion of a poor or lack of coordination between the Ministry of Health and the National Health Authority. And you hear anecdotal and also certain kind of rumors about people not very cooperative with one another. That's an internal story which I don't want to get into, which is something that they can resolve with themselves, I'm sure. There is also virtual absence of a dedicated contract management system with skilled staff for supervision, monitoring, or regulatory oversight. As a result, compliance to quality assurance and data reporting is highly varied. As I said that earlier, there are lack of standard formats for the reporting. We could see some shades of strategic purchasing during the COVID-19 hospitalization, but remember, most private hospitals were extremely unhappy with the kind of tariff structures that were offered to them. But they complied with it due to the emergency law. Otherwise, they could have been hauled up with the Disaster Management Act or any other kind of emergency law. The TB program recently introduced a performance-based contracting with a robust contract management system. I am saying this because there are some green shoots of strategic purchasing. That's not new, but it's been happening. But we are unable to really learn the lessons and integrate it with the larger, expanded model of our existing purchasing mechanism. Likewise, contracting for dialysis services, like specialty ward that was there in Uttarakhand, some state level health insurance schemes like Tamil Nadu and Karnataka. These have shown some innovative purchasing arrangements. So we perhaps have to really consolidate these findings or maybe lessons and incorporate them. My last point is about the way forward. Now I'm not concluding because this, as Alexa said, that it's a long drawn process. Strategic purchasing is not something that you can immediately succeed to implement. What are the possible areas for us to really think through and think about what can be done? Identify and develop policy priorities. For example, if out-of-pocket expenses is your primary objective, we all know that primary care out-of-pocket, the existing schemes and the expenditure pattern among the NSS data has suggested, a very large proportion of primary care and ambulatory care needs are not covered under any of the existing schemes. So we need to perhaps think about what are our policy priorities. Second, based on that, we need to think about a very deliberate, politically committed directions for strategic purchasing. Without a political commitment for a long-term choice, we are likely to have, we have seen this many times in PPP models, that a murmur of protest, then the politicians go backwards. And that is not possible with the kind of strategic purchasing strategies that you think about. It is equally critical to develop an institutional framework for better coordination between the current National Health Authority and possibly in the future, state level counterparts like State Health Authority as purchasers and payers. So we need to really think about institutional frameworks to begin with, along with the policy commitment. The next point is that we need to think about moving towards demand-based, for example, use. I'm just giving a kind of a thought, morbidity-based. You saw that data from the PMJY, which gives you an indication that NCD care is one of the most sought after kind of service. So it would be very important to look for that explicit benefit package for each level. I'm not suggesting it's only for tertiary care level, but deliberate attempt to look at each level. For example, somebody, I think Deva had alluded to extending NCD screening to the community from the hospitals. That can be a deliberate approach. So these are strategic choices based on epidemiological profile or fixing the fixing a realistic tariff, and conducting an HTA-based, approach to service, defining the scope of services, and make the offer or the purchasing arrangement attractive enough for the private sector to compete, and allow the public sector hospital to also compete in a way that they retain the revenue or retain the resources and are able to really have a competitive mode with the private sector too. Eliminate fragmented pooling of finances. There is a desire or a demand about missing middle. So why not think about a middle class pooling also, and also their employers. The multiplicity of purchasing authorities perhaps are to be thought through as to who would be the right kind of a people for, or maybe one, or maybe statewide one, or maybe if that does not allow competitive kind of a purchasing, maybe other arrangements could be thought through. It's also important to think about competitive selection of providers and use professional contracting systems to manage these transactions. An IT-based contract management system to monitor and manage these contracts, so that it generates analytics, conducts periodic audits, and prevents frauds. This would require a technical and managerial capacity within the NHA as well as SHAs, that is state health authorities, and also requires generating standardized data formats for reporting. We also need to think about moving towards output-based or performance-based financing and blended payment, which Alexa also indicated too. Capitation mode, or a global budget mode, or a case mix model, which is the DRG model, or any other method that we can think about, use a blended payment system and a unified payment mechanism. Payments tend to be the dampener for a very large number of private providers, and in future it can also have a dampener for the public sector competitive spirit. Benchmark the standards, develop the processes and performance indicators, as in the case of Korea or PhilHealth, or even in TB program that we have. And finally, I think it's very important for government to play a stewardship role and taking an active leadership role. With these, I hand it over to Professor Ramesh Bhatt. Thank you so much for this opportunity.
Well, thank you, Professor Venkat. I think very impressive list of the challenges and the way forward. I think each point is a point for carrying out the research in this area, in this field. And I think very insightful presentation. Thank you very much. May I request now the discussants to, I will request Professor Muralidharan to take the floor. And Professor Muralidharan is a good old friend and professor at IIT Technology, IIT Madras, and is a professor in the Department of Humanities and Social Sciences, has been working in the area, in the health sector area for long number of years. He has been the member of the mission steering group of the National Rural Mission Government of India, and has published extensively. So I welcome him. And if Dr. Muralidharan, if you can just take 5 minutes to discuss these two presentations, and then we move forward.
Sure. Thank you very much, Dr. Ramesh. We're meeting after many years.
Long time.
And I want to quickly thank the organizer, the PGI Institute in Chandigarh, and the organizers who are the Secretariat, Shankar and his team. Quite frankly, since last evening, after I received the PPT of these two presentations of Alexo and Venkat, I've been thinking, what is it I can add? As some others have already mentioned, that it's difficult to add anything substantial to what we have heard from the two presentations. But if anything, I want to re-articulate or emphasize one point, commonality between my own experience with PMJ in 3 or 4 states, including Bihar and UP. Recently, we are working on it, and Tamil Nadu, and what they have said, the two presenters, Venkat and Chair himself referred to this process, this complex process, this long drawn process, strategic purchasing, and not many of us really have had enough experience in our country context on what is strategic. But one thing came out very clearly from both the presentations, and I'm glad I was there. The last session got overrun, and I could listen to Anup and Devdas in particular, and it gels with their point as well. It's a long process, and the first initial phase is going to be extremely important in building the trust of the beneficiaries, potential beneficiaries, as well as those who have benefited already as inpatient of beneficiary of the scheme. So lots of grievances. I've had experience in the past 4 or 5 years with my association with the Anup and PHFI team, and Shakti was leading the team in Tamil Nadu, that we had opportunities to sit through some of the grievances meetings, monthly meetings with providers and others. This was after nearly 10 years of experience with CM's insurance scheme, and we felt, and even now after having done some surveys in other states, that this grievance council and awareness creation was mentioned repeatedly by the speakers as well as others. They were also mentioned, particularly what it means involving community. Very low awareness among the potential beneficiaries, and even more importantly, the grievances among those who got admitted. And then we did 3 surveys in the last 1 year. We got the names of the households who benefited from the scheme, and we particularly focused on how much they ended up spending out of pocket under PMJ as after having had treatments. Enormous amounts. Particularly we concentrated on cancer and cardiac patients. So, if anything, I would like to re-emphasize this, and I'll stop with that. What is it that I would like to re-emphasize is that building the confidence and trust of the beneficiaries, community of beneficiaries in particular. We need a set of household-based survey studies, a large number of them too, with a view to enhance the effective implementation of the scheme. Many processes are put in place, one of which is the grievance addressal mechanism, and do a survey on how well it has worked, particularly providers too have lots of grievances. So I wish to know, for example, if anything, pose a question to Professor Venkat, that, what is it that providers would like to see? What is the nature of contract they would like to see that they enter into the NHA? In Tamil Nadu, for example, the contract was such that the rates were fixed for 5 years, no changes made. There is no interim evaluation of the rates. Of course, it requires a lot of information about how to peg with the cost of care that is increasing. Okay, so if you speak to, therefore, the providers, genuinely speaking, their grievances, but that apart, I think among the various surveys that I would initiate would be do a household survey among beneficiaries about their grievances. So that also ties up with the broader points on governance, monitoring, evaluation, so on, and also ties up well with Anup's request towards the end of this last slide, that requesting NHA to release household data on how much they ended up spending. With this, I will close. I have only one point that I have highlighted. Yeah.
No, thank you very much, Dr. Muralidharan. I think you have brought very important point in the discussion that the importance of the trust actually is something very critical, and significantly the trust depends on the transparency in the system. So I think trust and transparency go together, and that I think is very important take from your discussion. And certainly I think the future debate on this issue must reflect on these points. May I welcome Dr. Selvaraj, who is the Director, Health Economics Financing Policy, PHFI, to just express his views. He is also, he was a TechAmi Fellow, so am I. So we are the same alma mater from Harvard School of Public Health. And but he has a privilege of being the Fulbright Scholar also, and has his health economics PhD from Jawaharlal Nehru University. And over the years, I think his contribution in the health financing area has been significant. And I welcome him to start his discussion on these two papers. Maybe if we can take 5 minutes, and then we can have some general questions from the other participants.
All right. So good morning, Chair.
Welcome. Yeah, please.
Yeah, good morning, Chair, my co-panelists, friends and colleagues. At the outset, I would like to thank the organizers for giving me this opportunity to share some of my thoughts and quick reflections on the presentation made by the earlier speakers in the area of strategic purchasing. Now, so as I understand, strategic purchasing essentially involves an ongoing search for the best means to optimize health system performance by deciding which intervention should be purchased and how should be purchased and from which providers. All right. Now, how do we situate this in the Indian context? Until about 2007, the purchaser-provider functions were mostly integrated as far as government services were concerned. Now, the introduction of public health insurance programs certainly led to separation of purchasing functions from the provision of services, and then the associated emergence of purchasing function. Now, let me also, I think it's a good time to remind ourselves that insurance can be both implicit and explicit. So the three characteristics, whether we talk about prepayment risk pooling and cross-subsidization elements, they are also present in the publicly funded and provided integrated system. So the simple point that I'm trying to make is that in terms of insurance, whether explicit or explicit or implicit, its functions are inherent in the integrated tax-funded health system as well. I think for many participants who may not be aware of this, it's important to understand that insurance by itself will not involve strategic purchasing, because if you look at the experience of the RSBO in the last 10 years or so before PMJ, it showed that it was largely passive in nature. Now, let me articulate 2 or 3 quick points on strategic purchasing. One to do with regulation plus quality issues. And then the second issue is around the fragmentation in schemes and its problems. The third is about how do we see this in terms of public funded system. In terms of the regulation and quality, if you look at the experience of the last about 13 years or so, beginning from Arogeshri in Andhra until today, 2021. So let's look at regulation and quality. What did we achieve in terms of regulation and quality? Did quality improve? Did regulation come in? I think one of the critical points that must be pointed out, I think in a country that is really largely, one of the largely private dominated, whether you talk in terms of financing or delivery of healthcare services, purchasing without regulation, in my view, is a recipe for disaster. It essentially boils down to throwing public funds essentially into private gutter. So I argue that strategic purchasing will fail or underperform with a large unregulated private health system. So the question is, did the government funded health insurance bring in some element of quality improvement? Yes, to some extent it did bring in some bit of quality improvement. But having said that, quality improvement in any case has been slow, but although it's been increasing incrementally over the years, that's true of both public and private facilities as well. Essentially, NHM has certainly brought in a lot of quality improvements, although it varies between state to state. So the question, in the absence of more rigorous empanelment criteria, for instance, one of the points that was made earlier, and regular quality monitoring mechanisms, just looking at hospital empanelment criteria only, it simply considers only the structural aspects, such as number of beds available in the facility, availability of emergency theaters, number of medical specialties, and so on and so forth. What it really doesn't look at is the systemic inefficiencies, such as overcharging, longer stays, adverse events, medication errors, resulting in readmissions. So these are major challenges, and that still remains in a big, major way. Now, some states adopt policies, for instance, empaneling only a limited number of hospitals that meet certain criteria. For instance, Maharashtra has done this. And there are states like Tamil Nadu, Bihar, and Madhya Pradesh now, for instance, where they have reserved certain packages. These are all high frequency, low value packages, reserved only for public hospitals, and so on and so forth. Uttarakhand has a different set of policies, where it only allows a referral from a public hospital for every procedure to be carried out in a private hospital. So I think these are all good experiences in terms of improving quality, improving also making sure that there's cost minimization. So that's one area in terms of regulation quality. Let me quickly move on to the second point about the kind of fragmentation that still continues, remains in a big way, which I think is still detrimental to strategic purchasing. Now, fragmentation of purchases, differences in package rates provided, and variation in package rates, in fact, they are expected to result in huge cost variation and outcomes. Now, if you look at simply the price variation simply between PMJ and ESIS and CGHS rates, they are in the range of anywhere between 12 to 123%. So it has huge problem. Therefore, I think it is critical that public purchasers share information among themselves about package rates in order to purchase collectively rather than in a fragmented manner, and if we continue to do it, we would continue to get suboptimal outcomes. So that's my second point. The third point quickly that I wanted to make, which I think is larger, bigger issues, especially if you have a large private sector dominated system, you're bound to have this kind of a problem. So the question is, how do we solve this? Now, this is more to do with the questions around purchasing of medicines. Now, India has a very interesting, successful elements of purchasing, and I still consider that as a purchasing, whether there is a public purchaser like the Tamil Nadu Medical Service Corporation or the Rajasthan Medical Service Corporation, which are basically large corporation procures medicines from suppliers directly. Now, this is a very successful model. Can we bring in this aspect as well into our purchasing, and how do we see even this purchasing? The reason why I'm saying is that there are two key elements involved in this kind of a purchasing. One, there is a monoxony purchase, where you have an advantage of public purchaser as a single purchaser, negotiating with the supplier directly to obtain maximum advantage. That's not possible in a fragmented private delivery system. So that's one point. But the larger point, which is going to be there for a long time to come, not going to be easily resolved, is the question around generic substitution. Now, many countries, most developed countries, even many of the developing countries are moving towards generic substitution to save enormous funds and obtain good outcome, as they are equally safe and efficacious. So, and this is certainly value for money. So the question is, the reason why I'm bringing this up is the fact that whether you take hospitalization episodes or outpatient care visits, for instance, hospitalization episodes, about 45–50% of the hospitalization cost involves medicines, and about 70% of the outpatient care visits involves the cost is basically medicine cost. So unless we do anything, something about this aspect of generics versus branded, we are not going to bring in any element of getting the buzzword called the value for money is not going to be obtained any sooner, because our private facilities are happy with branded medicine for reasons that's all very clearly known. You don't call that as rent seeking, but if you do it in a public system, you call that as rent seeking. But there's actually rent seeking. So unless we do something about it, we are not going to bring in cost minimization any sooner. I think I'll stop there. Thank you.
Well, thank you, Dr. Salviraj. I think great points about a good regulatory framework to make sure that strategic purchasing concept works. And also, I think the two important points on the empanelment quality and what needs to change and what needs to be resolved before we get into the strategic purchasing in India. Well, we had great presentations and great discussion, very great insights, I think, on the topic, which is very complex. As I started, we are dealing with something very complex because of the too many agencies involved in it, and you do not have any kind of a guidebook on this, that the things are done in this manner. I think that is it is a highly unstructured situation. All the countries deal with this situation in a very ambiguous terms and try to find out that what is best for them. Well, after listening to the discussion and after listening to the papers, I think I find that there are 6 elements in this strategic purchasing issue when one looks at that. And I'll just narrate that. I wish we had more time to discuss this important topic, but I'm sure that we're just running short of time. And I'll also try to summarize the questions which have been come. Now, as I mentioned in the beginning, that this strategic purchasing is itself very complex, having the multiplicity of agencies and a lot of fragmentation in the system. So there are 6 elements to this strategy if one wants to take it forward from the implementation point of view. Also that I think that there may be participants who may be also looking at from the research point of view. I think the first element is that defining the arena of this strategic purchasing. That's the question of what actually. Basically, what question should deal with the identifying the intervention and the services which we would like to include it, which of course has to be based on the understanding the needs of the population, our national health priorities, and also cost effectiveness analysis of the various interventions. Once we have some idea about the arena and what we want to do, the second element in this strategy is that service provision and from whom. Because we have multiplicity of the providers, public, private, within private, we have for-profit, not-for-profit. And we have also the important requirements in terms of that what should be the service quality, what should be the efficiency, and what should be the equity challenges in implementing and ensuring that the services reach to the target population which we cover. I think the third element in this strategy is the vehicles which we use. It's a how part of this implementing this strategy, which largely focuses on the design of the system, various elements in the vehicles like the contractual arrangements, provider payment mechanisms, whether we should go for the public integrated model or public contract model or private contract model. I think these are the kind of choices which we have to make if we want to implement this concept effectively. In strategy, whenever we teach, the one very important element in strategy is that whatever you have discussed in terms of what you want to do and from whom you want to purchase and what mechanisms and vehicles you are going to use, you cannot do this overnight, and there has to be a good strategy on what is the scale, scope, and staging of this whole strategy. Because that is how you have to define that in what stages I am going to implement it. And therefore, I think one of the presenters, Dr. Alexo, mentioned that it has taken many countries almost 10 years to implement it. And during the 10 years, what you will do first, like it is a kind of an one act play that you have to do it in a staging kind of a thing, the first act and second act and third. That has to be very clear in terms of the scope, scale, and staging part of it. And also, I think the discussants and the papers have revealed and helped us to understand the fifth element in this strategy is the governance issue. Now, given that there are multiple principal agent relationships present in the system, it is very important to look at from the principal agency framework, basically the kind of challenges we face between the purchasers and providers, between government and purchaser, between population and purchaser, and it will create a whole lot of dysfunctional challenges, which I think if we have not thought through how to structure it, it's going to create a big problem for us. And it also leads to very high agency costs, because the agency cost gets reflected in terms of the monitoring, regulation, accreditation, modulating the mechanisms, and the government playing the stewardship role to make sure that things. And the last element, I think, before I close, is the economic logic of this whole strategic purchasing. I think that's very important. I think these are the 6 elements of the strategic purchasing, which very effectively have been discussed by the paper presenters and the discussants. Well, I thank you very much and hand it over the floor to Dr. Shankar Pinjar.
Thank you very much, Professor Bhatt, and thank you to all the panelists as well and the discussants. I think this has been an excellent session. So following on from the PMJY, we thought that this would be a session that would need to delve deep into the issue of strategic purchasing that becomes absolutely integral when we start to think about purchasing of healthcare services in the context of such a large health insurance scheme. And I think that the speakers, both Dr. Venkat and Dr. Alexo, have done a brilliant job. And then the discussants that we had, both Professor Murli and Dr. Shaktivel. So I think overall it's been an excellent session, and thank you all very much.
Can we leave?
Yes, sir. I think we'll now wait for a couple of minutes before we begin the next session. So thank you very much, sir.
All the best.
You're more than welcome to stay here and join us for the subsequent sessions during the conference as well. We really benefited from your feedback.
Thank you. I will try.
Good morning, everyone. Can everyone hear me?
Yes, very well, Dhruv.
Hi, good morning, Dr. Prinja. How are you? Are we on schedule to begin at 11:30? Because I do know that we have a tea break right now, right?
So we're going to begin at 11:30 sharp, and because we'll have another session at 12:30, so we have 1 hour for us.
Okay, great. It's pretty unsettling to see my picture up here like this, but I can't see. I think we're just waiting for Dr. Chauhan. Am I correct, Kaushik? Kaushik, can you hear me?
Who, me?
Oh, no, Dr. Sen, I was asking Kaushik.
Yeah, I'm here.
Okay. Kaushik, we're only waiting for Dr. Chauhan, right?
I think so. I just follow it up.
Okay. I have 11:30 on my clock. If you wait for a minute, Dr. Prinja.
Do you mind, Dhruv, if we just begin the introduction, so Maninder can begin your, and then you can take over the moderation.
All right, sure.
A very good afternoon. So we will be starting our parallel session on exploring supplementary financing mechanisms to finance healthcare in India. So moderator for this session will be Dhruv Pava. Dhruv is a senior director at Global Health Strategies, and he works to develop market access strategies for health and nutrition related products, services, and policies. And recently, he has been working on analyzing financing mechanisms for implementing key health policies in India. Towards this end, he has liaised with leading finance, tax, health experts, and policymakers to organize a national consultation on the subject. Prior to joining GHS, Dhruv worked at JP Morgan's investment bank in New York, where he analyzed mergers and acquisitions, debt and equity, raising opportunities for customers, consumers, and healthcare companies. Over to Dhruv. Thank you.
Yeah, thank you, Maninder. So good morning, everyone, and welcome to our next session, which is on the role of supplementary mechanisms in financing healthcare in India. As you all know, I'm Dhruv Pava. I'm Senior Director at Global Health Strategies. Firstly, I want to thank...
Dhruv, we're not able to hear. Oh, sorry.
Sorry. Is this better now? Can everyone hear me?
Perfect.
Okay, great. So firstly, I just want to thank all our participants. I believe we have a bunch of participants who I can't see here, but I know they're there. So thank you all, and thank you for our very accomplished panelists who've joined us here early on Saturday morning. So thank you. In terms of our agenda, we have 60 minutes. The first 10 minutes of which I'm going to request Dr. Prinja to just set the context by talking a little bit about the challenges we face in financing universal healthcare in India, and more specifically, maybe even talk about the case for immunization, post which we'll spend 40 minutes over a panel discussion. After that, I'll request Dr. Prinja to come back again and help us just summarize the recommendations. And then Kaushik Bose, who's the Vice President of Global Health Strategies, will help us just close out the discussion. With that, Dr. Prinja, I'll hand it over to you first. Post that, I'll introduce all the panelists and we'll dive into the panel discussion.
Sure. Thank you very much, Dhruv. I hope my slides are there.
Yes, I can see that.
All right. So thank you very much. And I must acknowledge the support from the Global Health Strategies and the International Vaccine Access Center for supporting this session. So I'll take less than 10 minutes to just maybe introduce the topic that we would be then delving deep into in our panel discussion. And I don't want to really stand between the eminent panelists and the audience right now. So I'll try to just set the context in terms of outlining the immunization program budget, giving a bit of an insights into the CMYPs and showing how the expenditure on immunization is growing, and what are the demands on the immunization financing, and then making a case, if there is, for thinking around supplementary financing mechanisms. So looking at the budget for immunization that we have, which is about nearly 6,800 crores. And if we look at that, about nearly 45% of this is actually on shared personnel, which means the human resources that are involved in delivering the immunization, the entire gamut of healthcare delivery system and the healthcare workers who are involved in delivering immunization services. So that constitutes the biggest chunk. And then the next big chunk is the share of the vaccines, which comes to about nearly 18%. Overall, we have about nearly 80% of the total costs being borne by the government, and about 20% comes from the external sources like the Gavi. But if we look at the breakup for just the vaccine costs, which account for about 18%, of this 18%, nearly half, I would say, is something that gets contributed by partners and donors. So that's the rough pie of the overall immunization budget. And this is something that is growing and is likely to grow as per the projections by the CMYP from about nearly 6,800 crores, which was in 2017, to an estimated upwards of 12,000 crores in 2022. And much of this scale up is something that is likely to be attributable to introduction of some of the newer vaccines that we anticipate that are likely to come, scale up of some of the existing vaccines like PCV to other states that are in the pipeline, that have also been announced very recently in the budget speech as well. So that's the kind of scale up paths that we are seeing for financing on immunization. And within this scale up of the overall cost to about nearly 12,500 crores, the share of the costs that are explained by the vaccine per se, the amount of expenditure that we're likely to have, is again set to double from about nearly 2,600 crores in 2018 to about 5,000 plus crore in 2022. Again, this is on account of some of the new vaccines like PCV and HPV that are being considered for either introduction or scale up. And this entire thing is happening in the context of an overall policy environment where the Gavi, considering the transition of India from in terms of the World Bank classification at the income level, is considering a gradual rollback from India. And it is likely that in the coming years, the support that the Gavi offers for supporting the routine immunization is likely to go down. And by 2022, it is expected that the routine immunization is to be funded through domestic tax-funded sources individually. Now, all this discussion is taking place in an environment, and these slides have been prepared in an environment where we're not factoring in the presence of a new thing that has happened, and that is COVID. And the emergence of COVID has actually completely transformed the policy trade-offs, and which have completely shifted. So from a pre-COVID period where we used to have a body called NTAGI taking decisions on introduction of newer vaccines, and which used to consider issues like the burden of disease, the effectiveness of the vaccine, or the cost effectiveness of the vaccine as potential criteria for making decisions on introduction of newer antigens, to now a situation where there are trade-offs of health interventions, not just on health, but on a range of other microeconomic outcomes at the level of individuals and households, as well as at a broader macroeconomic level as well. And each intervention that we think about to address this problem has ramifications at each of these levels. And there are significant externalities of any kind of an investment that we are trying to think about for COVID, which means that we would necessarily have to also think about the opportunity cost of that spending, that additional spending that we are likely to generate. And this additional funding may come from within a reallocation within the health sector, or may come from additional revenues that the government may be able to generate. So which means that there is clearly a role of trying to think and safeguard the existing budget that we have for the health sector, and then trying to think of newer ways of financing the additional set of interventions that we might require. And it is in this context that the government has recently also announced a large package of 35,000 plus crores that is focusing only on introduction of the COVID-19 vaccine, which if you look at it in the perspective of the previous slides, it's like more than 10 times the estimated vaccine costs in 2020. So that's quite a massive jump in terms of the overall vaccine expenditures or financing. So this brings us to this, to sort of think about the need for these supplementary financing mechanisms in the context of these key developments. So one is the phasing out of Gavi. Two is this government's announcement to scale up some of the existing vaccines or introduce newer vaccines like PCV or HPV. And then there's this big question around the COVID vaccination. So in this kind of a background, we would really look forward to, illuminating views from the galaxy of experts that we have in the panel on trying to think about exploring the feasibility of these mechanisms that could possibly be there. But more importantly, trying to discuss the institutionalization of mechanisms that could be evolved in order to A, draw such revenues, and two, in order to utilize such revenues, such that there is a proper governance and also there is a proper accountability. So maybe I'll stop here and let Dhruv take over and take it forward from here on. Thank you very much.
Thank you, Dr. Prinjal. Thanks a lot. Before we begin, I just want to quickly introduce our panelists. So, and I'm just going to go by how the tiles are arranged on my screen. We have with us Mr. C.K. Mishra, who's the former Secretary, Ministries of Health and Family. Sorry, I just lost my screen here, which had the introductions. Okay. So we have with us Mr. C.K. Mishra, who's the former Secretary, Ministry of Health and Family Welfare and Environment and Forest and Climate Change. Dr. Virendra Chauhan, who's the Executive Chairman, National Assessment and Accreditation Council, and the Arturo Falaschi Emeritus Scientist, International Center for Genetic Engineering and Biotechnology. Dr. Salima Razvi is a research economist at the Copenhagen Consensus Center, and Dr. Pranab Sen, who's the director at International Growth Center in India. So again, thank you to all our panelists for joining us here today. Before we begin, I just want to quickly go over some of the mechanisms that we have researched. And Maninder, do you have that presentation? Can you upload it? If you don't, I can share my screen.
Yeah, Dhruv, I'll suggest if you can share your screen, that might be good.
Okay, great. One sec. Can everyone see it? Because I can't.
Yeah, we can see, Dhruv.
Yeah, I'm gonna.
It's gone down now.
Okay, one sec. Okay, you guys can see this now?
We can see it if you can put it on our presentation view.
Is this presentation view now? Because my screen.
Yeah, this is better.
Okay, great. So while looking at supplementary financing mechanisms, and when we spoke to and did research, we were faced with quite a few questions. Number one being that, listen, we got to look at efficiency of spends. We got to look at, decide exactly how much money do we require. And then we also got to see that, listen, these, maybe are not enough to generate those quantum of funds. I personally feel all those arguments are very valid, but I personally don't think it's an either or. So for example, efficiency, I believe like we have to spend better and there's enough evidence for that. But I think you still maybe have to look at supplementary financing mechanisms. Same way in terms of quantum, I think the quantum of funds that we require in our country for financing universal healthcare is, I think, going to be a perennial challenge as it is for most of the countries. So I think even then, supplementary financing mechanisms maybe have a role to play. And lastly, obviously, I think by definition, supplementary financing mechanisms will only be able to help us at the margins. But even then, I think they might be good to look at because we have successful case studies worldwide and in some cases, even in India. And the way we filtered out the supplementary mechanisms were largely three criteria. Number one was we did not want any of these mechanisms to lead to increased government debt because there are easier mechanisms of doing that, right? Number two was we looked at mechanisms which do not lead to large-scale tax increases for vast parts of the population. So, for example, so what we excluded is a simple cess, which has been popular earlier, but we did not want to look at it. And lastly, we also looked at mechanisms which have the potential, at least on paper, for generating funds that could be earmarked, could be additional and could be earmarked for healthcare. So with that, I'll just quickly talk about our first mechanism, which actually is also my favorite, which is trademark-based financing. So if any of you guys have looked at any Apple product, you'll see that most of their product range, they have one product red version where they charge you a little extra to the consumer, and then large parts of that money go directly to the Global Fund, which was started by Bono and Bobby Shriver in 2006. It has been widely successful. It has been able to generate $650 million up until 2020 for the Global Fund. And before there was product red, private enterprise generated only about $5 million. And I feel in this regard, we could look at a bunch of other signaling devices or certifications. For example, we had the ISI mark earlier, and Dr. Sen, I know you've recommended that to us as well. Similarly, there's so many certifications, right? Today, you have, for example, food products, you have like US FDA or kosher, various different certifications where consumers are ready to pay up. So the question is, will the consumers be ready to pay up for some amount, some certification that says that, listen, some part of this money is going towards a good cause. And we know by research that millennials are predisposed to buying a lot of cause-related products. And that's what's happening with many private enterprises are doing it by themselves. And it's also like a advertisement, additional advertisement for many of these products. But if this good money could be channelized into specific interventions, maybe such as immunization, which are very important, they could provide additional sources of financing. The criticism this mechanism is faced is that to make it popular, you first have to spend a lot of money in terms of advertising. But I guess while I think that's a valid criticism, I think many interventions might have that. Okay, number two, lotteries. While it was surprising to me that more than 50% of the countries did have lotteries, and in India also we do have lotteries. In our discussion and our research, we in fact decided to not consider this because of the negative externalities and just the whole gambling kind of addictions it might create. I just put it in there as an example of the things we looked at. Tobacco taxes, I find very interesting for a couple of reasons. One is it generates substantial amount of tax revenue. 43,000 crores is a number that I know last. However, what really happens is cigarettes, which forms only 10% of the overall tobacco consumption, contribute to about 80% of the tax collection. Bidis and smokeless tobacco, for largely being taxed less in the case of bidis and could be a lot of illegal trade, they generate very little in terms of tax revenue. So I think there are two questions here. One is there enough political will or capital to even tax other forms of tobacco a lot more in India? And the more important question, like other countries such as Philippines, Vietnam, and we found examples from 35 different countries who earmark taxes from tobacco towards healthcare. So is there appetite for doing that? Lastly, corporate social responsibility. And I know, there could be a lot of debate on whether CSR should have been there, should not have been there. Is it just another form of tax for private enterprise? I think valid questions, but now that we do have CSR, we thought of looking at it for a couple of reasons. Number one, at least at the very onset, it seemed like, just few companies generated max amount of CSR funding, but that is shifting. If you see, about, I think, 7,500 crores now at last count that we know, were contributed by much smaller companies, because many companies over a period of time now have over 5 crore in terms of profit. And they have to contribute less than 50 lakh rupees. So when that happens, there's a long tail of companies who have to contribute less than 50 lakh rupees. We've seen enough research to showcase that they find it very difficult in that small quantum of funds to set up a whole CSR division within their company. So maybe many of them could pool their money into a fund which is transparent, which, and of course is as good as only the kind of reputation that fund has, to then direct their money towards healthcare interventions. And the overall CSR pool is getting substantial. It was close to 19,000 crores in 2019. And I think the challenges that these companies face, I think the government is obviously well aware of that, and they created avenues where companies could directly allocate, send their money, and it's just very easy for companies to cut one check, right? So, for example, the Swachh Bharat Kosh was allowed under CSR, and the Clean Ganga Fund. I know the Swachh Bharat Kosh generated about 950 crores over the last many years through just CSR. The PM Cares Fund is allowed, and more recently, contribution to incubators for research and development projects in medicine. And the PM Cares Fund, we know during COVID got a lot of money from corporates, and a lot of that was just directly from CSR funding. So the question here is, again, at least for at the margins for certain important interventions, maybe such as immunization, could funds be directed towards CSR? So with that, I'll quickly stop the presentation. So our topic of discussion here mainly is, yes, supplementary financing mechanisms, but what is the political and economic viability of these mechanisms? And lastly, but more importantly, maybe on paper they look nice, but what is the potential of these being implemented and how to go about it? So I think with that, I'll just quickly invite opening comments. And so Mr. C.K. Mishra, if I could come to you first, just to give you opening comments on the political economic viability and if any of this could be implemented and what would that look like? Sir, you're on mute. We can't hear you.
Thanks, Dhruv, and thanks, Dr. Prinja, for your presentation. The canvas has been well laid out, and we have experts here who would comment on the viability of additionality in funding in healthcare in particular. I mean, immunization is what we are talking about today. What I would like to just share with you is a sense of administrative implementation on how these funds can get utilized. See, one of the basic things that people keep talking about when we talk about primary healthcare and also immunization in particular is the capacity of the states to absorb funds. The common refrain is that there is enough funding available, but not all of them can be utilized because we don't have the capacity to absorb them. I think this debate needs to shift a little because slowly states are getting ready to do it. And I don't think we should stop an idea of additional financing merely because there is no capacity, rather than create capacities for additional financing. So that is one point that I would like to. And the basic concept is that a death that is preventable must be prevented. Therefore, I have always felt that a lot of these resources need to go in immunization. Fortunately, in India, immunization has been well funded, well financed, and we've not had shortages. But please remember that we've been doing immunization with constraints. Therefore, supplementary funding is a critical issue. Now, I'll tell you what the constraints are in implementation. Let us take 2018, 17, 18, 19, when the biggest shift happened. We introduced Mission Indradhanush, added more people, and also during the same period added 5 new antigen. This was the only time perhaps in India when at a go we introduced 5 new antigens. But even with Gavi support, which is now tapering off, we were not able to introduce this antigen across the country. We're still doing it in a very phased manner. I mean, this year's announcement of pneumococcal being rolled out throughout the country, this happened in 2018 when we introduced it. But it's taking us 5 to 6 years, and this happened in the case of pentavalent, this happened in the case of other antigen also. It takes us 5 to 6 years to 7 years to really roll it out across this country. And apart from the fact that there are some logistic issues, the major constraint is financing at a go. So the thought that we need to consider is, do we need to pump in supplementary financing to actually ensure that what we are trying to provide to people in terms of antigen, we do it across the country, and in one go we are able to spread it out. There is another argument that is always given when implementation comes, that there is enough money for immunization in the budget, why do you need more? There are many things that are happening, and particularly now with COVID, we have learned that supplementary financing could have been very well used to create a better cold chain base, for example. We could have expanded that. It's not just about the number of children getting immunized. It's about creation of infrastructure. And infrastructure, so far in India, we've mostly been creating through UNICEF help, through other multilateral help. So we need focused financing in creating infrastructure. I mean, cold storage points, better cold storage facilities, better facilities down the line. I mean, the A&M actually reaches the target. Till that point, what is the kind of cold chain facility that we are creating? And while on antigen, one of the points made by Dr. Prinja was that a huge amount of money of the immunization budget goes on to the personnel and the salaries and other things. We need to take that in a slightly different context. We need to understand the overall health systems, because the personnel who are involved in immunization are not personnel totally dedicated to immunization. The same A&M who's going on Tuesdays and Thursdays into the field to immunize gets back to the PHC on other days and does the work. So actually attributing that expenditure to immunization, I don't know. Dr. Sen would perhaps guide us on that. I don't know if that is the correct way of looking at the total. So I think there is a scope where we can design a better health system with additional funding. We can get more antigen into play with the additional funding, and we can actually expand the base of immunization in the country. We also spoke about COVID. 35,000 crores in the budget this year for COVID. That is a dedicated funding, which I don't think will continue year after year after year. So we should not mix that up with our routine immunization program. They are completely different things. The structure of routine immunization is being used, but the COVID vaccination is a completely different thing. In fact, what has happened is the reverse. Because of COVID, our routine immunization last year has lagged behind so much that it will take years to catch up on what we have lost. And when I say it's lagged behind too much on account of immunization, that also means less expenditure. That certainly means less expenditure. And if you really look at the overall scenario and the world getting into vaccine production, or particularly in India, the larger players all preparing for vaccine production, we are not factoring in that antigens required for routine immunization are taking a hit even at the production level. So as a country, we are getting into a situation where I'm afraid we might land up with shortage of immunization vaccines, with shortage of several other things. And these are things we need to very carefully look at, because we are using the same personnel, we are using the same manufacturing capacity for syringes, manufacturing capacity for other things. So we need to look at it very carefully, and today is the time, more than ever, that I think we need supplementary financing. Now, how do we get into supplementary financing, and how does it fit in into the overall structure? To be honest, I mean, from my previous experience, I can tell you it is the most difficult thing for the system to accept something that is coming from outside. The integration and an absorption that we think will happen if some money is put on the plate is not that simple. It's a very complex way the entire structure works. So we have to create a systemic mechanism where whatever is coming in is able to flow. And, generating additional resources, you spoke about, and we've discussed this earlier as well, sin taxes, taxes on tobacco, lotteries, and other things. The problem with this is that we have for a long been charging cess, health cess on several things. Nothing of that flows to the budget of the health ministry. So even if I agree with you, Dhruv, and we increase the taxation on BDs and we increase the taxation on everything else, which we call sin tax, is it going to help the health systems? Is it really going to strengthen the financial base of the health ministry, so to say? Unless, like examples you showed, you have a dedicated mechanism of some fund flow happening to that structure for a dedicated cause. We've been struggling with this for the last, I think, 5-6 years, but there's been no answer to this. So there is a problem and a practical issue at the field, even if we have additional funding on how to integrate it. CSR, for example, and that is a classic example in this country where despite availability of some fund, we have not been able to put it to proper use. In the health sector, for example, I mean, fair amount of CSR money is going. But if you look at where it is going, somebody buys an ambulance and puts it in one of the villages. Somebody puts a few equipments in a PHC or a CHC, and that is CSR done. So it is not so well integrated into the system to give the output that you need. So can we create a basket where whichever company wants just puts the money in there and leaves it to the wisdom of the spender? I mean, there's a difficult one. It's not easy for every corporate to accept that. Please let me clarify that. But there are two options. Either you leave it to the wisdom of the person who is spending and how he's going to utilize that money, or alternatively, which I had proposed to all the industries bodies in 2018-19, alternatively, let us have an agreed list that we need financing additionality only in these 6 sectors. You please put your money only in these. Don't put it anywhere else. So unless we are able to work this out with the industrial bodies and the corporates, I think CSR funding, even though it is happening, is not getting us the desired result. And if there is one source of fund which can easily flow into primary healthcare and particularly immunization, it is the CSR funding. That is available. I'm not getting into a debate of whether it is the correct thing that the government has done or not. I mean, that's a separate issue altogether. But the fact remains that we have a pool of funds which we can really use. This whole talk about successful implementation of immunization so far, one of the critical players has been Gavi. In 2018, when we were negotiating the last 5 years of Gavi's involvement in India, they actually wanted to exit much earlier, but we stretched it because we had just introduced 5 antigen and we needed Gavi support. So now India is in at a crossroad where external funding for immunization is going to decrease. Therefore, we will be looking at additionalities to kind of run our immunization system. And I think that is where additional finance would be required. And what we need to work on is a mechanism of integrating that additional finance into the declared programs of government so that we work towards a common goal and we are getting that additional investment into our system. I mean, we have experts who elaborate more on how or whether it's possible, not possible. But I think it's a good issue to discuss. And I think we should also, apart from the experts, throw it at people who can do the supplementary financing mechanism to see what they feel about it, and are they keen on it or not, or they feel there any value in this or not. So I'll stop here. Thank you very much for giving me the time, and I would be very eager to listen to the experts and learn a lot today. Thank you.
Thank you, sir. Very important points. Couple of them that really resonated with me is that we do require a focused approach to prevent every death that can be prevented. And couple of things there is, how do we scale up much faster, because we do take, while we've introduced antigens, it takes long to scale them up. How do we expand the basket? And more specifically, the third point is additionality, where we've had various examples of, health education says where money is fungible, you take it from one place, it reduces from the other. How do we set up that mechanism? So Dr. Sen, could I come to you for that very specific question of additionality? How do we, create a mechanism to make sure most of these funds, if they're implemented, will be additional and not just replace the money coming from general overall tax pool?
Let me first compliment Mr. Mishra for essentially going to the heart of the problem. I think the basic story hinges around one critical issue, which is that if you're going to talk about mass immunization programs or any medical intervention at a mass scale, it has to be through the government system. There is no other way, right? Now, if it is through the government system, then the issue of fungibility cannot be wished away. Now, we need to keep that in mind. And I think Mr. Mishra spoke from the heart, because as health secretary, he was probably crying blood to get funds for what was needed and what was necessary. And at the end of the day, and he refrained from mentioning it, but now that I am a free agent, I can, it ultimately depends upon political commitment and nothing else. For COVID, 35,000 crores have been earmarked, right? It's not that the money isn't there. But we should ask Mr. Mishra, supposing he has given 35,000 crores during his 3 years tenure, he would have probably done wonders. Why is the commitment to the 35,000 crores there, whereas we are not getting a commitment to what is otherwise a paltry sum of 2,500 odd crores? That's at the heart of the problem, right? Now, as he said, the 35,000 crores is not going to hang around. The 35,000 crores for COVID has, what should I say, a political value, which is huge. But that value is going to go away the moment Corona is stopped being seen as a threat. So one can't and should not, in fact, believe that this 35,000 crores is a step up which will remain forever. It's not. It will probably go away next year or the year after, at best. The question then is, raising the money, I think, is less of an issue. What is more of an issue, I think, is to address the way those funds are made available to the public healthcare system and ensuring that it does not displace funds that would have otherwise flown through the budget. That is the question. That's the fungibility issue, right? Now, there are various ways this can be done. And let's be very clear that whether we are talking about CSR or we are talking about trademark-based funding, there is an institutional issue at the side of the autonomous agency that will need to be set up to manage these funds. And again, Mr. Mishra talked about that. That's a lesser issue. Dhruv, you've been in this game long enough, you would probably be able to devise a framework of this kind. The real issue is, how does that institution interact with the public healthcare system? That's the critical point, right? So even if you think of Gavi, Gavi is important. And the reason why Gavi money doesn't get displaced and is treated as an additionality is simply because Gavi has an international backing, which can give rise to a lot of very adverse publicity for the government if it messes around with those funds and uses to substitute its own money. But we have no such guarantees for funds collected domestically for domestic purposes. Now, in a situation like that, it would have to be done at a more disaggregated level. And here again, Mr. Mishra can come because of his experience. You see, what you would have to do is that the funds would have to be tied to a particular activity, and much more importantly, it would have to be tied as a matching grant. Whether it's 50-50 matching or 30-70 matching, that we can decide. That's not really a critical issue at this stage. But it would have to be on a matching grant basis. Now, the government as government, and certainly not government of India, cannot take this kind of funds through the budget. The question is that are there institutional points along the full delivery chain where such matching grants can be given and can be accepted? This is essentially an administrative issue. And I don't think it's insuperable, but a matching grant method may, in fact, at the moment, given the kind of systems that we have in the country, may actually be the better way to go. The other alternative is to say that the public health system will do what it has to do with the funds that the government gives it, and we will create a supplementary mechanism in the private healthcare system, which is again to provide essentially a private subsidy mechanism for vaccination. Okay, one of the methods that we can think of is actually to build this in and work with the insurance companies on this. Because insurance companies, when they do family health cover infants and children as well. So that's one method of doing it. The other method is actually to locate private institutions. And remember, a lot of the hospitals in India are charitable institutions, a lot of them. Is to actually talk with them and say, can we help you to expand your outreach to those who are unable to access the government system? Not as a replacement, it cannot be done, but as a supplementation, and to actually fill up the cracks between the stools. So although this is about financing, additional supplementary financing, I think Mr. Mishra has been absolutely right saying that financing is the lesser problem. And as far as the CSR money is concerned, all that has to happen is one line has to be inserted into the CSR rules, which permits funds to be given to this agency. That's not such a big deal. The real issue is the mechanism by which funds raised outside the government system finds its way into financing either the government system itself or supplementing the government system through private initiatives.
Great, sir. Thanks a lot. So what I do understand, I completely appreciate my thoughts exactly. at the heart of it, it's a question of just political will. In terms of implementation, it could be various ways. There could be an autonomous body, and they could be matching grants given maybe, and you could also engage the private sector who do it completely outside the realm of the government, and insurance companies could be a great mechanisms because it is in their interest that people are healthier and live longer. All points well taken. I would like to now invite Dr. Razvi to give us your thoughts around this.
Thanks, Dhruv, and thank you, Dr. Prinja, for inviting me to this panel. I've been listening to both Mr. Mishra and Dr. Sen, and again, as Dr. Sen said, the points are absolutely spot on. It is sheer lack of political will and commitment to health in general. And even the focus on health in India has traditionally been on curative and tertiary level care, not on preventive and promotive care, which is really key for ensuring the populations are vaccinated, immunized, etc. We've been talking for increasing, the share of health outlays as a percentage of GDP to 2.5% for over the last so many decades now. I think at least for the last 25 odd years that I've been working in this space, we've been discussing that, and we are still stuck around the 1.5% of GDP. The reason for that also is because, like Dr. Sen very rightly said, the lack of political will. What we need to do is ensure that the out-of-pocket expenditures that the Indian citizens face, those have to be reduced, definitely. The pandemic this year has been like no other year. The pandemic has caused immense financial distress to lots and lots of people across the country. The Pew Research Center came out with a report just yesterday in which I think it says 35 million Indians have been pushed from middle class into poverty, and a 75 million additional citizens have been pushed into deeper poverty. So we are looking at immense grades of financial hardship, which are going to impact the capacity of those households, of those people to actually go out and access healthcare, which is why supplementing health financing in the country is even more crucial. And for immunization specifically, we definitely need that, given the way the disease profile is changing in the country. Would the immunization program see a targeted financing available for it, given the spate of the increase in NCDs, the increase in the resurgence of communicable diseases coming back? We need to ensure that that immunization budget is protected, and more and more funds are put into that. Sin taxes, as you mentioned, Dhruv, and as Dr. Sen said, the tobacco tax that has been put on tobacco and its subsidiaries, it's the revenues from that, I think, go into the general revenue pool. They are not targeted for health. Could we find a way of ensuring that those revenues are targeted? I think it's a very minimal percent, 0.3%, which is supposed to go into the health pool, but even that doesn't make its way really. Also, when we're looking at talking about CSR, the CSR, yes, the Companies Act was a wonderful step in the right direction, mandating a certain amount of money be set aside for social development. But what really happened was that instead of seeing the multiplier effect of those funds, I feel that the government spends are shrinking. It's not that the pool is expanding, the pool of finances is expanding. Rather, that the CSR funds are coming in and the government is not really stepping in to increase its level of share in the thing. So that is a concern. And again, with the CSR funds, what ideally we would like to see is a targeted, to see where exactly those funds are being spent. Again, it's a general social development, like Dr. Sen said, or Mr. Mishra said, ambulances somewhere, some eye operations done, cataract surgeries done. That's not what we want. We really need to focus and find out, or rather ensure that the funds that are accrued, and it's a healthy amount, right? The CSR funds, we really have to ensure that they make their way into the specific programs like immunization and vaccination. We're talking about almost, I think, 5 to 8 million children unvaccinated annually. And that's a large figure. I mean, we can talk about a 70 to 90% coverage, but that really hides the number of children not being vaccinated. And we really need to step up with identifying and reaching out to that, those children who are not being reached. Yep.
Thank you, Dr. Razvi. So I guess it brings us back. Yes, there are a lot of these things that got to be done, and how do we do it? So ultimately, it does come back to political will. Dr. Chauhan, I would like to come to you next. And this is the year of the scientists, right? And the public maybe looks up to scientists, people with knowledge of vaccines and the importance of preventive healthcare. So ultimately, if we maybe look at this in the sense of demand generation from the public, that this has to be a political issue, this has to be election issue, how would you say we could probably do that in our country? And maybe even put immunization at the center of it. So I guess you're on mute.
Am I audible now?
Yes, sir.
Okay, so I don't want to repeat what Navid said, what Mishraji has said, and the last speaker has said. No matter what I want to cover, the topic on which you are focusing today, it will be repetition of one of the things that has been said. I'll avoid that. Let me just very quickly, this doesn't need any convincing to anyone that immunization at an early stage against infectious diseases is probably the best way of, there's no better way to spend your money in health. That I don't think even I have to say. New vaccines will come up. What is the scientist? I mean, you can see how much what has come up, unfortunately, through the COVID is the vaccine hesitancy. That even with all the science, all the push government and money, scientists, manufacturer, in countries which are highly educated, which have all the information, good or bad, there is still 30 to 40% hesitancy. So I'm not really addressing the issue because that has been addressed. I'll just say that much more needs to be done. What COVID has done, fortunately, unfortunately, brought on the surface is the apparent to me at least, lack of trust in the science itself. And this sounds very strange because never before science has moved so fast to produce this or that, especially vaccines for any disease, ever before. This is absolutely breathtaking. But never before this has also come up that the mistrust. And the example would be death of Tanzania's president 2 days back. A lot of people in various parts of the world still believe that this has nothing to do with COVID virus. We don't have a pandemic. This is really bothered. But let me just get away from this. I wanted to get out of my head as a scientist. If India, it's not if, India will be producing very large amount of all kinds of vaccines, including COVID-19. There's no shying away from this. The availability of vaccines all over the world, especially of COVID and other vaccines, I dare say, is possible only because one of the major reasons is India produces them at very high quality at very low cost. So I think the government at a different level should have leverage with Gavi or CEPI or WHO or whatever. India needs to be treated, especially vis-a-vis funding, for not now, for many years to come. Because no other country probably would have invested in the infrastructure of producing high quality vaccines for rest of the world, for Africa, for 60% of all vaccination, number one. I think our Prime Minister in South Africa made a pitch that even for COVID vaccines, India should be allowed to have a different patenting availability of producing. I think this is a good time to leverage Indian strength. Coming now to the topic that you are discussing, yes, of course, we should have funding from anywhere. I merely repeat what Sen has said and what others have said. My own experience this CSR in education and elsewhere has been, if large sums of money have to be obtained from, let's say, large business houses will be very comfortable if they knew which basket their money is going to go for. And Mishraji has already said that we should have a mechanism. Now, I have found over the years in education, there are a whole lot of wishful things, which we discussed even today, that this mechanism should be there. Krishnaji was in the government. You know the complexities. Wishful list is definitely there. This should happen, that should happen. Doable stuff out of that should be culled out very, very quickly. Otherwise, we could be discussing in next year, year after, that this mechanism should be there or not. So I personally, as a nut bolt person, would like to see what precisely is the pathway to put that mechanism in place and get one of them just. Can CSR money, for example, if HPV comes in, or meningitis vaccine comes in, let's say I'm a big business house and say, all right, I'll take responsibility of 10 states in Northeast of elsewhere. I will take the responsibility. I'll fund it. Will the mechanism allow that to happen to immunization? I think steps like this, very clear, thoughtful. Otherwise, CSR money is going in education, will go in health. You won't know where the traces are. But I'm merely repeating what Mishra ji has said, what Professor Seth said. Out of large amount of wishful thinking that you and I can discuss now or next year, what is immediately doable? Is the political, we all know political will for education and health. If there's a political will, things will happen. But we all know that it hasn't happened. So the next question, how do you increase the political will from 3% to 6% in education, from 2% to X% for health? I would be very happy to have that kind of discussion. Here is the pathway. Thank you.
Thank you, sir. And I want to thank everybody. I just want to say one thing. What I took from this conversation is that maybe money alone doesn't make the world go round. What you need at the very beginning is that will, and you have to work towards creating that political will. But at the same time, they have to be, as Dr. Chauhan said, very specific, focused starting point. At least you take one thing and get started. And maybe those are our next steps, that have a very focused one approach where you try to implement something at least first and then scale it up. So with that, Dr. Prinja, I'm going to hand it over to you to just do some of the recommendations, and then Kaushik to just help us close out the meeting. Thank you.
Thanks very much, Dhruv. I think you've given me a very difficult task to summarize something that comes out of such luminaries, and it's I'm not sure if I can really do justice in the next couple of minutes or so. But I think that I have tried listing about 4 or 5 key messages that I could call out. The first, obviously, that you tried to make is the issue around the political will and the level of importance that we need to place on immunization. I think at the current juncture, we don't see that there is a difficulty in placing importance on immunization, given the fact that as part of the newer Finance Commission recommendations and the new fiscal federal relations between the center and the state, the government is now transferring 20% of allocations on performance-based funding. And one of the key criteria that has been set for, which is an essential criteria for states to meet, which comes as part of NITI's recommendation as well, is achievement of a certain level of coverage for immunization. So I think that going forward, that kind of a vision at least certainly places importance on immunization, which needs to be certainly pepped up even further. We did find that there's a resonance among the experts and the policymakers that there is certainly a need to step up financing, and supplementary financing options do offer a choice. But there are certain issues that need to be addressed. First, and which was clearly brought out by almost everybody, was the issue of perhaps making some kind of arrangements for earmarking these funds. Because if we don't earmark, so it's like a difference between a tax-based funding for healthcare and a social health insurance. So in a social health insurance, there is a earmarking of, there is a hypothecation of the fund that you generate, revenue that you collect from the individuals, which is earmarked for health. And this is essentially perhaps what we need to also think about if the supplementary financing mechanisms need to be tapped. There has to be a role for earmarking. The second is that where and how do these funds get utilized? And I think that the suggestions that Mr. Mishra made about who becomes the decision maker for utilizing, do we really leave it to the user to decide? Or do we make it a kind of a bucket list where the CSR funding or the other options of supplementary financing could actually be drawn towards is something that needs to be worked out. I think it also reminds me of the early days of health sector reforms, where initially the donors actually came with their own set of wish list, that this is where where we want to invest. So we want to invest in malaria, or we want to invest in HIV. But later on, the governments became more stronger stewards of controlling where and how to spend that money. So maybe a capacity within the government to sort of make sure of that there are arrangements to utilize this resource would also become very, very important if this is to be taken up. And finally, I think there were very good suggestions from Dr. Sen on perhaps thinking around something like a matching grant, which brings in a bit of an accountability from the government side as well, that and from the private sector or the CSR or the other mechanisms of supplementary financing. But the key question, which all experts did allude to, is that what is the implementation framework or the governance structure that we set up in order to really roll it out. And I think that, as in the previous session, so we had a previous session on strategic purchasing. And one of the key lessons that I went out after that session was, it's certainly not something that will be a transformative shift that may happen in just a few months or a year's time. I think systems take time to ultimately progress. So similarly, here as well, I think taking the suggestion that Dr. Chauhan made about maybe trying out certain pilot exercises, maybe in a few states, try this out, learn from the success stories, and then maybe scale it up. So I think that possibly could be a very good suggestion that could be taken forward from this consultation, that maybe develop pilots of governance that could then be scaled to demonstrate the effectiveness. So I'll stop here and I'll hand it over to Kaushik now to maybe take it forward.
Hello. Thank you. So to begin with, since there's very little time left and we have overshot, to begin with, I'd like to thank all our panelists, Mr. C.K. Mishra, Dr. Salima Razvi, Dr. Pranab Sen, and Dr. Chauhan for sharing their insights in this thought-provoking discussion that we had today. I would also like to thank Dr. Ratin Roy, who couldn't be here today, but he shared his valuable inputs in earlier deliberations. Dr. Shankar Prinja and Mr. Dhruv Pawar to actually curate this interesting discussion today on financing, supplementary financing. And I would like to also thank my colleagues in International Vaccine Access Center, Johns Hopkins University, Global Health Strategies, the Department of Community Medicine and School of Public Health, PGI, and Indian Association for Preventive and Social Medicine for enabling this discussion today. I'll just give me a second. I'll just share my screen. So we first felt the need to study the role of supplementary financing mechanism a few years ago with synthesizing evidence on challenges to India's road to universal healthcare. It was a fascinating area of study, especially since there was no dearth of available global and regional evidence. But in India, however, we did not have too many published evidence available. So we also realized that we need to address critical gaps in health financing to evaluate the role of supplementary financing mechanism. Hence, PGIMER, Global Health Strategies, and International Vaccine Access Center have developed a policy paper which outlines 3 supplementary financing mechanisms, namely trademark-based financing, tobacco taxes, and corporate social responsibility contributions to generate revenue for key health interventions and supplement the overall health budget. We hope that this evidence shared here and the questions that has been discussed today will encourage you to delve deeper into this area and play a decisive role in crossing the miles between evidence generation and to policy. We hope the insights offered here today would help sustain this pertinent solution-oriented conversation on financing of health. We'll share this paper with all of you at the end of the conference. The paper will also be available on the Global Health Strategies website soon. So I would like to thank you all once again and adjourn this meeting. Thank you.
Thank you, everyone.
Thank you, Dhruv. Thank you, Dr. Punjab.
Thank you, everyone.
Thank you very much to the.
Thank you very much.
Thank you very much, all the panelists. I really appreciate your time. I know you're all very busy people, but if you have time and if you can stay back for the next session, we'll absolutely love it. It's going to be a session on health technology assessment and use of cost effectiveness evidence in policy making and decision making. So thank you very much. So I'm now going to move forward to our next session, which is a very interesting and a very well-awaited session in our conference, which is on health technology assessment. And I'm going to introduce the chair for the session, who is Madam Anu Nagar, who is the Joint Secretary, Department of Health Research and Ministry of Health, who's actually the person who is steering and carrying forward this entire movement of health technology assessment within the government. She's a Indian Forest Services officer from the Himachal cadre. She's a member secretary of the Medical Technology Assessment Board of the HTA agency in India. And she's also within this entire COVID pandemic, she's led the initiatives around development of the entire diagnostic labs in the country. So without much further ado, I'll hand it over to Madam Anu Nagar. We unfortunately have not been able to have Mr. Rajiv Sadanandan join us for this session. So over to you, Madam.
Thank you, Dr. Shankar. I thank you all and the organizers for inviting me to this session, and I'm really privileged to be here. As you all know, that HTA plays a major part in evidence-based decision making, and if we do not...
Ma'am, could you be a little louder? I think we're, yeah, or maybe closer to the audio.
Am I audible now?
A little better, but if it could be a little bit better, it would be even further good.
Okay, let me increase the volume then. Is it any better now?
Much better, ma'am. Thank you.
Thank you. So thank you, Dr. Shankar, for inviting me here, and I'm really happy and privileged to be a part of this session. And HTA, as you are already aware, that it plays a major role in bringing evidences for decision making. And you know that if we do not have proper scientific evidences, then other factors like social factors, financial factors, and institutional factors play a role in decision making, which might lead to suboptimal health outcomes, or it may also use to inefficient use of already meager resources that we have. In our present budget, there is 137 increase in health expenditure, and it is very important at this juncture that we have proper use of HTA to have better health outcomes, and the mandate that we've been given gets fulfilled. So HTA has been recognized as a tool by planners for setting health priorities in public health expenditure. And accordingly, in 2017, DHR, the Department of Health Research, was given this role, and we set up a Medical Technology Assessment Board. So this MTAB, the Medical Technology Assessment Board, it has a three-tier structure. At the top is the board, followed by technical committees. We have resource centers, 16 of them all over the country, and it is assisted by a secretariat in the DHR headquarters. We've taken a number of studies. The number is quite limited, say 20 right now, but there are many studies ongoing, and we really plan to take this thing forward. And one of the important studies that has been taken up, like this session said that we would be talking about health benefit packages, pricing and reimbursement decisions. So very important study that has been taken up by PGI Chandigarh is on costing of health services in India. So this study has been used to actually frame revise and formulate the health benefit packages for the largest tax funded public insurance scheme, that is Ayushman Bharat, in the country. And its impact has been quite visible. And I'm sure Dr. Kavita or Dr. Nidhi would actually be talking about the impact that it has made, the savings we've been able to have. So this study is also very important because it has been able to, through this study, we are generating a cost database, which was not present earlier in the country. And this cost database would actually help us in taking our studies further and revising the packages, and also to be adopted by many other states all over the country. So apart from this, we have started taking initiatives to integrate the states more into our HTA process. We've had nodal officers appointed from each of our states so that states realize the importance of HTA and use them in their decision-making process. We are also trying to make our processes more transparent. We are going in for peer reviews. We are trying that we should have patient groups included and industry included into the decision-making process. And Dr. Shankar, you are already working on the cost effectiveness threshold, which I think is very important for a country like ours. So these are some of the initiatives that have been initiated by the department, and Dr. Kavita would be talking more about them. But India needs to learn a lot from the countries who have already been using HTA in their decision making. And I see a very rich panel here, and we would have global perspectives on the role of HTA and their contribution to policy and decision making. So this is all I have in the beginning. Thanks.
Thank you very much, madam. So we'll now invite Peter Baker, who's the Deputy Director of the International Decision Support Initiative and the CGD policy, to deliver the presentation. He's a policy fellow on Global Health Policy team at the CGD, and he's the Deputy Director of the CGD's International Decision Support Initiative. He's been on a number of committees advising the UK's HTA agency, and he's going to give us a flavor of how the HTA has informed decision-making at a global level. So I'll now request to play his pre-recorded video.
Today about the topic of the role of HTA in achieving universal health coverage, a global perspective. And it's a privilege, I think, to be speaking to you in this important conference. I'll just bring up my slides. So to give you an idea of my background, I'm a public health doctor and specialist by background. I'm a member of a similar organization to yours, I think, in the UK, the UK's Faculty of Public Health. I work for the Centre for Global Development, and I have a role as the Deputy Director of the International Decision Support Initiative, which supports around 10 countries around the world think through exactly these issues around bringing health technology assessment to support UHC. So universal health coverage is, of course, a very worthwhile agenda and a major priority for most countries around the world right now. One of the things I think we perhaps don't talk enough about is the fact that we actually can't have it all in UHC. We might want it all, but we can't. Resources are always constrained. Indeed, the very core idea of the UHC cube, as we commonly see, is the idea that not everyone can be covered for all services and for all costs. So, but that's not just true in a kind of static situation right now. That's also true in a dynamic situation over time. In fact, at any level of development, at any level of budget, there will be some services that a country can provide and some services that they just can't afford. And they'll have to make those very difficult choices. But equally importantly, they'll have to set up a rigorous and an effective process for making that decision. So it's not just what you decide as a country for UHC, but it's how you decide. And it's not just, as I said, it's not just countries with limited budgets that have to make these difficult choices. All countries have to make these difficult choices at all level of income. So just to use the example of the UK, I have a role as a committee member on the UK's Health Technology Assessment Agency, NICE, that decides what should be funded under the National Health Service. And colleagues in similar committees to mine took a look at the world's most expensive drug and decided, yes, this was a good use of NHS resources. But then similarly, we took a look at another drug, which was less expensive, called Lynparza, and decided that was not such a good use of NHS resources and rejected that. And I'm just really trying to make the point that at all budget levels, countries need to be able to make difficult decisions around what should not be provided because it's too expensive or not cost effective or in other ways inappropriate for our country. And that needs to use a rigorous process that takes into account the best available evidence. We see three common challenges making these kind of evidence-informed decisions in UHC around the world. And I think these are three common problems that an HTA process a health technology assessment process can support. The first is that decisions are often made in a kind of ad hoc, case-by-case process. This is where a particular technology or drug is considered by government or by the payer for a health service, and its merits individually are reviewed in isolation. So for instance, take an example in 2011, we were looking at the Colombia case where a decision was made not to expand the vaccine provision. So kind of core and very high value vaccine services were only funded at about 58% coverage. Whereas similarly, in the same year, in fact, a decision was made to fund a very expensive cancer drug called Avastin. The point here really is to say, if those two decisions were brought together in a coordinated process, and the opportunity cost, as we say, of funding Avastin was probably implicitly that there was not enough money to expand your vaccine provision in the Colombia context. This is why many health economists talk about the moral case to consider opportunity costs, because what they're trying to say is that you can only spend your health dollar once. If you spend it on a more expensive and less value for money intervention, then you're unable to spend it on probably a higher priority intervention. And this is why there is a need for a rigorous process to consider both the costs and benefits of technologies in a coordinated way. The second common problem is a lack of transparent and explicit and systematic process for doing this. The result then is a limited consideration of the evidence, so probably, and not all evidence is considered, so probably the decision isn't as well informed as it could be. But secondly, and one of the most important things that we often discuss with countries when we're talking through this problem, is health systems are very complicated. They're made up of lots of stakeholders, and some of them are very powerful, including health providers, including the medical profession, including insurers. And if you make these decisions in an explicit and transparent and systematic way that people have faith in, they're much more likely to implement it and support it on the ground. Thirdly, analysis is often disconnected from decision making. This means that both the analyses such as HTAs are not directed at the most important decisions because they are not informed. Decision makers do not tell them what are the most important decisions to be addressed, but also that they were underfunded because decision makers don't see the value in carrying out such analysis. This is why there's now been a really large global movement, I think, particularly in middle-income countries, particularly in Asia, and with India very much leading the way, to use the health technology assessment approach to support UHC. And indeed, now there's a WHO World Health Assembly resolution that supports its use. But how can HTA help? Well, firstly, I think it's worth taking a moment to make sure we're all on the same page about what we're talking about. Health technology assessment is a systematic comparative process and evaluation of the properties, the costs and the benefits and the impacts of health technologies. And by this, we don't just mean a technology such as a drug or even a technology such as a device. We also mean a preventative medicine such as vaccines, but also things that you might not normally consider to be technologies, such as psychological interventions and public health interventions. All of these can be considered using an HTA approach. We also don't just simply mean a cost effectiveness analysis. We're not simply weighing up the costs and benefits, although that must be done. We're also considering things like equity, feasibility, whether you have the right human resources to be able to deliver on the technology, and perhaps other health policy priorities that may want to be defined, other criteria. This means that HTA must be part of a rigorous process. And in fact, most of the time, actually, in my work, when we're talking about HTA, we're not really talking about the analysis so much as the whole process. This is about a systematic approach to considering what are the key priority topics that you need to look at, what are the key decisions you need to make. That's the first thing, topic selection under this 5-step approach. What analysis do you need to carry out to support this? Who and how do you need to appraise this evidence to see what the relevance to your context and whether the evidence is good enough to make a decision? Then what decision are you going to take and how are you going to implement it and monitor that implementation as well. So to take an example, looking at the this report, looking at the cost effectiveness of safety syringes in India, this is a nice example of a good bit of analysis that my understanding not only impacted on the provision of this important technology in the health service, but also impacted on procurement. And I guess that's on the final things I wanted to point out. HTA can impact on UHC policy through 3 main ways, I think. The first is helping governments and payers to set priorities. This is the traditional role of HTA in deciding what should be part of a health benefit package or what should be part of an essential medicines list. The second is about what services should be purchased and how, what the price should be, but also what drugs and vaccines should be procured and at what price. And finally, HTA can inform rigorous clinical guidelines and quality standards. So I'm looking forward to the discussion today. Here are a few discussion points that I think we should consider. The first is we or you really should be proud that India is leading the way in Asia with one of the most one of the biggest HTA programs, including with HAIN and their regional resource hubs and so on. The HTA systems require long-term investment. There needs to be long-term commitment to things like training, such as master's courses, data systems, such as databases of costs, decision-making systems, such as the appropriate appraisal committees. But probably the most important thing that needs to be invested in is the political will to say no when a technology is not appropriate for the country. Thirdly, there is a tendency to focus HTAs on high-tech medicines. But actually, with this group now, today, I would encourage us to try and support the use of HTAs to look at public health interventions and prevention measures, which can fully be considered too using HTA methods. Finally, HTA is too often, as I've said, becomes purely an analytical exercise disconnected from decision making. And I would encourage us to investigate ways for a stronger relationship between the HTA analytics and the decision makers. Many thanks. I look forward to the discussion.
Thank you very much. I think that was a brilliant start to our session today with the opening remarks and the kind of discussions that it has generated. And I think we're right now absolutely rightly poised to now see, in the context of this global discussion, what are the scenes on the Indian HTA development scene. So I'm going to now invite Dr. Kavita Rajshekhar, who's a senior scientist of the ICMR and the Department of Health Research, and who's the coordinator for the Health Technology Assessment Program in the Department of Health Research. So over to you, Dr. Kavita. You may share your slides. I think this needs to go off and then you can share your slides.
Thank you, Dr. I hope my slides are visible.
Yes, your slides are visible. You may put them on a presentation mode and you'll have about 10 minutes.
Yeah, is that visible now?
Perfect.
Yeah. Thank you to the chair and thank you to Dr. Peter, who has already briefed what India is doing. So the way forward, I think I don't have to tell what HTA is. Madam Anunagar has already briefed that we have a secretariat, we have a technical appraisal committee, we have technical partners and resource centers, and the highest body being the Medical Technology Assessment Board. So briefly to tell us, Dr. Peter had already told you what process is being followed internationally. India also follows the same process. We get topics from state and the central government. We identify which resource centers can take up the topic and develop a proposal for that. The proposal is being taken to the Technical Appraisal Committee in consultation with stakeholders. With the approval of the board, the recommendations go as a policy document for implementation by the user department. So this is the process under the Health Technology Assessment Program that we are following. Now, the procedure. We also follow a similar procedure where we compare the alternative technologies that are available in the same platform. We identify the efficacy, the effectiveness of that particular technology. Dr. Peter also mentioned that there is a limitations for the evidences that are available. India also faces a lot of challenge in that point. So we also consider the budget impact analysis that technology will have on the value for money that the government has allocated for the healthcare centers. So we have a choice between two technologies. We identify the equity, the legal, and also the social considerations which back up a technology when it is going to be implemented, either in a primary sector or in a tertiary sector. So the HTA has the responsibility to collect, analyze data. We present our findings as a transparent and clear demarcated recommendations. We address the research question that is being asked by the user department because they are the implementation people. We ensure that the assessment is guided by technically sound advised experts in consultation with the board and the technical appraisal committee. We respect the time frame because this is how the decision makers would like to be implemented in the healthcare sector. We follow up with the decision makers on the findings and also arrive at a conclusion in the place where it is going to be implemented. The progress that we have made till date and where the current status of HTA is, we have about 16 resource centers and 10 technical partners. We support the central and the state government and also support the National List of Essential Diagnostics, have completed 20 studies. There are 34 studies that are ongoing. We have a multicentric study which supports the Iapsmcon Bharat package, which I'm going to elaborate. So this is the costing study of healthcare services in India. This was initiated in 15 states. This is the largest costing healthcare study in the country, which is being spearheaded by PGI Chandigarh. We have 15 tertiary hospitals sampled in this, 30 district hospitals sampled in this, 40 private hospitals sampled in this. As the first phase of costing study, we have completed the tertiary care centers with 855 packages, which supported the largest health benefit package program called as the Ayushman Bharat Pradhan Mantri Jan Arogya Shri program. So we helped in revising the packages also, and we also helped them in establishing the packages. So this is how the largest costing healthcare study has been supporting benefit packages, devising and designing in India. Now, how do HTA support in improving healthcare? Dr. Peter also mentioned that we have safety engineered syringes, but we also have programs where we support viral hepatitis control program where safety engineered syringes have become a part of the guidelines. There were states which adopted the HTA and they issued government orders that all the private and public sectors should have safety engineered syringes in place. Now, we also help in priority setting, designing programs. So there was a program which was running for screening cervical cancer program in India. We supported and identified which will be the most cost effective. We identified the visual inspection with acetic acid every 5 years will be most cost effective. And this has been recommended in the operational guidelines for National Program for Prevention and Control for Cancer and Diabetes. We continued this and we said screening for hepatitis B and C at primary healthcare center should be very cost effective, which was being a user department provided from the Tamil Nadu. We are undertaking study for screening of breast cancer. We are also completed a study where said the population-based screening for type 2 diabetes and hypertension in India should go simultaneously instead of going separately. And this would be a cost-effective model for the country. We went into point of care facilities. When health and wellness centers were being rolled out, we said what will be the point of care facilities that will be a part of the health and care facilities. There was also being topics which had come from Tamil Nadu which said keep blood counters for diagnosis for dengue. If they are going to be placed in the primary healthcare center, will it be a cost-effective technology? The other topics that have been undertaken are sickle scan, a point of care technology for screening sickle scan anemia, evaluation of pulse oximeters which could be treated for pneumonia if they are going to be placed in the primary healthcare centers, a portable ECG facility, if that is going to be placed in a primary healthcare center, will it gain cost when it's going to be taking care of treatment that is going to be followed by the primary diagnosis? Urine check analyzers, if they are going to be placed as primary point of care devices in the health and care facilities, will they be able to identify what is the antibiotic sensitivity and followed by antibiotic treatment for that? Validation of digital hemoglobinometers compared with the gold standard of Sally's spectrophotometer. This was being done, approved by the board, and this has been implemented in the health and wellness centers. Standard treatment workflows, which was being identified and devised by ICMR. There were a few topics which said when the standard treatment workflows or guidelines are going to be formulated, we need to identify what will be the role of PCI and CABG when it is going to treat single vessel and multiple vessel diseases. Will it have a hand over the OMT, the medical treatment that is going to be followed with it, or that is going to be followed prior to this or followed post to it? Use of pacemakers for complete heart block. What kind of pacemakers have to be designed? What of pacemakers have to be developed? What will be the stage when pacemakers have to be identified and implemented? Intraocular lenses for cataract surgery. If it is a simple intraocular surgery which is going to be diverted by laser treatment or by manual treatment, what will be the kind of lasers that is going to be used? What will be the kind of lenses that is going to be used in that? Uterine balloon tamponade for the management of postpartum hemorrhage. There are varieties of uterine balloon tamponades available, but the one that we identified was a condom-based balloon tamponade that has already been available in primary health centers that can be used to manage postpartum hemorrhage along with treatment. So we are also looking at intravenous treatment of tranexamic acid for postpartum hemorrhage. Diagnostic and screening devices. So TB program was being floated with the gene experts of CBNAT that were being explored and that was being used for diagnosis of TB. TrueNAT was an indigenous device that was being made. We identified that TrueNAT was much better. It gave a cost gaining and that can be supplemented, not supplemented along with the gene experts that are being rolled out for the TB program. RT-PCR kits were being developed for identifying H1N1 pandemic that happened, an epidemic that happened in India. Variety of kits were being formulated in India. We identified which could be the best cost-effective kit and efficient kit that can be rolled out as the program, as a part of the program. Portable automated auditory brainstem response, neonatal screening devices. We had the BERA, which is the gold standard device, but we identified that there was a indigenous device that was being developed called as the SOHUM. This device rolled over or gained over the BERA technique because that required a vacuum-based auditory system. This system ruled, it had a clinical efficacy. We had collected real-world data for identifying and studying SOHUM. The other technologies that were taken are automatic detection of diabetic retinopathy. The study is underway. Drugs, price regulation, value-based pricing for anti-cancer drugs. Drug prices were reduced. We have identified 40 drugs. Even after the reduction of price, we want to see whether they are cost-effective and rolled out in different sectors, whether these drugs are available in the effective prices. Iron therapy, sucrose and iron therapy for management of anemia for pregnant women. This is a program that was rolled out by Gujarat. We are studying the cost effectiveness of the rolled out program. Intravenous tranexamic acid, as I said, for postpartum hemorrhage. Health benefit packages. So we are supporting the revision. We supported the revision of packages for Iapsmcon Bharat. This we are extending for revising the packages in Meghalaya and Manipur. We are also looking at the cost of a program called as the Janani Shishu Suraksha Kalyan, a program that has been rolled out by the Ministry of Health to identify the cost that is being rolled out and the cost that we can gain if the program is going to be rolled out in a different manner. Price regulation and procurement. As already told by Dr. Peter, we had the safety engineered syringes. While doing the safety engineered syringes, we identified that the cost was very high. So the study conducted by PGI Chandigarh said that if it is rolled out below a threshold value, it will be a cost effective and a cost gain technology for India. Life cost analysis. We have a GFR that is being the Bible like, which is used for financial regulations in India. The Rule 136 itself says that when we are procuring new equipments or equipments for diagnostic, for treatment, we can do a life cost analysis. The same thing was done for the Roche machines, which were used for the diagnosis of SARS-CoV-2. We compared it with the RT-PCR testing strategies, and this was used for procurement of Roche machines in India. The largest study, 12 countries are already having the EQ5D, 5L value sets. India also said that we should also be doing this. We have done the biggest study with the 2,700 samples. Again, PGI Chandigarh with Dr. Shankar spearheaded the study. We have done it in state, district, PSU, household, and individual wise. The study has been completed, and then now we have a value set for India.
I request you, Dr. Kavita, to please wrap up. Thank you.
Yeah, we are just wrapping it up. So the significance of this is that we are using it for new and existing technologies for universal health coverage and standard treatment guidelines. This is the policy documents that we prepare after a study has been completed. We have a manual that we have devised for the technology assessment programs. Last but not the least, for the way forward, we have a legislative board bill that has been drafted and it is under consideration, and all ministries have supported us. Now we'll be taking it forward. Thank you so much for this opportunity to showcase what STA has been doing and how we can support new and programs, drugs, interventions, cost-effective technologies that can be used to save budget and money for India. Thank you so much.
Thank you very much, Dr. Kavita, for that such a illuminating and well-informative talk on describing the entire gamut of the initiatives that the HTA agency in India is undertaking. And I think it resonates a lot with what Peter Baker also mentioned about the kind of directions that HTA agencies should be taken in trying to prioritize the public health programs besides just drugs and diagnostics and other things. I think one of the key criteria for priority setting in India, besides cost, besides efficiency, is consideration of equity. And I think that there could be nobody better than Professor Richard Cookson to talk about this such an important issue of how to incorporate the importance of equity within our decision making. He's a professor at the Center for Health Economics and a co-director of the Equity in Health Policy Research Group. He has such a long list of accomplishments. He's been a co-chair for so many committees and has been a member of the Technical Appraisal Committee of the NICE in the UK. But one important thing that I would like to inform all the young students of public health and the young researchers and faculty members, more than 1,000 are currently logged in, is that he's written a very interesting book on distributional cost effectiveness analysis published by the Oxford University Press. I myself have read it and I've recommended it to a lot of my own students. So I think it'll be a pleasure to hear him speak. And I now request the organizers to start his video, pre-recorded video. Thank you.
Hello, I'm Richard Cookson from the University of York in England, and I'm here to talk to you about fairer decisions, better health, the role of distributional cost effectiveness analysis. So let me share my screen with you now. There we go. So it's a great honor to be invited to speak at this conference. And I've recently enjoyed working with an Indian colleague, Indrani Gupta from the Institute for Economic Growth in Delhi, And we wrote with other colleagues this paper in the Lancet about inequality in healthcare globally. And we actually compared England and India in this paper. And there's a lot of information about international healthcare inequality. So that's hopefully of interest to you by way of background. And clearly, India has got very high healthcare inequalities and also a very high share of private expenditure in international context. And so I imagine in coming decades, probably you'll start spending more on public healthcare. That's the trend throughout the world as we move towards universal health coverage. And on that path, there are very tough decisions to be made, and you need good evidence for doing that. And what this talk is all about is getting better evidence about the equity or the health inequality impacts of decisions as we move towards universal coverage. So at the moment, decision makers tend to see the world like this. They look at averages, average costs, average benefits, average health outcomes, average quality. Everything is averages when you're actually making a decision at a high board level of an organization. Occasionally there are reports that tell you about health inequalities, but the actual evidence shown for when you're making a decision is all about averages. And what distributional analysis is all about is splitting that distribution of averages into equity distributions, into the rainbow of equity distributions by socioeconomic status, by ethnicity, by gender, by whatever variables are of importance in the decision-making context. And the idea that is, if decision makers have information about who gains and who loses from their decisions, they can make fairer decisions, as well as improving average health. So distributional cost effectiveness analysis is about adding that equity dimension to cost effectiveness analysis. Cost effectiveness analysis just looks at efficiency in terms of total costs and effects, whereas distributional analysis looks at equity in the distribution of costs and effects. And it does so by all sorts of different variables. Often it's socioeconomic, wealth, but also it can be ethnicity, geographical location, and various other variables, depending on what's important. And it can be applied to all sorts of different kinds of decision in health and indeed in social policy. So, whether to fund a particular cancer drug, how to prioritize COVID vaccination, how to prioritize medical workforce investments, whether to introduce a sugar tax, and so on. There's all sorts of decisions that are being made all the time, and we want to know who gains and who loses from different decisions, different ways of designing healthcare programs. So the basic idea of distributional cost effectiveness analysis is this equity, efficiency, impact plane. On the vertical axis, we have the efficiency impact, let's say the total population health benefit of a program. And on the horizontal axis, you've got the equity impact, which is usually thought of as the health inequality reduction or increase. So on the right-hand side, you've got a reduction in health inequality. That's what we're aiming for. On the left-hand side, you've got an increase in health inequality. That's a bad thing. And the idea is that some policies are win-win. They're good for both efficiency and equity. But some policies are in the trade-off quadrant. Some policies are cost-effective. They improve population health, but they harm health inequality. That's in this quadrant. And the other way around. Some policies are not cost-effective, but they might reduce health inequality. They might be good for equity. And so we have trade-offs. And so distributional analysis, as well as providing information about who gains and who loses, also has ways of making these trade-offs, of thinking about how we trade off efficiency and equity. Here's an example of how we apply this in practice. This is in the UK. We've applied distributional analysis to all sorts of public health programs recommended by the National Institute of Health and Clinical Excellence in the UK. And we plotted them here. Most of them were win-win, but there were quite a few that were cost-effective, but were actually harming health inequality. And so the question is then, can you redesign these programs to shift them closer to the win-win quadrant? So I just want to talk a little bit about principles of equity. So there's lots of different ways of thinking about equity and justice, which are valid, and distributional analysis only looks at one way of thinking about equity, which is the value maximizing approach, which is where we're interested in maximizing benefit of policies, and we're also interested in reducing the inequality. And sometimes we can trade those two things off, and then we're aiming to maximize social welfare. But there are other ways of thinking about equity which are related to but different from this. So, for example, the moral rights way of thinking, which is about individual rights to autonomy, to be treated with dignity, and so on. And there's the fair shares way of thinking, which is that you spread money out and resources out so that everyone has at least some of what they need. Whereas the value maximizing approach is a bit more binary in its way of thinking. It might give all the resource to the person who needs it most or who benefits most. And finally, there's obviously the fair process way of thinking, impartial, democratically accountable, and so on and so forth. There's various virtues of a good process for decision making, which, if you follow the fair process, then the outcome must be fair. But the value maximizing approach and the distributional analysis approach is very much focusing on health outcomes and the fairness of those outcomes, the inequality in those outcomes. So it's a slightly different way of thinking about justice. And we need all four of these ways of thinking, right? There's all sorts of ways of thinking. We need to bear in mind all of them. And just to give you another example of how ways of thinking differ, we can distinguish between concern for health inequality and concern for the rule of rescue, or concern for people who are currently in ill health and in peril, which may not necessarily reduce health inequality. And let me give you an example of that. Is it fairer to prioritize a new drug for late stage skin cancer, or is it fairer to prioritize postnatal home visits? Now, people with late stage skin cancer are badly off in terms of current health. They've got very short life expectancy and they've got severe morbidity. So you could say it's fairer to prioritize them. That's the rule of rescue way of thinking. Or if from a health inequality perspective, it's the other way around. Babies with poor postnatal care are worse off in lifetime health with a below average expected length of life and below average expected social status as they grow up. And skin cancer deaths tend to occur in older people with above average social status. So prioritizing skin cancer treatments will not reduce health inequality, although it will respect the rule of rescue. So there's a difference between these two principles of justice, and we have to balance and think about these two different principles. They're clearly different. Now, the equity methods of distribution analysis generally focus on the health inequality way of thinking. And let me give you an example of how that can be done. Basically, we need to measure the baseline distribution, the baseline health inequality. Then we need to measure the distribution of benefits of a program. Then we need to measure the distribution of opportunity costs of the program. And then we put all that together and we find the final distribution. And then once you've done that analysis of distributions, then you can think about trade-offs, you can evaluate them. There's various ways of evaluating them. Now, the crucial aspect of evaluating the distribution of benefits and opportunity costs is to think about the staircase of inequality, because inequality emerges at various steps in the patient pathway. Firstly, we've got social differences in the eligible population for a program, differences in prevalence of disease, basically. Then you've got differences in the uptake of the program. Who is going to get this intervention? Then you've got differences in the effectiveness. Once you've delivered the intervention, how effective is it? Now, the example I'm going to give is a smoking cessation program. So the effectiveness may depend crucially on whether you continue taking your smoking cessation, whether you put the patch on and keep it on and follow the program. And then finally, you've got social differences in opportunity costs. Where is the money coming from for this program? What other programs or other activities will not be funded? And that opportunity cost may have a social distribution. If you take money out of one kind of budget, one kind of program, that will have a different distribution of opportunity costs than if you take it out of, let's say, general taxation or defense spending or some other kind of pot. So very important to know where the money's coming from, what are the opportunity costs of the program, if you want to think about equity impacts. So I'm going to rush through this. Here's the smoking cessation example. This is an example from England. Do you subsidize smoking cessation or not? And if you do subsidize it, do you put more effort in locating smoking cessation clinics in disadvantaged areas? Do you make a special effort to reach disadvantaged communities or not? And when we analysed this, we found that in England, the benefits accrued mostly to the north of England and poorer groups, just because smoking prevalence is so much higher in the socioeconomically deprived communities in England. And we did find that there was a trade-off between the standard universal way of funding this and what we call the proportional universal way of funding and delivering it, which is where you make extra effort in disadvantaged communities. The proportional approach was less cost effective. It didn't generate such large health gains, but it was fairer. It distributed it made sure that uptake was higher in disadvantaged communities. So you've got a trade-off. And then you can think about that trade-off and you can analyze it, and basically you've got to think of the inequality aversion parameter, which tells you how much you care about reducing health inequality versus improving health. And what we found was that if you have a reasonably high level of concern for reducing health inequality, then you will favor the proportional universal approach. But if you don't care at all about reducing health inequality, if your parameter is 0, then you will stick with the standard universal approach. And we leave it up to the decision maker how much they care about reducing health inequality. That's a value judgment. But we can show you, given how much you care, then we can show you what the best policy would be. So that's basically what distribution analysis does. It provides you evidence and allows the decision maker to make their own value judgments. We're doing a course in the details of this, a web course, so there's the date for that. And there's a book which shows you how to use these methods, and there are spreadsheet training exercises freely available, so you can self-learn for doing this. And I'm really pleased that you've let me speak about this. I'm really pleased that there's a new HTA agency in India just being developed now, and I'm delighted to see they are starting to do some simple forms of distribution analysis already, which is very encouraging. So I'm really pleased that this is moving forward. And hopefully in 5-10 years' time, this kind of analysis will be done much more regularly and decisions will be moving in a fairer direction. We've seen the COVID pandemic lay bare inequalities. So, this is the time to start focusing on equity and getting better evidence about it. All right, thanks very much.
Thanks very much, Professor Richard. I think that's been an extremely illuminating talk, and I'm sure there are a lot of questions coming in, but I'll try to hold those questions up for the final discussion. And I now move on to our final speaker, Dr. Nidhi Gupta, whom we wanted to introduce because we wanted to have a clinician's perspective as well. And because ultimately we might be the generators of evidence, but ultimately it has to be used for either clinical decision making or policy. So I would like to introduce her, who's an oncologist, a radiation oncologist with specific interests on breast and gynecological malignancies. But she has strong interest in use of HTA for informing clinical decision making, and we've been recently collaborating on certain studies for determining cost effectiveness of anti-cancer drugs. So without further ado, I'll pass it on to Dr. Nidhi, who has a pre-recorded talk, which I'll request the organizers to start up. Thank you.
First of all, I'd like to thank the organizers for giving me an opportunity to deliver a talk in this Iapsmcon conference. Today, I'm going to speak on the topic HTA from a clinician's perspective. First of all, I'm going to give you the example of a few drugs which are used in the management of breast cancer as an illustration of how HTA can be used for clinical decision making. Next, we are going to discuss how the views differ drastically between a clinician and the administrator, why these views differ, and what are the challenges in incorporating HTA for clinical decision making. Towards the end, we are going to look at what is the way forward and what are the possible solutions we can offer for these challenges. Now, these are the NCCN guidelines 2021 for the management of invasive breast cancer. They guide us about the adjuvant endocrine therapy. These guidelines are based upon the clinical effectiveness data and based upon the level of evidence they are given the various categories. So level 1 evidence is equated as category 1. Now if we look at the guidelines for the management of postmenopausal women with breast cancer, the endocrine therapy recommended includes aromatase inhibitors for 5 years, a switch therapy consisting of a combination of aromatase inhibitors and tamoxifen for 5 years or tamoxifen for 5 years. All of these are category 1. There are multiple other options, all of which are category 1. So what I want to emphasize is that majority of the guidelines will give you multiple options to deal with a clinical situation and they will not pin you down to one particular option. Similarly, we have the ICMR guidelines for the management of the systemic therapy in the breast cancer patients. Now these guidelines say that along with the chemotherapy, we should use adjuvant trastuzumab for HER2 positive patients. This trastuzumab is an expensive molecule. Now the guidelines recommend that this trastuzumab can be used for 1 year. Alternately, it can also be used for 9 to 12 weeks as an acceptable alternative, or sometimes when it is not feasible to use trastuzumab, we can only give chemotherapy without trastuzumab. Now, so sometimes when we have multiple options for dealing with the same situation, HTA evidence can help in clinical decision making by showing the superiority of one particular regimen over the other. This is a study which we conducted on the endocrine therapy in breast cancer patients. Here we compared 3 arms, 5 years of aromatase inhibitors, 5 years of tamoxifen and 5 years of switch therapy. At the end of our analysis, we plotted our results on this cost effectiveness plane. On the y-axis was the incremental cost incurred with respect to the comparator. As we go up the axis, the incremental cost increases. As we go down the axis, the incremental cost decreases. On the x-axis is the health benefits gained in terms of QALYs. So if we go to the right, we are gaining QALYs. If we go to the left, we are losing QALYs. So when we plotted our results on this cost effectiveness plane, here the grey scatter plot represents the comparison of 5 years of switch therapy with 5 years of tamoxifen, and the blue scatter plot represents comparison of 5 years of aromatase inhibitors with 5 years of tamoxifen. So what we can see is that clearly 5 years of aromatase inhibitors and 5 years of switch are dominant strategies over 5 years of tamoxifen alone because they give us better health benefits at a lower cost. So we will say that 5 years of tamoxifen alone should not be used in the management of breast cancer. Within the two, we can see that 5 years of switch appears to be more cost effective, keeping in mind the threshold for cost effectiveness in India. So it gives us certain recommendations for standard treatment guidelines for the adjuvant endocrine therapy in women with breast cancer. Similarly, we did another study on the cost effectiveness of trastuzumab for the management of breast cancer in India. Here we compared the longer duration of 1 year with the shorter duration for 9 weeks. And what we found was that the shorter duration of 9 weeks was cost effective as compared to 1 year of trastuzumab. Though 1 year of trastuzumab gives us greater health benefits, but the additional cost incurred with 1 year of trastuzumab is not justified given the threshold for cost effectiveness in India. Now here comes the conflict. When I discuss the HTA evidence with my clinician colleagues, for example, if I try to explain them that 1 year of trastuzumab is not cost effective irrespective of the greater health benefits it gives, then at the end of this clinical discussion, my clinical colleagues just ask me one simple question: so what? That is to say, how can you deny a longer duration of a drug for an individual patient when it is associated with a longer survival? Now this happens because while an administrator thinks at the health benefits gained at the population level with the money being spent, but a clinician is only concerned with the survival curves. That is, a clinician concerns himself with giving the best possible survival with the best possible treatment to an individual patient. And I will say that the clinician is not completely wrong in doing so because we operate in a multi-payer system. Now what happens in a multi-payer system is that the decisions about the clinical management are taken based on a mutual discussion between the clinician and the patient. Here the clinician explains to the patient the multiple options which are available for a particular situation. And the clinician discusses with the patient the risk-benefit ratio, that is, the benefit incurred in terms of the survival gained and the risk, that is, the adverse effects associated with that particular treatment. The clinician also discusses the cost associated with these treatments, and then based upon the paying ability of the patient chooses a particular treatment. Now, what the clinician does not discuss with the patient is the cost-benefit ratio. Though the current system of health financing has led to this multi-payer system, I will say that this is not a very healthy system. This is because it leads to a lot of unmet needs even for necessary care. Being diagnosed with HER2-positive breast cancer is not an option. So getting an optimal treatment for HER2-positive breast cancer should also not be an option. While the guidelines continue to recommend 1 year of adjuvant trastuzumab, the fact remains that in India, only 8% of the patients are able to get this drug for 1 year. And out of these 8%, 50% of the patients are enrolled in some form of clinical trials where they get the drug free. So practically, only 4% of the patients in the country are able to afford 1 year of trastuzumab. So we can see that the poorest are the hardest hit in terms of the unmet needs. And this leads to further inequities in the utilization of the health services. Now, besides the multi-payer system, the other problem which we face in implementing HTA for clinical decision making is that the process of clinical decision making is very complex. Now, on my slide, you can see a network map. It gives us all the options which are used in the management of a metastatic hormone receptor positive breast cancer. And this is just one of the situations in the entire clinical spectrum of breast cancer. You can have multiple such situations. For example, hormone receptor positive breast cancer, hormone receptor negative breast cancer, HER2 positive breast cancer, HER2 negative breast cancer, triple negative breast cancer. What is the stage of the disease? What is the histology of the disease? What is the performance status of the patient, and so on. So as to say that you have n number of situations and you have n number of options to deal with these situations. So when I look up for evidence in the literature, I do find ample clinical effectiveness evidence for all of these situations. But when I look for the HTA evidence, I hardly find anything. So can the HTA evidence match with the clinical requirements? So what is the way forward? One is that we need a single payer system. And the best option available right now is the Iapsmcon Bharat Pradhan Mantri Jan Arogya Yojana, which can help in the uptake of the HTA evidence in the country. The packages of care which are formed within the Iapsmcon Bharat should be based on the HTA evidence. Once this is done, then the money which is given to the providers should be based on the standard treatment guidelines which have been framed using this HTA evidence. Finally, when we reimburse the providers, then it should be dependent on whether this standard treatment guidelines have been adhered to by the providers. Lastly, if we really want the HTA to be the prime driver of clinical decision making, then the rate at which the HTA evidence is being generated in the country should be paced up to match with the clinical situations. Thank you. Good morning, everyone. First of all, I'd like to
So thank you very much, Dr. Nidhi. I think you've raised very interesting questions, especially for our discussion. I know we've come to the time has come up, but if the chair permits us to go for 10 more minutes extra, I'm sure that there are questions in the chat box which I'd like to pose to some of the panelists. If you agree, then I'll just go a little further. Thank you very much. So I think that we're very well set with the four sets of presentations. We heard about the global scenario. We heard about the Indian developments. We've talked about the how to go a little further and start to think not just in terms of cost effectiveness, but also trying to link the important question of equity, which is absolutely central to our discussions in India. I mean, we have when the HTA discussions were taking place in the beginning, I remember that there were 3 important criteria that were set to be guiding principles for decisions or recommendations. The first was value for money. The second was the extent of reduction in out-of-pocket expenditures. And the third was how much newer interventions are able to improve equity in utilization of healthcare services. So by all means, I think we are very much in principle in agreement to trying to incorporate the principles of equity in our assessments. The only thing is that how well we are able to manage the methods also as well and apply them to inform our decisions is something that needs to be seen. But I think one of the key questions that came up much towards the end of the discussion was that what needs to be done in order to further link this evidence with decisions around policy. And that is also, I mean, grounded in the context of where we are in Indian scene, especially with regards to where we are in terms of our journey of universal health coverage. So we are at pretty much lower level, low spending, low coverage of some of the even more cost-effective interventions. And there are relatively weaker institutional frameworks to link this evidence to policy. So within this context, my question to both our international experts, Pete Baker and Richard Cookson, would be, what could be your suggestions in terms of so we have 2 important stakeholders, perhaps the most important in India for taking forward the HTA. I mean, they are representatives of the HTA agency. What would be your recommendations to sort of go over the next 3 or 4 years? What should be the important things that should be leveraged to ensure that A, decision making is transparent and fair, and B, the decisions actually get used for policy? I mean, the evidence does get used for policy. Maybe I'll start with Pete first and then Richard.
Thank you, Dr. Shankar. It's an excellent and challenging question. So I propose, I guess, one of the key areas is to get the topic selection right. If you make sure that you're addressing questions that are of key priorities to the decision makers, then and you're doing the analysis that is well designed to meet that topic, then you're more likely to get buy-in from them and them to utilize that answer in their procurement or purchasing decisions. Institutionally as well, I don't know the details at the kind of the national level and at the state level and so on, but building the decision makers into the institutions such as HTIN so that they can help shape it, they can help understand it, they can be integrated with it, will encourage their use of it. But finally, I think having some clearer criteria on how you make a decision is needed. My understanding is that there isn't a threshold, for instance, yet in the Indian context, which and I understand, Dr. Shankar, you're working on some of this, and that kind of clarity can help, being a bit clearer on when you say yes and when you say no. It is a very difficult area and very difficult. There are very few countries that have managed it. But perhaps one first step I was thinking, based on the presentation today, would be to look at which decisions, which analysis have led to a yes decision and which ones have led to a no decision, and look at kind of what was the cost effectiveness level of those analyses and those interventions, and begin to form a kind of database or a review of previous decisions and consider why they resulted in a yes and why they resulted in a no. I haven't seen that many no's, for instance, today, and I'd be quite interested to know whether there are many. But once you've collected all your yeses and no's together, you might get a picture of what the criteria are, and you might want to add some additional criteria, such as Richard's equity analysis, that might encourage you to then go on and do more analysis such as that. Dr. Shankar, do I have time to look at some of the questions in the chat box, or should I move on?
Yeah, I think you made an excellent point, the last one, where you said that looking at what works in terms of making evidence to policy and what are the criteria that people used. And actually, this is something that the DHR and Dr. Kavita has recently asked us to undertake a study in order to look at the HTS that have already been done to assess the extent of quality that they've been able to perform at, and then have a discussion around with stakeholders and trying to see that what factors led to uptake of that evidence, and what were those factors that really did not lead to an uptake of that evidence. So I mean, I think your point is absolutely spot on, and I think DHR is absolutely working on that point. I'm happy for you to take a look at the chat box and answer a question or two if you want before I move to Richard.
Okay, just a few quick points, I guess. The first question was on private sector, and there's no reason that HTA can't be fully used in the private sector. It applies to any major decision maker or funder, and a private sector health system would be totally fine to use the HTA approach. Traditionally, it's not been done very much around the world. It would be great if the US had led the way in this, but they haven't, sadly. South Africa and Discovery Health have done some of this. Perhaps there's just a problem of scale here. Each private sector insurer doesn't particularly want to do the analysis separately. So but if they got together, there's no reason it couldn't inform private provision. And then on out-of-pocket payments, so HTA should very much look at that. It should look at financial protection, but it might interest the audience and the panel to think about some areas where there are trade-offs here too. Sometimes financial protection and efficiency of health production, as it were, don't fall along the same lines. And I think dialysis is one of the clearest examples of this, where probably in lots of countries dialysis is not cost-effective or marginally cost-effective. But yet it may well be justified, because if you do not provide it, there are catastrophic health expenditure costs that tend to fall on people. So there are some difficult trade-offs there around financial protection versus efficiency sometimes. But I'll leave it there. Thanks.
Sure. Thanks very much, Peter. Richard, your reflections on the set of questions that you can see.
Thank you very much. And I thought that Dr. Gupta's talk about this was very illuminating, and she put her finger on exactly the problems. And I think in the chat box, the question about multi-payer system is the big question. And because in principle, cost effectiveness depends on the payer completely. So there's no one cost effective or not. It's cost effective for this payer, not for that payer. So it's very complicated. And so topic selection and also payer selection is really important. Who are you trying to advise? And I mean, I don't know the Indian system, but what Dr. Gupta was suggesting seems very sensible to me. Focus on the big payers in big regions that do cover wide populations, and try to make useful, get the quick wins here, make some useful HTA advice that will actually get traction. Because HTA worldwide was designed in the single payer context. So, we have to recognize that. And if you want to use it in a multi-payer context, there will have to be adaptations and creative new ways of doing it. But I mean, it's all possible. I mean, basically the problem is finding useful evidence for the relevant decision makers. So I'm sure there are ways of doing it. And one other reflection is about the private role. I mean, absolutely right. I mean, and as Dr. Gupta pointed out, if you're paying privately, you don't care about the cost effect. You just want the best, most effective. So, it's not going to be directly useful for an individual patient paying out of pocket. Of course, it's not. But I think the point is, gradually, India will start paying more publicly. You're going to move, I mean, there's a lot of attempts to move towards universal health coverage. I know that sometimes things are called universal, and they're not really, and they're very feeble and not very generous systems of universal. But nevertheless, there will be a trend towards more public spending. And to be honest, I think HTA is mostly about spending that money wisely to get the most health benefit, the biggest reduction in health inequality, and the biggest improvement in financial protection. So really, the answer to the question, how can HTA help in a country where most spending is private? The answer is it can help when you do start spending public money. You can spend that really well. That's the answer there.
Thanks, Richard. I think we are very much closing in on time. So I'll now hand over to Madam Anu Nagar with my final comment, and for her to make the closing comment actually, but with a final comment from my side that the discussions that have taken place have actually highlighted the role that the HTIN and the DHR needs to play in order to possibly also engage with a set of these actors like the NHA and like the regulatory agencies like the Pharmaceutical Pricing Authority. Perhaps I think there needs to be an office of the HTIN even housed there as well to make sure that they are nudged to make use of the evidence that is generated here. So with that comment, maybe I'll hand it over to you, madam, for making the final comments. You're on mute. You'll have to unmute. Thank you.
Thank you, Dr. Shankar, and I totally agree with you that there has to be more awareness about HTA in the policymakers, and this fact was also highlighted in our recent MTAB meeting, where we are going to take up this issue with the pharmaceutical department and the health department, and also try to convince the finance department when we talk about the bill that we are going to shortly introduce, that this kind of intervention would actually save money, and this money can be put for better use, maybe in the health sector or otherwise. So this thought has to actually go deep into our policy planners, and we are working towards that end. And I also take the suggestion of Dr. Peter that we have to be very careful about our topic selection, because we are just beginning in our HTA framework, and we need to be very judicious about starting selecting the topics, because we should be actually taking those topics right now which actually make an impact. Earlier, we were taking topics as in when they came, because we had just started and we were not so particular about them, but that aspect is very important. Dr. Nidhi's presentation has been an eye opener, and I thank you for that. And taking Dr. Cookson's view, so equity concerns have to be addressed when we are talking about standard treatment frameworks, and we are totally open to revising our STWs or revising whatever studies that we have undertaken. We would definitely do that. And I would say that HTA is an uphill journey that we have started, but we are determined to reach the top. And with cooperation from all of you, from national partners and international partners, we are definitely going to achieve what we've thought for. That is all from my side. Thank you, Dr. Shankar.
Thank you very much, Madam. And I think it's been a wonderful panel, wonderful set of presentations, and the thought-provoking conclusions that we come up with. So I'll close the session now, and with all the gratitude to all the chairs and the speakers. You're more than welcome to please stay back for the rest of the sessions, but we'll have a small break right now in our conference for the lunch, and thereafter we'll resume. We'll resume at 2:30, about 45 minutes from now. Thank you very much.
Thank you.
Thank you, Dr. Shankar.
integrates with your existing microscope to enable dynamic time-lapse experiments never before possible. Achieve optimized bio-inspired cell culture with Solasic Onyx microfluidic plates. Choose from a variety of application-specific plates that give you superior control over the cell culture microenvironment. Reagents and media are added to wells on the left. Cells are observed in culture chambers, and waste flows out for collection on the right. There are 4 independent rows of wells addressing the corresponding culture chambers. You can simultaneously collect data from up to 4 experiments with conditions that you can set yourself. Adherent or suspension cells are added directly to the 4-cell inlets prior to starting the experiment. Capillary-driven cell loading automatically loads cells into the cell culture chambers in a gentle, well-distributed manner. After loading, the plate may be incubated to allow cell seeding. Once medium is loaded, individual microchannels connect each solution to the cell culture chambers in the center imaging area of the microfluidic plate. The Solasic Onyx microfluidic system gives you the control you need to discover new science. The system creates a vacuum seal with Solasic Onyx microfluidic plates and allows hands-free changes to perfusion, temperature, and gas environment. The system uses positive pneumatic air pressure to control perfusion in the microfluidic plate. The manifold connects the control system to the plates and is easy to adapt to any inverted microscope stage. The Solasic Onyx FG software is intuitive and easy to use. First, choose the appropriate microfluidic plate type. Program simple protocols with a few clicks of the mouse and adjust flow rates easily during your experiment. In manual operation mode, you can quickly set your media conditions, flow rate, and temperature. Or create an automated protocol by choosing sequence, duration, and flow rates for more complex experiments. For each step in your protocol, click to specify the solution well, flow rate, and duration. In this example, we create a protocol with multiple solution changes at specified time points. For even greater flexibility, revise your created protocol or design your own with a few simple commands. Click Run and move on to other work while the system automates your experiment. Control perturbations to your cells at different flow rates with multiple reagents at even and consistent distribution. Media or drug changes can occur within seconds, while cell responses to stimuli are observed with time-lapse microscopy. Conduct live cell imaging for up to 3 days while cell health is maintained. Take control and design dynamic experiments using the Solasic Onyx microfluidic platform.
Hello, I'm Ken Schweeder. I'm a Global Product Manager in Emerging Chemical Synthesis here at Merck, or MilliporeSigma in the US and Canada. For today's virtual seminar, I'm going to discuss our offering in photoredox catalysis. Before we jump into the topic at hand, first want to give an overview of innovation that we're focusing on to accelerate drug discovery. So we have offerings in the lead discovery area, such as our off-the-shelf DNA encoder library, as well as in chemical biology with our protein degraders. We have a reaction design. We have our retrosynthetic software, Cynthia, Then today we're going to focus on the areas of small molecule synthesis and reaction platforms with the area of photoredox catalysis. So this short seminar will be broken down into 3 parts. The first we'll discuss the photocatalysts themselves. We have worked with many players in the field to develop a robust offering over the years. We will then move on to talk about our photoreactors, which we pride ourselves in having plug-and-play reactors that that have been designed to bring consistency and reproducibility to any photocatalytic reaction. And the last piece, arguably the most important, is the know-how content that we provide to beginners as well as experts. So jumping into the photocatalysts, and we have photocatalysts ranging from all different types. The classical iridium and ruthenium catalysts are strongly represented. We have over 50 combined of those 2 types. We then have some of the newer organocatalytic, or the organophotocatalysts, including some acridinium catalysts brought in from the Nishevitz lab, as well as beryllium phenoxazine catalyst brought in from Garrett Miyake's group, as well as some joiner acceptor catalysts. And as I mentioned, we source a lot of our innovation and work with, and through many collaborations, different professors throughout the world. So if you are interested in commercializing a photocatalyst, please don't hesitate to contact me. My contact information is shown on this slide. Moving on from the photocatalyst to the photoreactors, we have 3 different main reactors that all focus on different aspects of reaction design and optimization. So the first is our photocatalysis reactor focused on reaction screening. We then have the syn-led parallel photoreactor for reaction optimization. And lastly, the workhorse instrument is the PenPHD photoreactor M2. And an important thing to remember is that all of these reactors have been designed to bring consistency and reproducibility. So going into further detail with our screening reactor, it's the photocatalysis reactor. So as you can see here, we have it, the starter kit contains an LED controller allowing you to adjust the intensity of the light, and also comes with a 470 nanometer LED array. So it's a blue light source, and then the reaction block and screwdriver. The consumable part of this platform is our 24 catalyst plate. And so this is a general screening kit. You have a wide range of photocatalysts included, so some acridiniums, iridium, ruthenium, as well as a few other different types of catalysts. And each kit contains 2 plates and 4 different solvents for screening. The main features here, this is a microscale format. So the user is able to run 24 unique reactions using approximately 100 milligrams of their own substrate. As we mentioned, this has 24 pre-weighed catalysts. It's 0.1 millimole of each. And the LED controller allows for variable intensity. And there are 3 different LED arrays available, the 470 nanometer blue LED that comes with the starter kit. And then there's an add-on 527 nanometer green LED, as well as a white LED array. Moving on to our next photoreactor, we have the syn-led parallel photoreactor. This is a great reactor for reaction optimization as well as small library synthesis. So this features a 4x4 array of 16 1 to 2 dram vials, and then each slot is a 1 bottom lit LED. So these are blue LEDs with a wavelength range from 465 to 470. And then this reactor also has a built-in cooling fan to provide consistent temperature, approximately 30 degrees C. And this fits well onto a round ICA stir plate. The big selling point of this reactor is that it has a consistent temperature and light intensity to all 16 vials, allowing for, as I mentioned before, reaction optimization as well as library synthesis. Moving on to our third photoreactor, we have the PenPHD photoreactor. And this is our workhorse instrument. The scale ranges from GC vials all the way up to 40 ml vials. The modular design allows for a variety of wavelengths. So the instrument comes with a 450 nanometer light module, but a 365 nanometer and 420 nanometer light modules are also available. The 360 degree reflective environment is able to maximize photon capture. Other interesting aspects of this are the touchscreen, allowing easy user interface, as well as the different different parameters that the user is able to define. That includes temperature, intensity, fan speed, and stirring. And another interesting aspect of this is that coming later this year, our multi-vial holders. So the current version allows only one reaction at a time to be run, but the additional vial holders will allow up to 5 reactions to be run at one time in the photoreactor. And moving on to our last piece here, we have a number of resources available on our website. So the first and most powerful is our user guide. This is a approximately 50-page user guide written by experts in the field that focuses not only on reaction setup, but also on different theory, as well as many different types of reactions that can be run. The next is our photoredox catalysis hub here. So if you're interested to look at our full product offering or access any of this content we've talked about today, you can find that at sigmaaldrich.com/photocatalysis. And lastly is our technical spotlight, which goes over some of the background of photocatalysis, as well as detailed descriptions of our photoreactors, including a table that describes the differences between the 3 different photoreactors. Thank you for your time.
Cell culture almost always includes a step where cells are quantified. Whether the goal is propagation, cell health monitoring, or harvesting for experiments, it is almost always necessary to get an accurate count of cells from culture or primary tissue extraction. Hemocytometry has been used for decades, but is subject to errors in counting and calculation, not to mention that it's time-consuming and requires staining reagents that are often toxic. What if counting your cells was an efficient, integrated part of your cell passaging or collection protocol with culture counter precision?
Okay, so welcome everyone back to the oral presentation session. And it is my proud privilege to introduce the chairperson for the session, who is Dr. Rakesh Kakkar and Dr. Sendil Amudhan. I'm really fortunate to be making the introduction to Dr. Rakesh Kakkar, who is actually my senior. When I remember doing my graduate medical studies, Dr. Kakkar was the postgraduate student, and he was the one who took our examination as well. So it's a great pleasure to be introducing him. He is the professor and head of community medicine at AIIMS Mangalagiri, and also the medical superintendent at AIIMS. He's been awarded with the Presidential Award, Appreciation Award in the faculty category in 2018. He has several publications to his credit in both national and international journals. And he's also the editor of the IAPSM's textbook of community medicine. So the second, the co-chair for this session is Dr. Senthil Amudan, who's an additional professor of epidemiology at NIMHANS, Bangalore. His expertise is in mental health, stigma, child mental health. And he's also received the AIMS Excellence Research Award in 2014 and for his outstanding publication in the International Journal of Epidemiology. He's also received the BMJ Award for South Asia in 2016. So over to you, Professor Kakkad and Dr. Amudan. Sir, you are on mute.
Thank you, Dr. Shankar, for the introduction. Voice is clear?
Yes, yes.
So we are going to start a session on health economics. And I know that Dr. Shankar Prinza is well known for this topic. And in fact, we are thankful to all organizers for inviting us for this important session. As we know, health economic is a very complex issue, and it is especially important in current scenario where all the countries are struggling with financial crunch. And this is health economic is about how to effectively utilize the scarce resources in health. And also, it is also about the efficiency and effectiveness and value and behavior in the production and consumption of health and healthcare. It is uncertainty about uncertainty in intrinsic to health, both in patient outcome and financial concern. So in present scenario, with this COVID scare, this is very important. And whenever there is a gap between the demand side and supply side, then the pressure on health system always increases. So before starting, if Dr. Senthil want to add something to it, so then we will start the session.
Thank you, sir. Thank you. I thank Dr. Shankar for the introductions. I also thank the organizing committee for providing this opportunity. As without taking much time, as our chairperson said, that health economics and public health are very crucial for decision making and for how to allocate an efficient, equitable distribution of resources. And we have 5 speakers to deliberate on their experiential learnings. Without taking much time, I request our chairperson to start the presentation.
So, first of all, so Dr. Deepshika Sharma is the first speaker. She is going to speak on adherence to country-specific guidelines among economic evaluation undertaken in 3 high-income and middle-income countries, which is a systematic review. So I invite Dr. Deepshika Sharma.
Good morning, everyone. Myself, Dr. Deepshika Sharma, PhD Scholar, Department of Community Medicine and School of Public Health, PGMER, Chandigarh. Today, I'll be presenting my paper titled Adherence to Country-Specific Guidelines Among Economic Evaluations Undertaken in 3 High-Income and Middle-Income Countries, a Systematic Review. Introduction. Recently, there has been an upsurge in publication of economic evaluations globally. However, the methodological quality of economic evaluation is essential if they are to usefully inform health policy decision making. To standardize the methods of conduct of economic evaluation, several countries have formulated specific guidelines. The impact of such guidelines has not been widely evaluated. With this context, we undertook a systematic review to assess the adherence of economic evaluations on recommendations made in national guidelines for three countries: a high-income country, Canada; a upper-middle-income country, South Africa; and a low-middle-income country, Egypt. These three countries were selected from a list of 47 countries having national guidelines. Methodology. A systematic search was carried out in three databases from 1 year after the publication of the guideline to 31st December 2019. The search strategy combined terms for two keywords: firstly, type of economic evaluation, and secondly, the three countries. Two-stage screening, that is title abstract screening and full text screening, was done by two authors. The inclusion criteria were as follows. The study had to be a full economic evaluation, that is a study that compares both costs as well as consequences of at least two alternatives. The economic evaluation should have been undertaken in either of the three selected countries. Economic evaluations undertaken in other than these three countries were not included. The economic evaluation should be pertaining to health sector. Non-health sector economic evaluation were also not included. Lastly, there was no restriction on the language of publication. Data extraction. Data was extracted using a specifically designed sheet which was pilot tested on 10 studies. The final data extraction sheet had two sections. First, the general characteristics, in which data was extracted on title of the study, the year of publication, the funding source, the author affiliation and background, and the disease category. And secondly, the methodological characteristics, wherein data was extracted on principles of economic evaluation. Adherence to national guidelines was assessed using specifically designed adherence checklists. Three different checklists were designed for the three countries based on their national guidelines. Quality appraisal was done using Drummond's checklist. Data analysis. Descriptive analysis was done to calculate absolute and relative frequencies. Mean, quality, and adherence source was calculated. Correlation was assessed using Pearson correlation, and various independent categorical variables affecting adherence were tested using analysis of variance. Results. After screening close to 4,000 studies for Canada and South Africa and 1,395 studies for Egypt, we finally included 44 studies for Canada, 79 studies for South Africa, and 16 studies for Egypt. Type of economic evaluation. Majority of the studies in Canada and Egypt were cost utility analysis, while in South Africa, majority of the evaluations were cost effectiveness analysis. In Canada and South Africa, model-based analysis were predominantly undertaken, while in Egypt, trial-based analysis was undertaken. Author details. Lead author background. In Canada and Egypt, lead author was a clinician by background, while in South Africa, in 53% of the studies, the lead author was a public health professional. The involvement of foreign author was higher in South Africa in comparison to the other two countries. Diseases studied. Non-communicable diseases were most commonly studied in Canadian economic evaluation, while in South Africa and Egypt, communicable diseases were more commonly studied. Type of intervention evaluated. In Egypt, pharmaceutical interventions were most commonly evaluated, while in South Africa, programmatic interventions were evaluated. We can see in Canada, almost all type of interventions were evaluated, be it diagnostic, pharmaceutical, device, or programmatic. Coming on to the methodological characteristics of the studies, the pair perspective was the most commonly used perspective in all the three countries. The most commonly used comparator was the routinely used therapy across the three countries. For obtaining effectiveness data, observational studies were used in all the three countries. Measure of health outcome was most commonly quality adjusted life years in both Canada and Egypt, while in South Africa, the measure of health outcomes could be clinical endpoints that was most commonly used in 38% studies, and also life years and disability adjusted life years were used in 22 and 28% of the studies. The type of costs included. Direct costs were included in almost all 93% of the studies in Canada, 62% of the studies in South Africa, and 44% of the studies in Egypt. Discounting. The most commonly used discount rate was 1.5% in Canada and 3% in Egypt. In close to 25% of the studies, no discounting was done in Egypt. Both deterministic and probabilistic sensitivity analysis was undertaken in Canada and Egypt, while 25% of the studies did not undertake any type of sensitivity analysis in Egypt. Mean adherence and quality. Mean adherence was highest for studies undertaken in Canada and lowest for Egypt. Similarly, quality was also highest for Canada and lowest in Egypt. When the correlation was studied between quality and adherence, we could see that as the adherence increased, the quality of the studies also increased. The adherence was higher for principles such as comparator, the cost, and the perspective, while adherence was lower for time horizon and discounting. Factors affecting adherence, we found that if the lead author background was a health economist, the adherence was higher. And similarly, if the funding source was a national source, the adherence was higher. Adherence was also higher for pharmaceutical interventions in comparison to diagnostic and programmatic interventions. Conclusion, adherence was highest for Canada, followed by South Africa and Egypt, a finding in line with the stage of majority of health systems in these countries. Several key factors affecting adherence were identified, including source of funding, lead author background, and type of intervention. Creation of country-level institutional frameworks for funding economic evaluations was observed as a result of evidence from this study. Development of local researcher capacity with special focus on training in health economics should be done, and the study provides evidence for revision of existing guidelines and development of new guidelines. Thank you.
So, thank you, Dr. Deepshika. If
Thank you, sir.
I want to know what is the criteria for selecting these countries. Have you chosen these randomly or?
Yes, sir. So we actually prepared a list of countries which were listed in the global repositories for having national guidelines. And then we selected a list which was for only English language study. And then after that, we randomly selected one for each group of the countries.
And what was the objective of this study?
So basically, this is part of my PhD work where
You still some. What was the purpose? Hello.
Hello.
Yeah.
Sir, am I audible?
Yeah.
So this is a part of my PhD work where I'm trying to develop a reference case for India, that is a guideline for India. So first of all, I try to review all the other available guidelines for different countries. And then I checked adherence for 3 countries. So as to develop the principles and recommendations for Indian context.
Is there any question from other participants or audience?
So I don't think we have questions from the participants. I have 2 questions for Dr. Deepshika. Thank you, Dr. Deepshika, for your presentations. I have 2 questions. Have you registered your review in any of the registries? Can you hear me? Hello?
Sir, I was logged out. Can you please repeat your question?
Yeah. Have you registered your review in any registries?
Sir, this wasn't reviewed. The review wasn't registered, but sir, I have published a protocol.
Okay, good. What are the recommendations or the implications that you have for your country based on your review, the learnings that you had from the review? Hello.
Hello.
Deepshika, are you able to hear, and can you put on your video while you're responding?
Hello.
Yeah.
Sorry, sir.
Can I repeat the questions? What are the implications?
Yes.
What are the inferences or the recommendations that you have for our country based on the learnings that you had from your review?
So, sir, there are different principles of the economic evaluation.
I think there is
some connectivity. Should be okay.
I think there is some problem at her end.
No problem. We will go for the next presentation.
Yeah, we can go for the next presenter. So, next presenter is Dr. Sana Rafiq Khurru. And the topic is calculating disability adjusted life years of COVID-19 to quantify burden of COVID-19 in Maharashtra state of India. So over to Dr. Sana. Dr. Sana?
Good afternoon, everybody. Title of my study was to calculating disability adjusted life years of COVID-19 to quantify burden of COVID-19 in Maharashtra state of India. World Health Organization announced the SARS-CoV-2 pandemic on March 11, 2020, and for better understanding the enormous influence of this pandemic on public health, it's worthwhile to quantify the burden of disease. Although incidence and prevalence reflects the magnitude of the problem, there is a strong need to adopt summary measures which examine health outcomes. DALYs for specific cause are calculated as a sum of the years of life lost and the years lived with disability from that specific cause. Objective of my study was to calculate DALYs due to COVID-19 from March 2020 to August 2020 to quantify burden of COVID-19 in Maharashtra state of India. The study was analysis of the available data, and we used the methodology given by WHO. For estimation of YLD, we calculated like number of cases multiplied by duration till remission or death and disability weight. For cases, we used the number of confirmed cases obtained from Directorate of Medical Education and Research, Government of Maharashtra. They reported that in Maharashtra, the cumulative cases of COVID-19 till August 2020 were 5,84,000. Out of that, 19,800 patients expired. For duration till remission or death, using available preliminary data, the median time from onset to clinical recovery for mild cases is approximately 2 weeks and is 4 weeks for patients with severe disease. Now, disability weights. We all know that COVID-19 is an emerging disease and its specific disability weights have not yet been determined. So, disability weights of similar infections diseases were adopted. Estimation of VILL, death, number of deaths multiplied by life expectancy at the age of death. Age group wise number of deaths were taken from Government of Maharashtra. Population of Maharashtra according to age groups and life expectancy were taken from sample registry system. Now coming to the results, table number 1 shows years of life lost attributable to COVID-19 stratified by age in the state of Maharashtra 2020. During the study period, there were 440958 VILLs due to COVID-19. Maximum deaths were reported in the age group of 61 to 70 years, but maximum burden of VILL was contributed by age group 51 to 60 years of age, which is almost 29% of the total VILL. The burden of VILL is less in older age and in younger ages. Table number 2 shows years lost due to disability. During the study period, there were 108510 VILDs due to COVID-19. Maximum VILD was seen in the age group of 31 years of age, almost 21%. The age group 41 to 50 years constitutes 17% of total VILD, and the lowest was seen in age group more than 81 years of age. Now, table number 3 tells us about the DALYs attributable to COVID-19 stratified by age in the state of Maharashtra 2020. The total DALYs of COVID-19 was 549,468.62. VILDs and VILLs constituted 19% and 80% of the VILDs DALYs respectively. The relative contribution of VILD and VILL varied by age. The contribution of the VILL increased with age. Maximum DALY was seen in the age group of 51 to 60 years of age. That's almost 26.8% of total DALY. Age above 81 years of age only contributed 1.5% in the total DALY. Coming to implications and conclusion. Contribution of all disease VILL and VILD in Maharashtra is 64% and 35% respectively. However, our study reveals that VILL due to COVID-19 in Maharashtra is 80%, which is quite high than the average VILL of disease in Maharashtra. In Maharashtra, all age dialysis of leading 30 major diseases like ischemic heart disease, COPD, and lower respiratory infections is 23668 per 1 lakh population. That of respiratory infection is 937 per 1 lakh population. However, in our study, all age dialysis due to COVID-19 was 490.74 per 1 lakh population. That's almost 50% of the total burden of respiratory infections and 2% of total all age dialysis of major diseases in Maharashtra. And on matching with leading 30 causes, COVID-19 attained 18th position. Considering the burden of COVID-19, the most important strategy to reduce daily of COVID-19 is to focus on reducing the case fatality because of the proportion of viral is very high. It can be achieved through improving the healthcare resources like hospitals, ICU services, oxygen supplies. In addition, preventive approach to reduce the incidence of COVID-19 is also important. If the case is exceeded than the capacity of healthcare resources, we expect a higher mortality. Ideally, we should calculate daily for a year. We have done it on the basis of few months, but our study can act as a model for future study on daily estimation of COVID-19 because it's necessary to know the exact burden of COVID-19 to make informed decisions. Thank you.
Dr. Sami.
Yeah, good afternoon, sir.
So, Dr. Senthil, if you have any questions.
So can I ask questions, sir?
Yeah.
Thank you, Dr. Sana, for your presentations. I just wanted to know that with the case fatality of COVID around 1.5%, you are saying that 65% of OLLs were contributed to that things. What could be the possible reasons for that? Do you think it's an overestimations, or what could be the reasons for that such a high contribution of OLL to the overall OLL?
Yeah, thanks a lot, sir, for the question. I'm not saying that it's 65%. I'm saying that the YLL is contributing almost 80%. So it is 80%. That's what my study is saying.
That's even too big, actually.
Yeah, that's too big, actually. As compared to the average YLL in Maharashtra, which I have quoted from a article which said 64% of the virals are mostly contributed. But why I think COVID is contributing more for it, so because in the initial stage we know that almost the severe cases needed more ICU care, more oxygen supply. So our healthcare system was not ready for that supply. I have even quoted in my discussion that there was less oxygen supply and there was not that much of ICU admissions. ICU beds were not available that much. So that's the reason which, according to me, we are seeing 80 viral is almost of 80%.
I have two more questions, ma'am. Have you
Yes,
calculated
sir, please.
the uncertainty interval for your estimates? And second thing is, what are the other limitations of your study?
Sir, first coming to your second question, limitation according to me is I have done it for the from March to August, but usually we calculate daily for a year. So one is this, and second thing is I didn't had any published data on the disability rates of COVID-19. So I took the disability rates of other infectious diseases, like I have actually taken the disability rate of influenza. So second thing is that. So these two things were, which according to me are the limitations in my study. So can you please repeat your question number one?
Have you calculated the uncertainty interval for your estimates?
No, sir, I couldn't. Why I couldn't calculate that, sir? Because uh, the data which was available with me was overall total number of cases I had divided in mild, moderate, severe, but I couldn't divide them on the basis of the age group. Like example, from 0 to 10, I didn't know how much were mild, moderate, and severe, and in other age groups. So I hope you understand what I'm trying to say.
Yeah. Thank you, Dr.
Yeah, sir. Thanks a lot. Thank you.
Over to sir.
I think now we can move to the third speaker. And,
thank you, sir.
So our third speaker is Dr. Yogesh Kumar Arora, who is going to present cost-effective analysis for screening and treatment option of hepatitis B virus infection in India. Over to Dr. Yogesh.
Good afternoon, everyone. I think my video will be played in a short while.
Meanwhile, you can introduce yourself.
Sir, I am doing my third year residency. Right now, I'm just exam going resident here. I'm going to appear in exams in April this year from PG Chandigarh.
Hello everyone, myself Dr. Yogesh Kumar Arora, Junior Resident Department of Community Medicine, School of Public Health, is going to present a study titled Cost Effectiveness Analysis for the Screening and Treatment Options of Hepatitis B Virus Infection in India. This study was done under the guidance of Dr. Shankar Prinja, Additional Professor Health Economics, Department of Community Medicine and School of Public Health, and Dr. Madhumita Prem Kumar, Assistant Professor, Department of Hepatology, PGI, Chandigarh. Viral hepatitis now ranks 7th in the cause of mortality in the world, and the absolute burden of and relative ranking of viral hepatitis has increased as a cause of mortality between 1990 and 2013. In the Southeast Asian region, 57% deaths due to acute hepatitis and 73% deaths due to chronic hepatitis are attributable to hepatitis B virus infection. Among the causes of transmission, perinatal transmission is an important cause of hepatitis B virus infection, which accounts for 35 to 50% of all HPV carriers. The rationale for this study, since India has rolled out a national program named National Viral Hepatitis Control Program in July 2018 to curb the morbidity and mortality due to viral hepatitis, including hepatitis B virus infection. One of the key objectives is to provide early diagnosis and management of viral hepatitis at all levels of healthcare. Now the objectives. The first objective of the study is to ascertain the incremental cost per quality adjusted life year gained for 3 alternative strategies for hepatitis B virus infection. The first strategy is to screen the general population. Second strategy was screening of high-risk groups, including MSMs, men who have sex with men, PWID, people who inject drugs, PLHIV, people living with immunodeficiency virus infection, and others. The third strategy was screening of pregnant women in areas where institutional delivery is less than 80%. And these 3 strategies were compared with the current scenario of diagnosis and opportunistic treatment seeking practices. Objective 2 of the study is to assess the incremental cost per quality adjusted life year gained with various treatments of chronic hepatitis B virus infection among the pregnant women. The first strategy was the antivirals and second was immunoprophylaxis as compared to no treatment. Now the methodology. This is an overview of methodology in which the first step was to the construction of dysentery and Markov model, which was later followed by the collection of cost of various interventions and comparators taken from primary data as well as secondary data. This was later followed by the evaluation of consequences, which helped in the computation of results. This is the overview of objective 1 and 2, in which in objective 1, intervention arm was including 3 strategies compared to no screening in the comparator arm, and in the objective 2, the intervention arm has 2 strategies compared to no treatment in the comparator arm. A Markov model based on the natural history of chronic hepatitis B virus infection was made to simulate the progression of infected population to different stages. This is a figure of dysentery in which a population of a hypothetical population of a cohort was followed hypothetically to be exposed with screening and treatment, which will end up in with the cohort will end up in 2 scenarios of treatment or disease Markov. In the same population, if they'll be progressed with the no screening scenario, they'll be ending up in the same treatment disease Markov but in a different number. This is a dysentery of objective 2, which has 3 scenarios, in which the first scenario was treatment of pregnant women with antivirals, and the second scenario it was treatment with immunoprophylaxis, and the third scenario was no treatment. This is a Markov model which has different state, and it was then populated with the progression parameters to ascertain the results. This was the intervention. This was the algorithm used for assessing the movement of patients among the screening and treatment arm to finally they entered in the Markov treatment and disease Markov. This was taken from the Government of India guidelines from the program. The costing was done from social perspective, which included health system cost as well as out-of-pocket expenditure cost, and the valuation of consequences, quality of life year gains was assessed. Discount rate was applied at 3%, and the horizon was used as lifetime horizon. A cohort of 136 people were assessed on their health and quality of life under the primary data collection, and the sample size was calculated with this formula. Study duration was 1st of July 2019 to 31st December 2020, and the participants were recruited from Department of Epidemiology, PGI, Chandigarh. The study tool was Euroqual 5D5L questionnaire, and this was applied telephonically. Now the results. For the objective one, in the scenario one, which was intervention one versus comparator, and the intervention was a screening of general population, the ICER was computed to be 83,649 in rupees. In the scenario 2, which was intervention 2 versus comparator, and the intervention 2 is screening of high-risk groups, the ICER came out to be 83,350 rupees. And in scenario 3, which was intervention 3 versus comparator, intervention 3 is the screening of pregnant women, the ICER came out to be 84,832. In the objective 2, in the scenario 1, which was intervention 1 versus intervention 3, means treatment with antivirals versus no treatment, the ICER came out to be cost saving as rupees 3,800 rupees saved. And in scenario 2, which was intervention 2 versus 3, which is comparison of immunoprophylaxis versus no treatment, ICER came out to be in rupees 2,387. Now, the implications and conclusions. Among the three intervention strategies examined, screening and treatment among the high-risk groups is found to be most cost-effective, and treatment of pregnant women with hepatitis B virus infection with antivirals proved to be cost-saving. And in comparison with hepatitis B, immunoglobulin proved to be cost-effective in comparison to no treatment scenario. Early diagnosis and treatment has proved to be cost-effective in multiple studies. The current study also suggests towards a community-based screening strategy followed by treatment for the effective and efficient execution of the objectives of the national program envisioned by the Government of India. The current study suggests to treat all pregnant women with hepatitis B virus infection to stop the transmission of hepatitis B virus infection from mother to child. Now, the strength and limitation of this study. The cost of drugs came down drastically when the government started procuring under the program, as shown by the study on hepatitis C virus treatment in a tertiary care hospital in North India. So we expect the price to come down in the same manner for this disease also. And the drug which was procured was tenofovir disoproxil fumarate, and is expected to be near 2,500 to 3,000 in rupees per patient per year. At this price, we can expect more cost-effective results in the future. As the cost of drugs and services are changing very rapidly, so it is sometimes difficult to predict future scenarios, and there might be new policies and laws affecting the same. This is a limitation of the study. Another limitation of the study is the discrepancy among the treatment strategy given by various clinicians is a matter of concern because it can change the cost of the treatment. Thank you.
So, thank you, Dr. Yogesh. Well, I can say it is a very useful study. It can be useful for program managers.
Thank you, sir.
So, have you tried it to evaluate that, or have you seen some studies? You have done all this study in PGI. So, what are the cost implications if a person will choose from private sector also? So again, the cost will be very high, I think, in comparison to the government.
Yes, sir. In this study, we have used a scenario where the people will take the treatment as they used to do before also. So there won't be any difference in the treatment seeking practices, but yeah, after the programs is rolled out, there will be some more coverage increase in the coverage of people covered under the program. So,
and how much was the out of pocket expenditure?
Sir, I've taken from a study done by my guide only. This was taken, not collected primarily, but taken from a study, all the cost.
Dr. Santhil?
Thank you, sir. Thank you, Dr. Yogesh, for your presentations. And I have only two questions. You have used QALY as your parameter outcome. So why did you prefer to use the term cost effectiveness instead of cost utility for your study?
Sir, cost effectiveness, I thought will be a term like I have not used dailies. So I've read not so deep in the topic, but they were using dailies in cost utility analysis. So that's why, sir, I use this term QALY in cost effectiveness analysis.
Okay, thank you. One more question is that there we used to enter a lot of assumptions in a decision tree and Markov model. How do you undertake sensitivity analysis for your cost effectiveness analysis?
So that I've not taken yet to that paucity of time. I was just close to the submission of my thesis, but I'm doing it currently right now. And hopefully I'll be doing it, sir.
Yeah, thank you so much.
Thank you, sir.
Yeah.
So now we can move to the third speaker, fourth speaker. This is Dr. Siddesh Shetty, and the study is about cost effectiveness of managing atonic postpartum hemorrhage in India with uterine balloon tamponade devices. So, over to Dr. Siddesh.
Greetings to all the delegates and respected faculty gathered here for this e-conference. I am Dr. Siddesh Shetty, and on behalf of the team at ICMR NIRRH Mumbai, I will be presenting the study titled Cost Effectiveness of Uterine Balloon Tamponade Devices in Managing Atonic Postpartum Hemorrhage in India. Postpartum hemorrhage is defined as maternal blood loss of 500 ml or more after childbirth. This is a life-threatening condition with pathological causes such as tone of the uterus, trauma, any retained tissue or coagulopathies. India accounts for nearly 12% of the global maternal deaths, which is the second highest in terms of number. PPH is its leading cause. It is reported that PPH affects nearly 3 to 6% of all women delivering. Atonic PPH is the commonest type. Now, uterotonics remain the mainstay of treatment for atonic PPH. UBT intervention is recommended if uterotonics fail to control bleeding or if it is unavailable. The mechanism of action is to insert a balloon into the uterus inflated with saline. This stimulates the uterus to contract and thus control bleeding. If bleeding remains uncontrolled, then surgical measures are undertaken. Now, there is a lot of literature that is available for UBT intervention. A recent systematic review with 91 studies has reported a success rate of 85.9%. There is some conflicting evidence regarding the use of UBT intervention, but global recommendations suggest to use it, especially in resource constrained settings. There are multiple alternatives or multiple choices of UBT devices that are available. Globally, Bakri and condom UBT are two most commonly used devices. Bakri is an expensive device, whereas condom is a assembled device. There are other alternatives such as the ESM UBT. So ESM UBT, the government of India is considering its introduction. So we were given this policy question to answer and assess if India should consider this introduction in the Indian public health system. So an economic evaluation approach was chosen to answer this question. What an economic evaluation basically does is assesses the alternatives in terms of its costs and consequences, compares them, and thus gives an informed evidence decision making. So with this brief background, we undertook this study to assess the cost effectiveness of 3 UBT devices relevant to the Indian context. We had 3 objectives. First was to collect the clinical effectiveness evidence for the 3 devices. Second was to estimate primary cost of atonic PPH management with UBT intervention. And third one was to assess the cost effectiveness of the alternatives. For the first objective, we looked at literature for the past 10 years. We eventually included 33 studies in the review, and the pooled UBT success rates are reported here. Now, the evidence basis was not robust enough, especially for ESM UBT, which was based on 3 case series studies. For the second objective, we undertook an economic bottom-up micro-costing study in the state of Maharashtra. One PhD, SDH, DH and a medical college from the state were chosen. Standard methods of costing with validated tools were used to estimate unit cost of various components of PPH management. Coming to the economic model, we chose a decision tree model for this condition. A willingness to pay threshold of 24,000 was chosen, and disaggregated societal perspective as recommended in India was used. The outcomes that we primarily looked was incremental cost per DALI averted. We have also reported maternal surgeries, ICU admissions and deaths. The population that went into the model was women experiencing atonic PPH, accessing public health facilities, and those that are eligible for UBT intervention. The time horizon for this analysis was lifetime. This is the decision tree. It basically starts with the 3 choices of UBT, followed by the healthcare level that is accessed by the woman, and the decision pathway flows consequentially. For DALI estimation, we use disability weights from the global burden of disease sensitivity, and here we've reported the sensitivity analysis variation. Looking at the gross finding of results in terms of costs and outcomes, you can see a similar cost reported for ESM and condom UBT, whereas Bakri UBT reports a significantly higher cost. In terms of DALIs, ESM UBT reported the most favorable one, followed by condom UBT and Bakri UBT. For maternal deaths, surgeries and ICU admissions, given the higher effectiveness of ESM UBT, the most favorable outcomes were for ESM, followed by condom and then Bakri UBT. Looking at cost effectiveness in terms of comparison, ESM versus condom UBT, you can see that cost is saved with ESM UBT, whereas outcomes are favorable, thus suggesting that at base case ESM UBT is a cost saving alternative. Similarly, for Bakri versus condom UBT, Bakri is more expensive, less effective, and thus it is not cost effective. We undertook sensitivity analysis for both the interventions. Here is reported the probabilistic sensitivity analysis findings. A willingness to pay threshold passes through the origin to the graph on your left, and with 10,000 Monte Carlo simulations, we saw that 63.7% simulations would be cost effective for ESM UBT, indicating that 0.36% error probability is there, suggesting uncertainty. To the graph on the right shows the willingness to pay on the x-axis, that is the society's ability to pay. So if the society's ability to pay increases, there is still only a 69% ceiling effectiveness for ESM UBT. Similarly, for Bakri versus condom UBT, only 0.1 simulations were cost effective, and the ceiling cost effectiveness probability was 11%, indicating that the intervention is not cost effective. To summarize, across both the analysis, Bakri versus condom, Bakri did not turn to be cost effective. For ESM versus condom, though ESM seems like a cost saving alternative, there is uncertainty with the results, and the clinical evidence that has gone into is limited. We also undertook one-way sensitivity analysis, which for both analysis suggested that clinical effectiveness evidence was the most sensitive parameter. Now, there are few strengths of this study. There is very limited cost effectiveness studies that are being undertaken. This study has generated primary cost for PPH management and has used this in the economic modeling, especially for the Indian context across healthcare levels. The couple of studies that are available have looked at UBT intervention as a whole. We have compared the choices of UBT devices. For limitations, the evidence that is gone into the model is not robust enough. The societal costs that we've accounted for are not complete, and the OOP that we've taken is not PPH specific. Provider preferences or ease of use has not gone into the model, and there are certain modeling assumptions which limit the study results. So conclusion for India, between Bakri and condom UBT offers better value. Between ESM and condom UBT, though ESM seems like a cost saving option, the results need to be considered with caution, given the limitations associated with clinical evidence, marginal nature of differences, and associated uncertainties. Our recommendation primarily is to assess and compare the clinical effectiveness of the UBT over identical measures. Second, qualitative aspects need to be considered in decision making, and third would be to generate health related quality of life source for India. Thank you.
Hello. Hello.
Yeah.
Hello.
Yeah, Dr. Siddesh.
Yes, sir.
Thank you for a nice presentation. And Dr. Senthil, if you want to ask some questions.
Thank you, Dr. Siddesh, for your presentations. I just have two questions. How did you account for urban-rural differentials in estimating the societal cost?
So we've not really accounted for urban or rural differences. So basically the primary costs in terms of the health system cost, we've taken from the Mumbai metropolitan region. So the only variation that we have is the tertiary facilities and the district hospital. The tertiary facility, the tertiary level of care is from an urban district, whereas the primary and the secondary levels are from the rural areas. In terms of out-of-pocket expenditures, sir, we've not collected any primary out-of-pocket expenditures. However, we've taken out-of-pocket expenditures from the NSSO source for child birth. So this basically considers the NSSO sample considers costs, the out-of-pocket expenditures for rural and urban. So yeah, so that's primarily where we were.
Okay, I have two questions. How did your primary objective of one is based on literature review? So how did that findings you have adjusted for the Indian settings or Indian context?
So basically, India recommends using UBT intervention for atonic PPH. So one is we've looked at literature which has specifically looked at addresses atonic PPH management. Secondly, when we were looking at literature, we've chosen studies which have been primarily undertaken in developing context. So specifically for condom and ESM UBT, we were able to find literature from developing country settings. However, for Bakri UBT, which is a relatively expensive device, majority studies were not from developing countries. So.
I have one more questions. We have a medical management also, like we have differential use of oxytocin as well as misoprostol for PPH. So
Yes.
how did you account for that thing? Have you accounted for medical management in your costing also? Differential thing, basically. How did that differential? Some uses misoprostol, some uses oxytocin. So how that was taken in your costing?
So specifically for the cost effectiveness study, we haven't taken medical management because the UBT insertion starts at a point after medical management failed. So in terms of cost effectiveness results, we've not accounted for medical management. In terms of costing exercise that we've taken, we've calculated a package for medical management costing, but sir, in that costing, we have not really accounted for differential costing of misoprostol versus oxytocin. We've just accounted for a package of costing that is undertaken at the facility, sir.
Okay, thank you, Dr. Siddesh.
Thank you, sir.
Over to sir.
I think we are running late, so we can start the next question. Next speaker, we can invite next speaker. It is Dr. Suraj Prakash, who is going to present about the status of enrollment under Nikshay Poshan Yojana among TB patients at a DOT center in a tertiary care hospital. So over to Dr. Suraj.
Okay. Good afternoon, sir. The title of my study is Status of Enrollment under Nikshay Poshan Yojana among tuberculosis patients at a directly observed treatment short course center in a tertiary care hospital of Delhi. The authors are Dr. Suraj Prakash Singh, Dr. Anita Kokar, and Dr. Neeraj Gupta, all affiliated to BMMC Safdarjung Hospital, New Delhi. Studies have shown that malnutrition is one of the major risk factors of TB, affecting the poor, underage, vulnerable, marginalized population majorly and causing significant economic burden. That's why the government launched Nikshay Poshan Yojana scheme in March 2018 to provide nutritious support to TB patients, wherein all the TB patients receive a benefit of Rs 500 per month through direct bank transfer. To avail this benefits, the patient need to submit details of their bank account, phone numbers, and addresses. A few studies have shown some patients may not be able to fulfill these criteria. Also, unwillingness of patients to reveal their bank accounts and insufficient incentive issues are also there. By assessing the coverage of this scheme and its challenges, it would benefit the patients to help and also help the policymakers in their decision to achieve the envisaged vision of the NTEP program. The primary objective was to find out the enrollment percentage under NPY among TB patients attending DOTS at a DOT center in tertiary care hospital. Also to find out the facilitating factors and the barriers towards enrollment in NPY among TB patients. The secondary objective regarding NPY. The study was a cross-section descriptive study conducted at DOT center. The sample size was calculated to be 188 with a relative error of 15% and non-response rate of 10% based on a study conducted by Nirgod et al. In Dakshin Kannada. The inclusion criteria was all patients undergoing a TB treatment at DOT center in the continuous phase of treatment. They were all encouraged to reach the required sample size after taking informed consent. A pre-designed semi-structured questionnaire was used containing questions on socio-demographic profile, knowledge about NPV and DBT and the enrollment under it, obstacles faced by the patient in availing the program benefits, knowledge and practice regarding nutrition and TB. The nutrition knowledge was assessed as per guidance document on nutritional care and support for patient with tuberculosis in India. Ethical approval was taken and data was collected in MS Excel and analyzed on license SPSS version 21. Coming to the results, a total of 188 TB patients were approached and interviewed for the purpose of study. The table shows the distribution of study participants according to socio-demographic characteristics. The mean age was 29 years with standard deviation 12.22 years. Majority, that is 57.5%, were male, 45.2% were unmarried. They lived in areas, majority of them in Bilanji, Arkepuram, Mohammadpuri, Safdarjung enclave. Almost all were Hindu. Majority of them were educated till intermediate, rest had higher degrees. They belong to the occupations like private sector jobs, students, housewives, 11.2% unemployed, few had government services, and few were retired. The mean number of cohabitant a participant had was 4.8 with a standard deviation 2.112. 80.9% had no BPL card. The figure 1 shows distribution of study participants as per category of DOTS treatment, where 90% of the study participants were receiving category 1 treatment, other for other categories. Figure 2 shows distribution of study participants as per category of weight, where majority of the participants belong to 35 to 49 kg and 50 to 64 kg weight band with a mean weight of 48.7 kg and standard deviation of 11.4 kg. Table 2 shows distribution of study participants as per enrollment in Iapsmcon Yojana. Only 88.8% of the study participants were enrolled. Only 75% were aware about the scheme, and majority of them got to know it by the doctor or health staff and during the enrollment process. Of those who were enrolled, only 15 received the benefit for a period of 2 months, an amount of 1,000 rupees. They spent it on fruits, regular food, vegetable, transport, chicken, egg, milk, paneer, or did not spend it. These categories are not mutually exclusive. 74.3% did not receive it, and 16.8% did not know whether they received it or not. For majority of them, enrollment experience was easy. For few, it was not. Only 55% were aware about the incentive. Only 63.5% knew what to buy for nutrition. Only 53.3% were informed what to buy for nutrition. The reasons for non-enrollment by those who were not enrolled was lack of awareness, no time, or lack of bank account. When they were asked if they wished to enroll, majority said yes, few said no. Of those who said yes, they wanted it for food or they needed money because they were poor or for transport. Those who said no, they said it because they don't need it or there was no bank account. Distribution of study participants as per the knowledge, attitude, and practice related to nutrition and TB, where the knowledge was assessed against the guidelines issued by the government. When the 188 patients were asked if do TB patient need special diets, 83.5% said yes when asked what special diet. The correct responses were meat, eggs, fruits, green vegetables, milk, paneer, milk pulses or paneer in decreasing order of frequency. The incorrect response was given by 5.9%, rest did not know. When they were asked do TB patient need to avoid any food items, 48.4% correctly said yes. The correct responses amongst them were smoking, oil and fried food, cold food, spicy food, alcohol and fast food. Incorrect responses were sour food, curd, rice, milk or urad dal. 70% said no, which was incorrect, and 34.6% were not aware. When they were asked if they will change their diet when they get DBT, the participants who had not gotten it, 88.4% said yes. Few said money is not enough or they don't know. When the participants were asked if they will change their diet when the doctor tells them, majority of them said yes. Few said no or don't know. Only few of the study participants were buying a supplement, mostly a protein powder or a calorie mineral supplement or calcium supplement. So a total of 188 patients were included in the study, out of which 88% were enrolled, of which only 15 got the incentive for a period of 2 months. 74.3% did not get the incentive and few were not aware. Enrollment rate under NPY is not universal but 88.8% only, and the actual DBT is at 8.9%. Only but half of the enrolled participants are actually aware why the incentive is being given under NPY. Coming to the implication, there is a need to improve enrollment rate amongst the patient by addressing the issues therein and creating more awareness about it. Also, alternate mechanism need to be explored for those lacking the required documents. Dispersal of DBT incentive needs to be regularized under the program. Furthermore, the transfer should take place on monthly basis, otherwise erratic dispersal may not reflect the nutritional status of the patients. A feeder system needs to be put in place to ensure that patients are actually withdrawing the incentive and spending it on nutrition. The study highlighted the need to make people aware through IC campaigns about the scheme and the DBT incentive. Also to make them aware about the reasons behind NPY, what to buy for nutrition, what to consume and what to avoid. Also, there is need to improve patient willingness towards improving their nutrition and receiving DBT to fill the gap between patient knowledge in nutrition and TB and their actual practice. There is a need to conduct a mixed method study taking services provider interviews in details regarding problem faced in DBT. The title of my study.
Thank you, Dr. Suraj.
Thank you, sir.
So, how do you rate the effectiveness of Nikshay Poshan Yojana in terms of cost-benefit analysis? Do you think it is really effective in
So, So few studies have shown that people are happy about it and they're actually spending it on their nutrition. And also that's something we also find out that people are willing to spend more on their nutrition when they're getting the incentive. Similarly, the majority of the section that get a TB are generally malnourished people belong to socio-economical status strata. So there's effectiveness of that. At the same time, a study done in HIV patients where the effectiveness of DBT was considered, and they did not find any significant association with the treatment outcome and the incentive or nutrition.
Found any limitation in your study?
So we did not take interview of the the health workers, the issues therein, why the money is not coming. When I actually talked to them, there were issues with duplication of data. There was a lot of backlog. So there's a need to conduct mixed method study considering all those points too.
Over to Dr. Senthil.
Thank you, sir. Thank you, Dr. Suresh, for your presentations. I just have one question without taking much time. Did you find any differences with regard to category of TB patients?
So the number of people we belong to other category, the non-pulmonary. There were not enough people to run a chi-square or other comparison test. So we cannot do that.
Okay, thank you. Thank you. Over to
Thanks,
sir.
Sir.
So with this, I think all the speakers are finished now, and no new speaker is left now.
Yes, sir.
So with this, we'll come to end of the session, and all important findings are presented during this session. This is very interesting field where always struggle for finding the best and cost-effective methods are searched out. So thank you from my side to all the speakers, to the organizers. Thank you. Dr. Senthil, if you want to add something.
Yeah. Thank you, sir. I thank Sir Dr. Rakesh Kakkar for chairing the sessions and also the scientific committee for providing the opportunity. Like rightly said, we have a diverse of presentations ranging from country guidelines to tuberculosis to COVID to antepartum things. That shows the diversity of health economics, and more importantly, the importance of human behavior and health economics. Also, the presenters have highlighted in the presentations. I think we had a good interactive learning from the presentations, and I wish all the best to all the presenters. Thank you.
Thank you very much, Professor Kakkar and Dr. Senthil. I think your overall guidance and stewardship to the session for the purpose of chair and the comments made it absolutely interesting, and we had very useful contributions. So thank you very much for gracing as the chair. We'll now move on to the next session. And this session is on is another oral presentation on the social determinants of health, and it's my pleasure and honor to invite the chair of the session, Dr. Ashu Grover, who is a scientist F in the Indian Council of Medical Research. Besides being one of the very eminent leading lights in the field of research in India, she happens to be the first postgraduate student of MD Community Medicine from PGI, the institute which is currently hosting this online conference. So welcome very much, madam. Her areas of interest include epidemiology, research management, research methodology, health promotion, and she aims to further enhance the work in the field of assistive technology and public health informatics. She has several noted publications and several chapters that have been written in the books, and she has many important contributions. More importantly, she has been instrumental in setting up these multidisciplinary research units in government medical colleges. I remember her very, very influential and instrumental role that she played in developing these MRUs in Himachal Pradesh and in several other states, and promoting young and middle-level faculty as part of the SEED grant scheme. She's also been very actively involved in the development of the Health Technology Assessment Initiative at the Department of Health Research. So welcome, madam. And we also have a co-chairperson for this session, who is Dr. Shraddha Kulkarni. Dr. Shraddha is an assistant professor in the Department of Community Medicine at Kashibai Navle Medical College and General Hospital in Pune. Her areas of expertise include nutrition, health planning and management, and maternal and child health. So over to you, Dr. Ashu and Dr. Shraddha.
Hi, thank you, Dr. Shankar, and nice seeing you after a very long time. And I was telling the Jyoti who just called me that give me 5 minutes so that I can join and go back. I was just driving, so no issue. I think thanks for introducing me to this event and where we are going to have various presentations by the young researchers and who are still looking their career forward. And I think the session, which is social determinants in health, I think this is the theme of the session. And the organizers have done their all good efforts to put the good proposals into the theme, which is being discussed over next 1 hour or so. So I look forward for very good presentations, and already they have been shortlisted. But I think still there will be few queries among the participants and other faculty who will be joining to this important session. Thank you, Dr. Shankar, and thanks organizers once again. So shall we start, Dr. Shankar? How do we go about?
Yes, ma'am. Basically, you'll have to call upon each individual presentation. So maybe Dr. Shraddha, or if you're busy in the car, maybe Dr. Shraddha can maybe call out the individual participants, presenters.
Okay, sir. Good afternoon. Now we'll start the session with the first presentation by Dr. Abhishek Mehta on the topic Pandemic in Digital Era. Can social media and online health platforms be game changers in risk communication? So, Dr. Abhishek Mehta, please.
Greetings for the day, everyone. The title of our study is Pandemic in Digital Era. Can social media and online health platforms be game changers in risk communication? Myself, Dr. Abhishek Mehta, a resident in Department of Community Medicine of Iapsmcon Pune, as principal author, with Dr. S.V. Bhaskar, Dr. Kunal Chatterjee, and Dr. Abhinav Parekh as co-author. COVID-19 was first detected in December 2019 in Wuhan, China, which was then declared as a public health emergency of international concern on January 30 by WHO. India has taken some unprecedented measures to control the COVID-19 transmission, which included the suspension of public transportation, the closing of public spaces, setting up of an isolation and quarantine centers, and the complete lockdown. Amid lockdown, social media and online health platforms were the most important medium of risk communication pertaining to COVID-19. However, at the same time, misinformation and rumors regarding the various aspects like transmission, prevention, treatment, etc., were disseminated over the social media. Therefore, we thought of doing a study to understand the role of social media and online health platforms in imparting awareness pertaining to COVID-19. The primary objective of our study was to assess the role of social media and online health platforms in risk communication towards increasing level of COVID-19 awareness during the lockdown. While the secondary objectives were firstly to assess the association of various socio-demographic factors and mode of information delivery with the level of awareness towards COVID-19, and secondly to assess the association of knowledge towards COVID-19 with their attitude and practices. The study was conducted during a period of lockdown for COVID-19 in India. The collection of data was through a structured questionnaire imparted by both face-to-face interviews and through online dissemination. Institutional Ethics Committee approval was obtained. The sample size was 384, which was calculated assuming a level of awareness at 50%, degree of absolute precision as 5%, and 95% confidence interval. However, it was decided to enroll as many participants as possible in the study over the minimum sample size. The questionnaire consisted of 5 parts: demographics, social source of information, knowledge, attitude, and practices towards COVID-19. Demographic variables included age, gender, education, and occupation. Source of information questionnaire had questions regarding sources of formal and informal information and top sources of misinformation from social media. The knowledge about the disease was assessed with regard to clinical presentation, transmission route, progression of disease, prevention, control, and legal provisions of COVID-19. The total knowledge score ranged from 0 to 12, with a higher score denoting a better knowledge of COVID-19. Attitudes assess the agreement on the final control of COVID-19, role of lockdown, superstition, the confidence in winning the battle against COVID-19, and misinformation from social media. The practice component was analyzed on the respondents' behavior on venturing outside home during lockdown, wearing of masks, following social distancing, practicing good hand hygiene, and stopping someone from spreading rumors. The data was analyzed using SPSS version 20. The categorical data were described as numbers and percentages, knowledge scores, attitudes, and practices. According to the demographic characteristics and sources of their information were compared by ANOVA and chi-square tests as appropriate with statistical significance level set at p less than 0.05. Now moving on to the results of our study, a total of 388 participants participated in the study. Table 1 describes the demographic characteristics of participants and knowledge score by demographic variables. The study found out that the overall knowledge score was 5.78 with SD of 2.3, suggesting an overall 48.16% correct rate on this knowledge. The mean knowledge score is significantly higher amongst healthcare workers and middle-aged adults, while significantly lower amongst those having education up to senior secondary. Table 2 represents the source of information of participants and knowledge score by formal and informal source variables. The top source of formal information came from official government of or WHO websites, wherein mean knowledge score was significantly higher amongst official government or WHO websites and scholarly literatures or journals. Likewise, top sources of informal information came from online news, social media, and television, and means knowledge score was found to be significantly higher amongst participants receiving information from print media, online news, social media, and television. This table clearly depicts the dependency of respondents on online and social media as the preferred source of informal information and the positive association of online and social media in imparting awareness during the lockdown period. This pie chart represents the top source of misinformation were majorly through messages forwarded on various social media like WhatsApp and Facebook, with WhatsApp at 49% and Facebook at 22%. Table 3 describes the characteristics of participants and knowledge scores by attitude variables. Majority of the respondents believe that COVID-19 will be successfully controlled and agreed to the decision of lockdown as an effective measure in reducing transmission. Also that misinformation leads to panic among public and person involved in any rumor must be punished. Additionally, the knowledge score was significantly higher amongst those having positive attitude. Table 4 describes the characteristics of participants and knowledge score by practice variables. Majority of the respondents endorsed that they have started wearing face masks, followed social distancing outside home, maintained good hand hygiene, and have asked people to stop spreading rumors on social media. However, 62% of respondents gave a history of going out of home at some point of time during the lockdown. Social media has played a crucial role in dissemination of information and creating awareness, as can be seen in our study. However, it has been also misused for creating sense of panic and spreading fake news, which led to inaccurate knowledge amongst people. So, what is the way ahead? Now, health education programs and online courses can be planned to educate the media consumers on how to find reliable information during any epidemic or pandemic. Now, to conclude, even though social media is blamed for the information, it plays an important role in risk communication in emergencies with an ultimate purpose of enabling the people at risk to take informed decisions to protect themselves and their loved ones, and thus may prove to be a game changer in time of crisis. Thank you so much. Greetings for the day, everyone. The title of our study.
Thank you, Dr. Mehta. It's a nice presentation.
Good evening, ma'am. Thank you so much, ma'am.
Okay, so just one question. So which sampling method did you use for the study?
Ma'am, actually, it was a period of lockdown. So earlier I thought of doing a simple random method, ma'am. But during the lockdown, it wasn't possible to do that. So it was just earlier it was made all the online users which we had disseminated this over a social media and all. So those who could receive this over a social media, they had used it and filled up the form, ma'am.
Okay, thank you.
Thank you so much, ma'am.
And in which study setting, that means overall community or particular area of the country or city?
It was all over India, ma'am. The questionnaire was disseminated all over the India, ma'am.
India. Okay, thank you.
Thank you,
Uh,
ma'am. Good day,
okay,
ma'am.
over to madam.
I have one query regarding the in presenting. I have one query, Dr. Abhishek. What about the misinformation? Can you hear me?
Yes, ma'am. I can hear you, ma'am.
Okay, what about the misinformation you said? No, most of the social media. So, what was that kind of misinformation which you had expected to be there, and how was that distributed among various groups of population, among health workers and other people?
Ma'am, the misinformation was all about the rumors which was floating around during that period of time during the lockdown, ma'am, over the social media, over the print media, and over the news channels. Just giving an example, ma'am, the misinformation which was floating around was use of cow dung, to prevent this COVID infection. Just an example, ma'am. Similarly, there were a few more
Was
things
it
which
categorized? Was it categorized by you?
In the question, ma'am, in the questions, I had asked them whether you do you believe that this thing maybe like what do you say mm, uh,
No, I
uh,
think you may have asked different questions, but I think it would have been good if you would have presented that so many respondents, maybe some proportions of those kind of misinformation which you had gathered. If you have
okay,
that
ma'am.
information, you should share it with us maybe sometimes later subsequently
Yes,
in the
ma'am. Surely I'll do that, ma'am. I'll come back to you, ma'am.
Thank you, Abhishek.
Good day, ma'am.
Yeah, thanks. Madam, can we go to the next one? I don't have the names who all
Okay,
are
okay.
in that list.
Next presentation will be by Dr. Jaita Burman on the topic, can household food insecurity truly predict the nutritional status of children? A community-based study in a slum of Kolkata. So Dr. Jaita, please.
Yes, ma'am, I am present. Good evening, ma'am.
Good morning, everyone. My study title was Association between Household Food Insecurity and Nutritional Status Among Children Aged Less than 5 years, a community-based study in a slum of Kolkata, Eastern India. Food security means that all people at all times have physical, economical access to sufficient, safe, nutritious food that meet their dietary needs and food preferences for an active and healthy life. Household food insecurity has been associated with several health and nutrition outcomes in both developed and developing countries. However, the relationship between household food insecurity and nutritional status of adult and children, particularly in developing countries, is not well established. HFI is one of the key determinants of chronic undernutrition in Indian children, particularly for those living in income insecure environment. Children are most dangerous because they are more susceptible to adverse environment and dietary changes can affect them at large scale. In an underserved areas like urban slums, the situation is worse. In India, few studies were available about this topic. With this background, this study was undertaken. This study was community-based observational study, cross-sectional in design, has done from March to May 2019 in slum under the service area of ward number 15 Urban Primary Health Centers, Kolkata. All households with children aged 6 to 59 of the age and their mothers were my study populations. The sample size, by considering the West Bengal proportion of stunting in under 5 children in West Bengal, that is 32.5. My study sample was 234 And data was collected from 257 mother-child pairs through face-to-face interviews with a pre-designed, pre-tested, structured schedule from mothers and anthropometric measurements of children. Technique was simple random sampling. The data outcome variable was nutritional status of under 5 children. It was assessed via anthropometric measurements. Independent variable was HFIAS scale. It consists of 9 low food status occurrence question in responses yes and no, and another sets of corresponding 9 questions of frequency of occurrence during last 30 days of recall. Standard scoring procedure was used with the frequency scores were ranged from 0 to 3, while 0 was a score for non-occurrence, 1 for rarely, 2 for sometimes, and 3 for often. The total score ranges from 0 to 27 had the score more the food insecure household. Data was analyzed with the SPSS software version 16. From my study, I have seen that half of the children belongs to 12 to 24 months age group, and around half of them were male. Table 1 shows the distribution of the study participants according to their food insecurity. It consists of 9 questions of HFIAS scale. Table 2 shows the distribution of the study participants according to the various factors related to the nutritional status. Table 3 is showing the distribution of the study participants according to the household food insecure and nutritional status. From this table, we can see that 29.9% were underweight, 27.2% stunting, and 17.8% were wasting. And 27.6% were food secure, 42.4% were mild food insecure, 22.6% moderate food insecure, and only 7.4% were severe food insecure. Table 4 is showing the relationship between household food insecurity and various factors with nutritional status. From this table, we can see that household food insecurity significantly associated with wasting and stunting in univariate logistic regression, whereas in multivariate logistic regression, stunting remains significant. The cross-sectional nature of the data also limits our ability to draw any causal conclusion. This is the study limitation of my study. The prevalence of the food insecurity found to be 72.4%, and the proportion of underweight, wasting, and stunting were 29.9%, 17.8%, and 27.2% respectively. The Government of India has adopted a range of policies to strengthen food insecurity, such as government controlled public distribution system, various schemes to enhance agricultural production and sales through the nutritional food security missions, and nutritional interventions for women and child via integrated child development scheme and mid-day meal schemes play a pivotal role. Identifications of bottlenecks at every levels of implementation of these strategies will reduce the inequalities and lay the foundation for sustainable growth. These were my references. Thank you.
Thank you, Dr. Burman.
Thank you, ma'am.
This is a very important topic, Dr. Jaita. But however, I have few observations and suggestions for you to improve upon it. First of all, whenever you are starting with some hypothesis or some project or something, some kind of a research, you have to really find out what is your primary objective. Okay.
Ma'am,
So, No. You can reply later on if the time would be there. So I have just comments and few suggestions to do that. So objectives you have mentioned was too many. So it will be very difficult that what is your primary objective? What are you looking for into it? And I understand that you were trying to find out the health food insecurity and proportions of those among the various underweight children. Could it be severe, moderate, or mild malnourished children? Okay, so those objectives you really have to go back and see to that. What is your primary aim to do this kind of a work? And secondly, when you were presenting this sample size estimation, so you took around more than 200, 250 or 230 kind of subjects you have taken. So what was the basis of your sample size calculation? You took that prevalence, proportions of those underweight children who were there as your primary sample size collection. So if whatever is your primary objective, your sample size has to be calculated based on that, right? How many of them you expect that to have a poor knowledge or the proportions of those people having food insecurity among these three categories of the malnourished children. So whatever would be the lowest one, you have to take that as a sample size calculation. My third observation in your presentation is that some of your tables are very crowded. So that's a general remark that you should try to avoid putting a crowded table into such kind of a presentations, since it is your beginning career. So you should try to learn to do that. And fourth and my last comment would be that you have not done 2 by 2 analysis. I know that how many of these three categories, underweight, and severe or those malnutrition categories you had, how many of them had food health and food insecurity? So that analysis probably is missing from your presentation. If you have done it, so you can share it in your paper when you write it. But we would like to see that how these three levels of malnourished children have been distributed across what is their level of health and food insecurity pattern, and similarly based on other parameters also. So these were my few comments. If you have any query, you can just let us know now, or then over to Dr. Sharda.
Okay, thank you, ma'am. I will correct, ma'am.
Okay.
Just one question. So you have selected this your sample by simple sampling method. Then what is the total population of under 5 years in the slum of this particular Kolkata?
Ma'am, total I have seen that 257 household where under 5 children was there. So my sample size was 234. By calculation, it was 234. By I have taken the data of 257, ma'am.
No. Out of how many total population you have selected these 257 by simple random sampling?
Ma'am, it was around 3,000. 3,000 population, but household was who has under 5 children, that is 257.
Oh, okay. Thank you.
Welcome.
So we go towards next presentation by Dr. Tarika Mittal on topic expenditure on public health and family welfare, a comparative analysis of low, medium and high income Indian states. So Dr. Tarika, please.
Greetings, everyone. I thank you for giving me this opportunity to present amongst you all. I am Tarika Mittal, a PhD research scholar at the Department of Economics, Punjab University, and my co-author is Dr. Tanvi Kiran. The title of our paper is Expenditure on Public Health and Family Welfare, a comparative analysis of low, medium, and high income states. India, being a huge country, faces inequalities in regions, inequalities amongst incomes among people, and thus a mixed setup of the government and the private sector together working hand in hand is the best for our nation. Amongst its various macroeconomic goals, social welfare tops the list. The government prioritizes public health and family welfare for better achievement of growth of the nation in totality. If we talk about the current situation, the government has been successful in its endeavors in COVID-19, whether it has been the spread of awareness of the disease, its testing quantums, its patient care, the techniques that have been used, the designated COVID centers for testing, real-time updation of data, various statistics, follow-up on health, the care of healthcare workers, frontline workers, etc. The objectives of our study is to examine the trend growth of expenditure in the pre and the post FRBMA period, which is 1990 till 2004-5 and 2005 onwards. The paper is also a comparative study on the relative importance placed on public health by the various states and the difference in allocations between their revenue and capital components on the same head. At the end of the paper, I will be giving policy recommendations on the same. The following materials have been used in this secondary study: the Handbook of Statistics, various publications by the Indian Public Finance Statistics, the Economic Survey of various years, budgetary documents by the various departments, and statistical abstracts. For the purposes of study, 3 states, Haryana, Andhra Pradesh, and Bihar, have been selected as the state with the highest, medium, and lowest GSTP respectively. A time series analysis has been done, and the following descriptive statistics have been used, which is mean, standard deviation, and coefficient of variation. The compound annual growth rate has been calculated by a semi-log model. The efficiency of expenditure use is essential in order to know the quality of expenditure. For the same 3 ratios have been used, that is capital to total expenditure on public health and family welfare, revenue to total expenditure on family health and public welfare, as well as the share of salaries and wages among the revenue component of the same. In the results, we see a comparative analysis of revenue expenditure in the pre and the post FRBMA period. Compound annual growth rate has been the highest in Haryana, followed by Andhra Pradesh in the pre-FRBMA period and Bihar in the post-FRBMA period. A close look at the capital expenditure in the pre and the post-FRBMA period show Haryana's performance as highly dismal. Excuse me, Andhra Pradesh has been the best performing among the 3 states. The ratio of capital to total expenditure has been the highest in Bihar and has been the least in Andhra Pradesh prior to 2014, after which it has been the least in Haryana. Looking at the salaries and wages component of revenue expenditure, they have been really high, almost 70% for all the years, after which they have, after 2015, they have been almost similar for all the 3 states. We can conclude from the following study that Haryana, though being the highest NSTP and GSTP state, has not been the best performing in terms of public health and family welfare. It really needs to invest in its capital components by way of infrastructural development and asset building. Bihar, in fact, has been has performed very well in its capital expenditure. It has the highest performing capital. It has highest capital expenditure that has been done. All the 3 states need to be more fiscally prudent and reduce their salaries and wages component of revenue expenditure. Looking at the current situation of COVID-19, Haryana and Bihar have had almost similar cases, though the mortality rate has been lesser in Bihar. Andhra Pradesh has had almost 4 times the cases, and still the death rate has not been so high, which only affirms our study. So that is it. Thank you very much.
Dr. Tarika, I think this is one of the very good topic which has been addressed in this particular theme. You have measured the expenditure, public health expenditure from various. Am I audible?
Yes, ma'am, you are audible.
Okay, okay. I have just one remark on this, though it is a very good work which she has done, but it can be little bit expanded to find out the more kind of health impact parameters, not only related to COVID-19, because that is one of the disease condition which is, just one time, and it may come and go and kind of seasonal variations, and it may have some other factors which will be affected based upon, but we cannot just put up that one parameter, which is a COVID-19 number of cases, confirmation and mortality, which we can find out that, okay, this state is poor performing or good performing or a best performing. So we have to take other parameters also in consideration, that maybe some communicable and some non-communicable diseases also. So you can expand your this work, but little bit in a more methodological way. More methodological way, what I mean to say is that if you have annual kind of data and keep on uploading or collecting that data from these sources, and take their real expenditure or the real outlay which these states have been given through the central government, probably, and it's a very difficult task to do, it's very easy to say, but I think then it would be more meaningful. Else there may be many questions which can be raised, that how could you identify these three states only the performance based on only one parameter. So Tarika, this could be a little bit you can think of. Dr. Shraddha?
Yes, madam. Uh, just I want to know what is the percentage of the highest difference between the highest GSDP state and lowest GSDP state for the budget allocated for the sector. Yes, Dr. Tarika, is she there? Madam, can I move towards next session?
Yeah, I think we can go to the next presentation, madam. Thank you.
So next presentation is by Dr. Mamta Bishnoi on the topic, the social capital among elderly population of Chandigarh, a cross-sectional study. So Dr. Mamta.
Good morning, everyone. Myself, Dr. Mamta Bishnoi, PG resident in the Department of Community Medicine, GMCS 32, Chandigarh. I am presenting an article by title The Social Capital Among Elderly Population of Chandigarh, a Cross-Sectional Study. According to WHO, social capital represents the degree of social cohesion which exists in the communities. It refers to the process between people which establish network norms, social trust, and facilitate coordination and cooperation for mutual benefit. An advanced level of social participation might support physical and mental activity, and feeling of security and active engagement might result from more neighborhood and family connections. This sense is particularly important in older people, and it is now being recognized as a critical problem. Along with the increase in life expectancy and the growing number of older people, a range of circumstances can take place. Older people at increased risk of social exclusion. They might lose important part of their social environment during retirement, or loss of partner, relative, or friends through illness, death, or change in geographical location, and their health might deteriorate, lead to disease and disabilities. Social capital is a new area of research among older Indian. There have been some studies in this field, however, none of them have studied elderly adults as a population. Much research into social capital have been conducted in the US and other Western countries, which ignore the cultural context of its conceptualization. Caution must be applied in comparison in which the cultural context of social capital is ignored. Against this background, the present study was planned to know about the status of social capital among elderly population of Chandigarh. Objective of my study to study the status of social capital among elderly population of Chandigarh, and to study the factor associated with social capital among the elderly population of Chandigarh. The study was conducted from January to April 2017. A community-based cross-sectional study was using convenience sampling technique. This study was conducted in Sector 41 and adjoining village Batrela and Baderi. A total number of 296 participants were selected from the electoral roll for the interview. The interview schedule is measure social capital status of Chandigarh, contain first performa containing the social demographic details of respondent, and second is structured questionnaire to study the status of social capital and factor associated with it. Data collection. The eligible participants were approached by an investigator by making house-to-house visit, and data was collected after obtaining informed consent for the participation in the study. And they were distributed a self-administered 30 question questionnaire, keeping in mind their availability, free time, convenience, and feasibility. The social capital questionnaire was initially developed by the Onyx and Bull in 2000 and consists of 32 questions which were answered using a 4-point Likert type response scale. The Onyx and Bullen scale of social capital was primarily developed in Australia. It is being modified according to Indian context, and only 30 questions were structured covering the 8 dimensions. A pilot study was initially conducted. It is social capital include the 8 dimensions, which include feeling of trust and safety, tolerance of diversity, value for wildlife, proactivity in social context, family and friends connection, neighborhood connections, participation in community, and work connection. The set of questions among these factors are so distributed that they form a consistency in question, and the respondent may not feel stressed while answering these answers. General social capital score is calculated by summation of the score of 8 factor of 30 questions. The higher the score, higher the level of social capital. The score of general social capital represents the social capital of the individual. Poorest score 30 or less than 30. Average is 31 to 60. Good is 61 to 80. Very good 81 to 100. Excellent 101 to 20. Statistical analysis is done by Microsoft Excel spreadsheet and OpenAP 2017. 7. Descriptive analysis was used to summarize data frequency, percentage, and mean and standard deviation. Informed consent were taken from the respondent prior to initiation of the study, and no element of compulsion in participation of the study. The result of study showed that the maximum number of respondents were in the age group of the 60 to 69 years, which includes 73.3%, and minimum in the age group of 80 years and above, which include 4.4%. In the present study, respondents were male 58.3, more than female 41.7%. And these findings were in accordance with elderly population in Chandigarh according to Census 2011. Mean age of the respondent was 66.47 plus minus 5.8 years. Male-female ratio was 1.4. Out of total respondents, 45.7% owned their residence, where overall maximum number of respondents were living in the tents in the study area. 2/3 of the respondents live in the nuclear family, and rest of respondents live in the joint family. Overall, in our study, majority of male respondents having a better social capital status than female participants. Finding only 2 who scored the excellent on the status were also male. As suggested by our finding that those responded living in the nuclear family has a higher mean score for social capital, it was found that more number of respondents in nuclear family scored higher in factor 5, which is family and friends connection in present study. It was also found only 10.1% of elder respondents participate in the community as a volunteer or as a part of local association. With increasing age, underlying pathology, genetic vulnerabilities, physiological and sensory impairment, and environmental barriers increase the risk for the mobility decline. In the present study, the highest degree of response of social capital reported by respondent was for feeling of trust and safety, followed by the proactivity in social context, followed by neighborhood connections. Bridging social capital can be measured by factor 2, which is tolerance of diversity, and factor 6, which is neighborhood connection. In the present study, neighborhood connection were found to be higher than the tolerance of diversity. Better social capital score, which is measured by using neighborhood trust, and community participant, is associated with a higher degree of physical mobility, independence, and mental well-being among older individuals. The study has some limitation, which were small sample size, short duration of study, and under or over reporting of the data by the respondent. Convenient sample technique was used to select the participant due to time constraints. Social capital status among elderly of Chandigarh city was good, and more study to be conducted to get comprehensive result for cognitive and structural aspect of the social capital. Conclusion of my study is that overall social capital status of Chandigarh in the range of good means 61 to 80. Age group of 60 to 69 years scored the highest on the social capital scale. However, very old respondent having a score of the average social capital score. Male score higher than the female in overall social capital score. Out of 8 factors associated with social capital, highest mean was for factor 4 and the lowest for the factor 5. Thank you.
Thank you, Dr. Mamta. Which scale did you use for these questionnaires? Is this scale standardized in some previous studies, or was it some developed for this study? Dr. Mamta? Are you? Am I audible?
Yes, madam, you are audible, but no response from Dr. Mamta.
And what about the education level? Was there any effect of education on the respondents' outcome? So those factors, literacy and their income group, because Chandigarh have high income group more, so they found out this relationship, but it was not very obvious from the presentation probably. So I don't know, the organizers can pass their comments to those participants. Then we move to next, no, Dr. Shweta?
Yes, ma'am. So next presentation is by Dr. Neetu Shukla on the topic Women's Autonomy and Postpartum Contraceptive Utilization Among Women in Lucknow.
Good morning, everyone. Myself, Dr. Neetu Shukla. I am junior resident in Department of Community Medicine at King George Medical University, Lucknow. The topic for my presentation is women's autonomy and postpartum contraceptive utilization among women living in rural Lucknow. The literature reveals that family planning can avert more than 30% of the maternal deaths and 10% of the child mortality. And by focusing upon the postpartum family planning, we can avert majority of the unintended and closely spaced pregnancies during first 12 months after the birth. NFHS 4 states that there is high unmet need for family planning among postpartum women living in Uttar Pradesh, and majority of them do not want to get pregnant within next 24 months after delivery. However, 70% of them do not use any modern contraceptives. Evidences show that the autonomy of the woman is one of the essential factors which influences their contraceptive utilization. And this can be assessed in 3 different domains, such as first one is decision-making power, extent of freedom of movement, and control over the finances. They can be scored as 1 if the decision is taken by the respondent alone, or if the decision is taken by the respondent along with his husband. The score is taken as 0 if the decision is taken only by the partner or any other family member or otherwise. In this slide, you can see the individually different domains. In decision-making power, we tend to see that who usually makes decision about the major household purchases, who decides about the major issues such as schooling of the children, marriages of the children, and and do they need to secure permission before leaving the house for any reason. Now, coming to the freedom of movement, we see that whether she is able to leave the house without company of another adult, whether she can go to nearby places, and who takes a decision about her health care and whether she can go to her family member or her relative. Now coming to the control over the finance, we see that who usually takes decision about her or her husband's earnings, how they can be used, and whether she can spend the money without consulting anyone. Keeping these views in mind, the objective of the study was to study an association between women's autonomy and her contraceptive utilization during postpartum period in Lucknow. For this, a cross-sectional community-based study was conducted in Lucknow from 1st of October 2020 to 31st January 2021. In this, a study sample size of 185 was calculated based upon the prevalence of 65% of unmet need for family planning during postpartum period according to NFHS 4. As you can see here that we have selected purposely selected two blocks of Sarojini Nagar and Chinhat, from which 10 villages and 20 villages were randomly selected based on proportional population, and further 7 households were chosen randomly for selecting the eligible women to achieve the desired sample size. Now we can see here that for inclusion criteria, we have taken that all the married women which were between 15 to 49 years and were having at least one alive child between 12 to 24 months were included and who have given the consent for the study, whereas those who have undergone hysterectomy or whose husband expired after the delivery or who have not given the consent were excluded from the study. In this, we use a pre-tested semi-structured questionnaire and this was done after doing a pilot study. As you can see here that the data was collected regarding their socio-demographic, reproductive characteristics, their women autonomy and utilization of family planning services. Data entry was done using EpiInfo and statistical analysis was done using SPSS version 23. Ethical clearance was taken before the study. In this demographic characteristic table, you can see that the majority of the women were age group 25 to 34. Mainly they were Hindus and around 25.8% were illiterate and majority around 95% were non-working and around 40% of the families were joint families. And you can see that that mean age at their marriage was 19.6 and however you can see here that around 18.2 were marriage under the age of 8 years, and the pregnancy unintended pregnancy that means mistimed pregnancies were 20.6, whereas unwanted pregnancies were 14.3. However, we could see significant percent of abortions in our study population. As you can see here, the woman autonomy, which we have just discussed, the decision-making power was seen in around 35.4, whereas very less freedom of movement was seen as compared to the other domains. In our study, we found that 60% had unmet need for family planning, whereas 13.9% used traditional methods, and the remaining 25% were using the modern contraceptive methods. In this table, after adjusting various variables such as age, educational status, utilization of ANC/PNC services, their place of delivery, and their knowledge about family planning, we have found that the time gap between the previous pregnancies and index pregnancies and their contraceptive utilization and their knowledge about the postpartum family planning were found to be statistically significantly associated with the contraceptive usage. And in the result, as we have seen that around 40% had high autonomy, 60% of them had unmet need for family planning, and as we have just discussed that there was association between the contraceptive use and in their knowledge about the postpartum family planning. So we have just discussed that neither their age, education or socioeconomic factor alone may not be enough to increase the uptake of modern contraceptive. However, understanding the woman's autonomy is a critical factor for the especially during the postpartum family planning, during the postpartum period, for the informed policies makers to improve their maternal and child health and efforts should also be made to examine the effect of various empowerment programs and thus reducing the gender inequalities. Thank you.
I think, Dr. Neetu, this is a very good study which you have planned, and it relates to the women empowerment, and very good data has been collected by you, and I think it has been very well done. Which place have you done this study? Which area?
Ma'am, in Lucknow, in rural villages of Lucknow, ma'am. It's a community-based study.
This is a rural study.
Yes, ma'am.
Okay.
Ma'am, purely
How about the urban area? Have you planning to do this? Because there will be reverse scenario in the urban
Yes, ma'am.
situations, probably.
Actually, ma'am, we were very much keen to know that why, although there these NHM, because of NHM, these family planning services and maternal and child health services are being utilized more in the comparatively in rural areas. They are utilizing it more as compared to, but still we have seen that the family planning services are not that much being utilized. It is not only that we have seen that not only because of their education, not only because of their socioeconomic status, but still there were many other factors, and most common was the limitation of mobility, which we have found that even very educated and very good peoples, they were also not, their women were not able to move out of their houses and make their own choices about their family planning issues. So that was the main
The
reason for
duration of marriage had any effect on that? Since
yes, ma'am.
Since married, 2 years, 5 years, 10 years, 15 years down the line.
It's been seen that the marriage, the duration was not, it was not affecting their women's autonomy. They have been saying that since their marriage, they have not been going out, so it's not of no use of going after they have grown old also.
So
So it was not found associated.
could you find the role of family members like husband and other, dominance nature of the other members in the family? So was that also the factor considered in your study, or?
Yes. Ma'am, we have seen the association with the joint families, like whether their in-laws and family members, they have discussed it or not. But ma'am, somehow the statistical significance was not there, because some family members, because ma'am, some families, they do have supported their women's, but it
So
was
how
not
much was
found.
that proportion? How much was that proportion of the joint family?
Few, ma'am, few was there, but those were more of educated people, like those in whom, so but those educated people were less. So like there were families in the joint families also, and many a times there were families also who opposed the women's not to use. It was a both a mixed type of response. So maybe the more larger sample size we'll study and more places, so that we'll be able to undertake it.
Okay, thank you, Dr. Shraddha. Any comment on that?
So it's a nice presentation, Dr. Neetu. So my one question is, in your study, there is 60% of postpartum women have unmet need for contraception. So what are your recommendations to reduce this particular proportion of unmet need of contraception?
Ma'am, we have found that a majority of them were having very less of mobility, of movement basically, and their decision-making power. So they were not able to take their own decision related to family planning issues. And ma'am, they were able coming in contact with field workers like ASHA, ANM, Anganwadi workers. So they have been using their services also. Like we have asked them about their OCP use and Chaya use. So they were purely dependent upon them. Whenever they are getting chance to get or in case of condom, whenever they are getting from them the field workers, they are able to utilize that. Otherwise, they didn't have any other option of moving out of their house and getting use of these services. Like we haven't found any women utilizing Chaya or Antra. That is because for every 3 months they have to get out of their houses to get those injections. And ma'am, getting PPICD inserted was also one of the reason which was limited because of their mobility, and because of that they were not able to move out. So but we have found that somehow the resources were limited, like Chaya and Antra they were willing to use, but somehow either because of COVID or some other reason, they were not getting the continuous supply of those. So it may be that more of the supply has to be given to the field workers so that they can provide them, because they were keen to use the family planning services. As we have seen that they were tending to use them, but somehow they were not able to use that.
Okay, thank you. So we are moving towards our next presentation by Dr. Rekha T. husbands' knowledge regarding antenatal care and their involvement in antenatal care of their wives, a facility-based cross-sectional study in Mangalore. So Dr. Rekha T.
Good afternoon, everybody. The title of my study is Husbands' Knowledge Regarding Antenatal Care and Their Involvement in Antenatal Care of Their Wives, a facility-based cross-sectional study in Mangalore. Pregnancy is a very challenging experience for the pregnant mother, involving emotional mental instability as well as physical discomfort. Hence, it is very necessary that attention and nurturing is to be provided by the family members. And the most responsible family member for this would be the husband. The husband should be educated about the events that would happen during a pregnancy, and he needs to be constantly aware about the condition of his wife so that he can provide her with proper guidance and support. With this background, this study was conducted with the objectives to assess the husband's knowledge regarding the antenatal care needed by a pregnant woman and to assess the involvement of the husbands in the antenatal care and well-being of their wives. Materials and methods. This cross-sectional study was conducted in two tertiary care hospitals affiliated to Kasturba Medical College, Mangalore, that is, Kasturba Hospital, Attawar, and Lady Goshen Hospital. The study was conducted amongst the husbands who accompanied their pregnant wives to the OPDs in the above said hospitals. The inclusion criteria were married men who had given consent to participate in the study, married men whose wives are primigravida and in their third trimester, married men whose wives are multigravida. The sample size was calculated to be 150 using the formula 4PQ by D square, and a convenient sampling was used. The study was conducted between January 2020 to February 2020. A semi-structured questionnaire was used, which consisted of three sections. Section A, which included socio-demographic information of the study participants. Section B, knowledge about antenatal care among the study participants. And Section C, which had involvement of the participants in the antenatal care of their wives. The questionnaire was translated into the local vernacular, that is Kannada, and was validated for content and language. Data collection methodology. Before conducting the study, ethics clearance was obtained for the Institutional Ethics Committee of Kasturba Medical College, Mangalore. After that, permission was taken from the medical superintendents of KMCH Attawar and medical officer of Lady Goshen Hospital, Mangalore. And then permission was also taken from the head of the OB-GYN department of the study. The participants were then approached in the OPDs. They were given an information sheet and explained the purpose and the nature of the study. A written informed consent was taken from the participants who were willing to be involved in the study. Only the completed questionnaires were used for final analysis. The data was entered in and analyzed using SPSS version 25.0, and the results are expressed in means and proportions. For qualitative data, chi-square test was applied and p less than 0.05 was considered to be statistically significant. Results. Table 1 shows the socio-demographic characteristics of the study participants. Most of the study participants, that is 58.7% of them, belonged to the age group of 26 to 35 years, and most of them, that is 62% of them, were married for 1 to 5 years. Out of the 150 participants interviewed, 58% of the participants had wives who were presently pregnant. And 63 of the participants had wives who had had previous pregnancies, and 61.9% of them had one previous pregnancy. Most of the study participants, that is 60.7% of them, were between the age of 26 to 35 years when they had their first child. Majority of them, that is 87.3% of the participants' wives had delivered in a hospital, followed by 8% who had delivered in a primary health center. Coming to the second table, which tells about the knowledge of the study participants regarding various components of antenatal care. Most of the study subjects knew the various components of antenatal care. 90% of them knew that their maternal smoking had an adverse effect on the baby's health, and more than 80% of them knew about the importance of taking extra calories during pregnancy, taking TT injections, and the harmful effect of maternal alcohol consumption during pregnancy. And 89% of them knew the importance of regular antenatal checkups. Most of the study participants were aware about the importance of screening for hepatitis B, HIV, regular checking of blood sugar, and HP levels. Only 14.7% of the study subjects knew that a minimum of 4 antenatal checkups were needed during the antenatal period. Table number 3 tells about the involvement of the study subjects in the antenatal care of their wives. Most of the study subjects in our study were aware and were taking proper care of their wives and were involved in their antenatal care during their pregnancy. So 90% of them ensure that their wives take enough rest during the day and provide them support when they were emotionally unstable. More than 80% of them provided support during morning sickness and accompanied their wives for antenatal checkups as well as for ultrasound checkups. And 78% of them helped their wives in their household chores. Coming to the conclusions and implications, in our study, majority of the participants knew the importance of antenatal care and visits. However, a very large proportion of them did not have any knowledge about the number of visits required for a positive pregnancy. Our study also finds that a major percentage of husbands involve themselves in the various mental and physical aspects of antenatal care of their wives. Husbands should be involved during the antenatal counseling of their wives so as to ensure that there is a positive outcome of the pregnancy in terms of a healthy mother and a healthy baby. Thank you.
Thank you, Dr. Rekha.
Thank you,
I
ma'am.
think again you have highlighted a very important topic, which is of very social issue concerning because at that time the woman requires its maximum attention and she needs a company of the partner, and if he has to be fully aware of that what is going on. But one thing which your study has come up with the knowledge about the tetanus toxoid injections which is below average, which we should say that they are not aware of, and the ANC visits also.
Yes,
Probably that could be linked to sometimes they accompany the woman and sometimes other family member accompanies the woman for the antenatal checkup examination. That is
Yes,
how
ma'am.
people are not aware of the various factors. I would like to ask that what was the part of the study? Was it a rural, urban, or was it a mix? I really missed.
No, madam. It was an urban setup, and of the 2 hospitals that we did the study in, one of the hospitals was a district OB-GYN hospital, madam.
Okay, is it a hospital-based study? You didn't go
Yes,
to the
madam.
community?
No, madam. No, madam. It was the early part of 2020. We had initially framed the study to go to the community, but since it was the start of COVID, so we had to change the study setting to a hospital, madam.
So would you feel that the findings of this study can be, how do you explain the generalization of the results?
Yes, ma'am. That is one of the limitations that I would say my study has at this point of time, because this is a purely hospital-based study, and we have taken the responses of only the husbands who have accompanied their wives in their antenatal checkups, madam. So yes, you are absolutely correct.
So what kind of bias you are anticipating in this kind of a study?
Here, madam, first of all would be an informer bias too, because when the husbands are coming and we are taking their responses, they tend to give a more positive response. If we go to the community, the people are more, I would say, they are not guarded in their responses.
Okay, Dr. Shraddha, I am done.
Okay, yes.
Dr. Rekha, in your presentation in the results slide, so you mentioned that place of delivery of last pregnancy, hospital, PSC, others, and home. So, what do you mean by the others?
Others would be like, for example, we had very few responses in that. So in addition to the hospitals, when we asked them, they meant mainly the government hospital, which is the Lady Goshen Hospital, which we had taken, and others which they had taken were the private hospitals that they had given.
Okay, so you can mention that the private hospital
Sure,
or
madam.
government hospital. Okay.
Valid point. Well taken.
And you also mentioned that some point of knowledge is lacking in the husbands.
Correct.
So, what are your recommendations to increase that knowledge of the husbands regarding antenatal care?
Madam, what we have noticed and over the years, what we have seen is whenever we have antenatal counseling sessions, it's usually the lady who comes for it. The husbands don't usually participate in that. So we would want to recommend that, we have a peer group kind of a session for people, especially the male members who come to the hospital. So in the hospitals, that is, if we are having it in a hospital-based setting, if not in the community, definitely we need to sensitize the husbands more. So awareness campaigns and having, a focus group discussion amongst men would be an ideal thing to do.
Okay, so health education sessions you can
Yes, madam.
conduct.
Yes.
Okay. Okay, thank you.
Thank you very much, ma'am.
So this was the last presenting session in this today's session. So for the concluding remarks by the chairperson, I will hand over to Dr. Ashu Grover, madam.
Thank you, Dr. Shraddha. And I think this was a very different kind of a session, which I had been listening from couple of 1 or 2 days since when the conference has started. And it has involved various topics. And it has been very carefully the choice of the topics and the abstract selections by the organizers. And they are varying from maternal health, they are varying from nutrition, they are varying from family planning topics, and other topics like including health expenditure. So those are some of the very important topics which they have been touched upon, and some of the topics like an elderly, that social security and all those themes have been covered over here. And we had the presentations from West Bengal, Karnataka, Lucknow, Chandigarh. 2 or 3 were from the Chandigarh itself. So this has given us an overall perspective of that what is the thinking which is going on among the minds of the young researchers. So I think this has opened the door for further research, and it should go definitely into the proceedings of the conference, that this is how our scenario of the social determinants in health is heading towards. But nonetheless, some of the topics like urbanization, which is having a large impact on the mindset of the people who are moving from rural to urban areas for the want of the more income to be generated, and somehow we are losing the theme of that the culture of that rural areas, which has to be inbuilt into the any development of any human being, cultures and the customs and all those. So those are the aspects which also I think should also need to be considered. And the concept of nuclear and the joint family has also touched upon in some of the presentation. But I suppose that the kind of our young children which are to be motivated through the grandparents and the joint families, and now this screen time which has increased definitely considerably upon various periods of time. So those are some of the factors which also should be a part of the themes which can be put together as a social determinants in the health. So I think overall it was a very good session, and thank you organizers to give me a chance to listen to all these presentations and give my remarks. Yeah, thanks again. Dr. Shraddha, any remarks from your side?
Yes, so today we had a very nice session, and in this session, very good mix of studies with interesting topics covering majority of social determinants. And all the participants have presented very well. And I thanks the scientific committee for giving me this particular opportunity. So thank you once again.
Thank you very much to both the chairs, Dr. Ashu and Dr. Shraddha. Thank you so much for taking this session forward in such a nice manner. I think your comments and questions really engaged the participants. So thank you very much. And thank you to all the participants as well who have made such a hard work and presented their studies so nicely. So thank you very much. And please, both the chairs are requested to do also join us tomorrow in the plenary sessions. Thank you very much, ma'am.
Yeah, thank you. Thank you, Shankar. All the best.
Thank you, ma'am.
Walls of smoke rose from father's lips, but my first smoke felt like lung whips. Yet routine, ritual, habit it became, and life would never be the same. I continued. They, the heroes, took the puff, and I bought it on the cuff. It seemed cool, till I knew I was made a fool. I smoked. I was 20, colleagues with teeth stained red. Try it, they said. Red stains, pan and gutka stains, tobacco stains. And alas, it brought all these pains. I chewed. Bitter it tasted, and my money was wasted. Yet I spat out red, until the day I spat out blood. I bled. I understood. Importance of life's most is realized not till it's lost. People, time, money, love, air. No, this isn't fair, I gasped. Every breath a struggle. Machines giving all oxygen they could smuggle. Now it's too late to create a new slate. I knew. I left. A warning note to my son I wrote. Slow death, painful death, breathless death. This tobacco steals your breath. I cried. Little packets of lies, your pocketed rice. To life I bow, thanks to tobacco, I died.
Hello everyone, I am Dr. Vivek Sagar. I am Assistant Professor at Community Medicine, School of Public Health, PGMR, Chandigarh. I am presenting here my few lines to promote guidelines of social distancing, specifically mask adherence. This creation has got recognition in Jan Andolan competition, where I had submitted this as a written draft. Now I am upgrading it by giving it my voice and expression, so that I can convince people in better way to follow COVID guidelines. If I could able to convince at least 10 people, I will be happy. The title of my creation is Mask आज का कीमती गहना. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. कोविड जैसी महामारी से गर दूर रहना है तो मास्क पहन, हाथ धो के 2 गज की दूरी को भी सहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. बदल गया है जमाना थोड़ा जनाब, बदल गया है जमाना थोड़ा जनाब. दिल से हैं पास लेकिन जमघट या पार्टी को फिलहाल दूर दूर से ही हेलो या बाय बाय कहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. वैक्सीन भी आज आ गई है मेरे दोस्त, वैक्सीन भी आ गई है मेरे दोस्त, लेकिन फिर भी आईने में देखो जाके हर रोज. वैक्सीन भी आ गई है मेरे दोस्त, लेकिन फिर भी आईने में जाके देखो हर रोज कि मास्क मैंने अच्छे से पहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. थोड़ी सी असुविधा है मास्क में हम मानते हैं, थोड़ी सी असुविधा होती है मास्क में हम मानते हैं, लेकिन लापरवाही दिखा ऐसे सस्ते में तो मरते नहीं रहना है. थोड़ी सी असुविधा है मास्क में हम मानते हैं, थोड़ी सी असुविधा है मास्क में हम मानते हैं, लेकिन लापरवाही दिखा ऐसे सस्ते में तो मरते नहीं रहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। कर रहे हैं गुजारिश आपके भले के ही लिए, कर रहे हैं गुजारिश सब आपके भले के ही लिए, तो ऐंठ में आके ऐसे इतने असावधान क्यों रहना है। कर रहे हैं गुजारिश सब आपके भले के ही लिए, तो ऐसे ऐंठ में इतने असावधान क्यों रहना है। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। माना तुम फिलहाल स्वस्थ हो सबकी दुआ से, माना तुम फिलहाल स्वस्थ हो सबकी दुआ से, लेकिन घमंड करने से पहले अस्पताल में जाके देखो। माना फिलहाल स्वस्थ हो तुम सबकी दुआ से, लेकिन घमंड करने से पहले अस्पताल में जाके देखो। एक मरीज से लेके फ्रंट लाइन वर्कर्स को पड़ता क्या क्या सहना है। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। थोड़ी सी तो उम्मीद की है आपसे सबके भले के ही लिए, थोड़ी सी तो उम्मीद की है आपसे सबके भले के ही लिए। इलाज से परहेज बेहतर, इलाज से परहेज बेहतर, बरसों से सबका ये कहना है। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे बहना है। करनी होंगी ये चंद बातें अपनी जीवन शैली में शामिल, करनी होंगी ये चंद बातें अपने जीवन शैली में शामिल। मास्क, हाथ की सफाई, 2 गज की दूरी एवं योग और व्यायाम। करनी होंगी ये चंद बातें अपनी जीवन शैली में शामिल। मास्क, हाथ की सफाई, 2 गज की दूरी एवं योग एवं व्यायाम। अगर कोविड जैसी महामारी को जल्दी जल्दी गुड बाय कहना है। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। धन्यवाद।
Hi, I'm Sanita and I'll be reciting to you my poem titled Survivor's Guilt. Just at the turn of the 21st century, public health achievements soared astonishing heights. Here are a few from the annals that I've picked out to recite. Massive efforts were put into the concept of vaccine-preventable disease. Now the pneumococcal vaccine is included in the national immunization programs of 135 countries. We've all heard of tuberculosis. We are all aware of its monstrosities. Can you believe a vaccine against it is coming? Watch out for N72 ASO1E. What used to be multiple is now reduced to fewer maternal deaths per live births, and millions of people all over the world now receive fluoridated water. Food fortification has led to diseases like beriberi and pellagra to be of dearth, and the incidence of neural tube defects has dropped, showing that folic acid matters. But despite the successful battles we have fought against these contending foes, many are left to altercate, lurking there in the shadows. Cancers of all types still take up to 10 million lives a year. Road traffic accidents are the reasons several people still die. Anxiety has claimed the top spot in global mental disease burden, and it looks like we need a worldwide lockdown to see cleaner skies. Nearly 500 million people still remain underweight. Abuse of opioids, cocaine, and more recently cannabis has seen ascent. And the surface temperature of the earth is 0.95 degrees Celsius warmer than the average 20th century measurement. So what will we do about it? Will we bring our resources together or crack under the pressure of political agenda? Will we try our very best to make a change in this world, or will we surrender? From these wins and losses, I see the people we saved, but I see the ones we've lost too. It's not fair that so many have died when they could have had the chance to make it. I have survivor's guilt. Do you?
Lucknow, the land of Nawabs, sits right in the heart of Uttar Pradesh, India. It enchants our eyes with royal charm, which extends to the picturesque green villages. Lives in these villages have improved with construction of free toilets under the Swachh Bharat Abhiyan, the Clean India Mission. India was declared open defecation free in October 2019. But during our fieldwork, we found a hidden dimension of sanitation in these villages: unsafe child feces disposal. So we decided to look more into this matter.
मान घर में बच्चे ने टट्टी कर दिया, अब उठा करके कहीं किसी गंदी जगह पर उन्होंने छोड़ दिया।
तालों में फेंकते हैं, कूड़ा में फेंकते हैं, डस्टबिन में बाहर डालते हैं। और जो बच्चे के ड्राइवर है वो अभी भी पेपर में लपेट के ये लोग में नहीं डालती हैं।
क्या आपके घर में शौचालय है? आप बच्चों का मल कहाँ पर फेंकते हैं?
खेत भी जाते हैं बाहर भी।
इनको जब टॉयलेट कराना होता है बच्चे को तो आप कहाँ पे कराते हैं?
ये डायपर पानी रहता है, वो पन्नी में करके बाग में डलवा देते हैं और फिर जैसे ऐसे कर देता है पॉटी वोटी तो नाली में पानी बहता है, नाली में डाल देते हैं।
According to the World Health Organization, a child's stool is considered to be disposed safely when the child uses the latrine or the feces is put or rinsed into the latrine or buried. Unsafe disposal is harmful because children's fecal matter is a source of contamination because they are prone to many pathogens while crawling, playing, etc. Many infections like diarrhea, hepatitis A and D, typhoid, polio, and worm infestations can be transmitted. Repeated infections lead to reduced immunity and damage to intestinal cells. This leads to reduced absorption of nutrients, leading to stunting and poor brain growth. This in turn leads to a vicious cycle of malnutrition and poor performance in life. Breaking the fecal-oral disease transmission cycle is important to reduce the under 5 mortality. We tried to find the reason behind this unsafe practice.
इनका टॉयलेट क्या लगता है आपको? क्या इतना कीटाणुजनक होता है कि
होता है मतलब कम जी, क्योंकि अभी दूध पीता है।
Some were even shocked.
इतने जागरूक तो है नहीं, इतना जागरूक नहीं, इतना प्रचार प्रसार नहीं है।
अभी उनको हैबिट में नहीं लिया गया है, इससे इन्फेक्शन भी बढ़ता है, लेकिन मोटिवेट कर रहे हैं लोग लेडीजों को।
Realizing the need for awareness, a campaign was started promoting children's health via safe excreta disposal, or in short CHE, for the term chi used by mothers to indicate a wrongdoing by their children. Focus group discussions were conducted and mothers were taught to dispose their children's fecal matter in a safe manner in latrines, and in case diapers were used, to cover it and throw in closed dustbins. This campaign started with one village and is now extending to many others. Ashas, the community health workers, have been advised to reinforce this good practice during village health, sanitation and nutrition days and also immunization sessions. Safe disposal of children's feces along with hand hygiene and safe drinking water will improve nutritional status and health of our children. This campaign is a small step, a tiny drop in a large ocean, but perhaps this can form a tide that can wash away malnutrition and suffering.
स्वच्छता ही सेहत की निशानी है।
कोविड-19 के दौरान वेक्टर या मच्छरों से पैदा होने वाली बीमारियां। संकट का समय है और हम सभी कोरोना की स्थिति को लेकर चिंतित हैं। हालांकि यह जानना महत्वपूर्ण है कि हर बुखार कोरोना के कारण नहीं होता। मच्छरों से फैलने वाली बीमारियां भारत में हमेशा से ही स्थानिक रही हैं। इनमें मलेरिया, डेंगू और चिकनगुनिया कुछ महत्वपूर्ण बीमारियां हैं। तो हमें इन बीमारियों का खतरा क्यों है? कोरोना रोकथाम पर अधिकतर ध्यान केंद्रित करना, वेक्टर बॉर्न बीमारियों के बारे में ज्ञान न होना, बारिश का मौसम एवं तापमान में उतार चढ़ाव इन बीमारियों के ज्यादा फैलने का कारण बन सकते हैं। भारत की 80% आबादी मलेरिया के उच्च जोखिम वाले क्षेत्रों में रहती है। पिछले साल इनके 3 लाख से अधिक मामले थे। वहीं डेंगू से हर साल 1.5 से 2 लाख एवं चिकनगुनिया से 50,000 लोग संक्रमित होते हैं। तो क्या लक्षण होते हैं इन बीमारियों में? मलेरिया में ठंड लग के बुखार आता है। इसके अलावा सर दर्द, बदन दर्द और जाड़ा भी होता है। वहीं डेंगू के बुखार में सारे शरीर में टूटने का एहसास और आंखों के हिलने पर दर्द होता है। वहीं चिकनगुनिया में बुखार के साथ जोड़ों में तेज दर्द होता है। मलेरिया एनोफिलीज मच्छर के कारण होता है जो प्रदूषित जल निकायों में पनपता है और रात के दौरान काटता है। जबकि डेंगू और चिकनगुनिया ईडीज मच्छर से होता है जो घर में एकत्रित हुए साफ पानी में पनपता है और दिन में काटता है। तो इन मच्छरों से फैलने वाली बीमारियों को कैसे रोका जाए? आइए जानें मच्छरों से होने वाली बीमारियों से बचाव के कुछ और तरीके। मच्छर मारक एवं मच्छर से बचाने वाली क्रीम का उपयोग करें। मच्छरदानी का उपयोग करें। पानी की टंकियों, बड़े कंटेनरों को ढक कर रखें। कूलर और फूलदानों का पानी बदलते रहें। वह अपशिष्ट पदार्थ जिनमें पानी जमा हो सकता है, उनका निपटान करें। फुल स्लीव कपड़े पहनें।
नमस्कार, मी एकता कम्युनिटी FM रेडिओतर्फे आपल्या सर्वांचे सामुदायिक हितार्थ जनजागृती कार्यक्रमात सहर्ष स्वागत करीत आहे. व्हॉट्सॲप किंवा सोशल मीडियाद्वारे चुकीचे संदेश आपल्यापर्यंत पोहोचविले जातात. त्यांना कसे ओळखायचे त्याविषयी माहिती प्रस्तुत करीत आहे. व्हॉट्सॲप किंवा सोशल मीडियाद्वारे आपल्यापर्यंत चुकीच्या औषधी उपचाराविषयी माहिती पोहोचविली जात आहे. ही माहिती खरी आहे किंवा नाही हे बघण्याकरिता काही शासनाद्वारे मंजूर असलेल्या साईटवर जाऊन बघू शकता. उदाहरणार्थ, आयुर्वेदिक औषधीची खरी माहिती जाणून घ्यायची असेल तर आयुष मंत्रालय लिंकवर जा, किंवा ॲलोपॅथिक औषधीविषयी खरी माहिती जाणून घ्यायची असेल तर शासनमान्य लिंकवर जाऊन माहिती काढा व त्यानंतर विश्वास ठेवा. शक्य असेल तर डॉक्टरांचा सल्ला घ्या. व्हॉट्सअपवर येणारी चुकीची माहिती फॉरवर्ड करू नका. आता आपण कोरोना होण्यापूर्वी कसे वाचू शकतो हे जाणून घेऊया. आतापर्यंत कोरोनावर लस आलेली नाही, म्हणून या गोष्टीचे कटाक्षपणे पालन करा. 2 फुटाचे अंतर, नाकातोंडाला मास्क लावणे, वारंवार साबणाने हात धुणे ही आजच्या काळाची गरज आहे. कोरोनाबद्दल लोकांच्या मनात असलेले काही गैरसमज जाणून घेऊया. लोकांच्या मनात कोरोनाविषयीची भीती निर्माण झालेली आहे. ती अशी की कोणत्याही आजाराकरिता दवाखान्यामध्ये गेले की कोरोनाची टेस्ट करून पॉझिटिव्ह दाखवतात. त्यामुळे दवाखान्याला फायदाच होतो व त्या पॉझिटिव्ह पेशंटमागे भरपूर दवाखान्याला पैसे मिळतात, असा गैरसमज लोकांच्या मनामध्ये निर्माण झालेला आहे. या भीतीने लोक दवाखान्यात जात नाहीत. हा गैरसमज चुकीचा आहे. त्यामुळे आजाराचे प्रमाण जास्त वाढतच चालले आहे. या आजाराची लक्षणे बघूया. सर्दी, खोकला, ताप, थकवा येणे, तोंडाची चव जाणे आणि वास न येणे ही लक्षणे दिसल्यास उपचार घ्यायला वेळ लावतात. तर माझी ही नम्र विनंती आहे की यातील कुठलीही लक्षणे दिसल्यास त्वरित दवाखान्यात उपचार घ्यावा आणि कोरोनाची तपासणी करून घ्यावी. तरच आपण कोरोनाची लढाई जिंकू शकतो. ही तपासणी सरकारी दवाखान्यात निशुल्क आहे. आता दिवाळीला सुरुवात होईल तेव्हा सुना किंवा मुली आपल्या माहेरी येणे जाणे करतील, तर त्यांना संदेश देण्याकरिता एक गीत सादर करीत आहे. तोंडाला मास्क लाव ग सुनबाई, मग जा आपल्या माहेरा माहेरा. तोंडाला मास्क लावलं ग सासूबाई, आता तरी जाऊ द्या ना जाऊ द्या ना. साबणाने हात धुव ग सुनबाई, मग जा आपल्या माहेरा माहेरा. साबणाने हात धुतले ग सासूबाई, आता तरी जाऊ द्या ना जाऊ द्या ना. कोरोनाची लस येऊ दे ग सुनबाई, मग जा आपल्या माहेरा माहेरा. धन्यवाद. जय हिंद, जय महाराष्ट्र.
भारत चाट रहे हैं, कब एग्रेसिव हो रहे हैं, कब काट रहे हैं, हम इस पर ध्यान नहीं देते और अंजाम ये होता है रेबीज, एक दर्दनाक दास्तां. हर साल इंडिया में 20,000 डेथ्स रेबीज के कारण होती हैं और इस लॉकडाउन में जानवरों को फॉस्टर करना, उन्हें अडॉप्ट करने वालों की संख्या काफ़ी बढ़ गई है. तो आइए हम आपको एक ऐसा ही किस्सा सुनाते हैं. मिलिए मिस्टर दुबे, मिसेस दुबे और बंटी से.
आभा, जरा चाय ले आइए. अरे बंटी बेटा, आप आ गए? ये क्या लेके आ गए आप अपने साथ?
पापा, मुझे पपी रखना है पापा, प्लीज. पापा ये दौड़ रहा था मेरे पीछे पीछे, प्लीज मैं इसको रख लूं क्या? प्लीज प्लीज पापा.
आभा, आइए देखिए बंटी क्या लाए हैं.
अरे अब क्या हो गया?
मम्मी प्लीज पापा को बोलो ना, प्लीज मम्मी, प्लीज पापा को बोल दो ना कि इसको मैं रख लूं प्लीज, वरना इसको कोई गाड़ी ठोक जाएगी. प्लीज, कितना क्यूट है ये, देखो प्लीज प्लीज.
बंटी, क्या है ये? मना किया था ना कोई डॉग्स अंदर नहीं आने चाहिए. रेबीज हो जाता है इससे. एक बार हो गया ना, बहुत सारे इंजेक्शंस लगेंगे. मुझे कोई आर्ग्यूमेंट्स नहीं चाहिए. जल्दी वापस करके आओ जहां से लाए.
बेटा, मम्मी सही बोल रही है, इसे छोड़ आइए.
तो क्या बंटी अब पपी अडॉप्ट नहीं कर पाएगा? लेकिन बंटी को तो यह बात पहले से पता थी कि उसके मम्मी पापा ज़रूर मना कर देंगे, इसलिए उसने अपने अंकल आंटी मिस्टर एंड मिसेस शर्मा को बुला लिया था.
अरे मिस्टर एंड मिसेस शर्मा, आइए आइए.
आंटी ने हमें बताया था मिसेस दुबे, मैं आपका कंसर्न समझ रही हूँ। रेबीज बहुत ही खतरनाक बीमारी है। मतलब इसके इनिशियल सिम्टम्स बहुत नॉन स्पेसिफिक होते हैं, बुखार, दस्त, उल्टी, थकान, सर दर्द, पर धीरे धीरे बीमारी बढ़ती चली जाती है। मतलब बंदा बेचैन होने लगता है, हेलुसिनेशंस, इवन पैरालिसिस तक हो जाता है, और लास्ट स्टेजेस में हाइड्रोफोबिया, एरोफोबिया, यानी कि ही इज इवन अनेबल टू स्वॉलो, दौरे पड़ने लगते हैं विद इन 10 days, एंड देन डेथ। और अगर किसी डॉग को रेबीज हो जाता है तो उसके मुंह से झाग निकलने लगते हैं, बहुत अग्रेसिव सा हो जाता है, वो सबको काटने दौड़ता है। और रेबीज सिर्फ डॉग से नहीं होता है, किसी भी मैमल से हो सकता है, कैट, बैट्स, फॉक्सेस, किसी भी मैमल से। और सही ट्रीटमेंट ना मिलने की वजह से मौतें इतनी ज्यादा होती हैं।
आंटी, मेरी जो टीचर है ना, उन्होंने भी बताया था कि जब भी कोई कुत्ता काट ले ना तो उसको ऐसे झाड़ फूक और ये उस पे ऐसे नहीं दिखाना चाहिए, घर पे कुछ स्टिचेस भी नहीं लगाने चाहिए, सीधे डॉक्टर के पास दिखाना चाहिए।
कुत्ते के काटने के बाद तुरंत जितना जल्दी हो सके 15 मिनट तक साबुन एंड पानी से अपने हाथ अच्छी तरह धोएं। एंटीसेप्टिक्स का यूज करें, इरिटेंट सब्सटेंसेस का यूज बिल्कुल ना करें। बेयर हैंड से घाव को बिल्कुल ना छुएं और ना ही उसे कवर करें। पेशेंट को जितना जल्दी हो सके हॉस्पिटल ले जाएं, और अगर सुपरफिशियल स्क्रैचेस हैं तो रेबीज वैक्सीन, और अगर बहुत ही गहरे घाव हैं खून निकलते हुए तो रेबीज वैक्सीन एंड रेबीज इम्यूनोग्लोबुलिन यूज किया जाता है।
और अपने पेट्स का इम्यूनाइजेशन कराना, इट इज़ द मोस्ट इम्पॉर्टेंट वेपन इन रेबीज कंट्रोल। मतलब जब पपीज 3 या 4 महीने के होते हैं तो प्राइमरी इम्यूनाइजेशन होता है, और उसके बाद रेबीज के बूस्टर्स लगते हैं जब पपी 1 साल का हो जाता है, और उसके बाद जब 4 साल का होता है तब। एंड एज पेट ऑनर्स हमें प्रिकॉशन के तौर पे स्टैंडर्ड वैक्सीनेशन करा लेनी चाहिए।
Dogs are definitely our best friends and therefore we need to take best care of them.
मम्मी प्लीज मैं इसको रख लूँ ना।
ठीक है बेटा, रख लो, लेकिन एक कंडीशन पे, पढ़ाई अच्छे से करनी होगी, ठीक है?
थैंक यू।
ये तो हुई हैप्पी एंडिंग, मगर इंडिया को हैप्पी और हेल्दी रखने के लिए हमें एक बहुत लंबी रेस दौड़नी पड़ेगी। हमें हमारे पपीज़ को इम्यूनाइजेशन करवाना पड़ेगा। वो काट दें तो हर्बल रेमेडीज़, इरिटेंट्स, बैंडेज, सूचरिंग या मैजिकल प्रैक्टिसेस से दूर रहना पड़ेगा, क्योंकि गलत ट्रीटमेंट ही हमारी जान ले जाती है। कुत्ते के काटते ही उसे साबुन से धोएं, एंटीसेप्टिक लगाएं और डॉक्टर के पास जाएं। इम्यूनोग्लोबुलिन के शॉट्स लगवाएं, वैक्सीन लगवाएं, पूरा कोर्स कंप्लीट करें, क्योंकि रेबीज़ का सिंगल डॉट वैक्सीन आज तक नहीं बना है। पूरी और प्रॉपर ट्रीटमेंट ही आपकी जान बचा सकती है।
आज की इस दुनिया में लोग क्या कहेंगे पे बहुत जोर है। ये कुछ और नहीं, हमारी अंदर की अस्थिरता का शोर है। मैं ये नहीं कह रही कि सहमति है नहीं ज़रूरी, पर तब तक ही जब तक वो बन ना जाए एक मजबूरी। बाल अवस्था, किशोर अवस्था और फिर प्रौढ़ अवस्था, हमेशा दूसरों ने ही की है हमारी भावनाओं की व्यवस्था। दूसरे की राय सुनकर तो 10 कदम की दूरी को 20 कदम में तय किया। विचारों का इतना बोझ हमने अपने ऊपर व्यर्थ ही लिया। तुम्हारा तन, मन, धन और विचार सिर्फ और सिर्फ तुम्हारा है। इनको पूरा कैसे करना है ये कर्तव्य भी तुम्हारा है। अपनी मर्यादा आप खुद ही तय कीजिए, पर दूसरे क्या करते हैं उस पे टिप्पणी मत कीजिए। जिंदगी बहुत छोटी है छोटे विचार रखने के लिए, इसलिए बड़े विचार रखें इसका मजा चखने के लिए। दूसरा अपना सही गलत खुद ही सोच लेगा, आप अपने पे समय दीजिए, वो ज़्यादा लाभ देगा। आलोचना और मजाक में फ़र्क समझिए, बोलने से पहले थोड़ा सोच लीजिए। निष्पक्ष रहना एक गुण है बड़ा, जीवन में आए कई नकारात्मक विचारों से यह है लड़ा। एक दूसरे को जीवन में बढ़ाइए आगे, फिर देखिए कैसे जुड़ते हैं ये सुनहरे धागे। तर्क वितर्क करना गलत नहीं, पर दूसरों की भावनाओं को दबाना भी सही नहीं। जो आपका सच है वो दूसरे का झूठ हो सकता है, इसलिए दूसरे की सोच को इज्जत देने से बहुत फर्क पड़ सकता है। और अंत में मैं यही कहना चाहूँगी, इस समय किसी को ये ना बोलिए कि देश जल रहा है और तुम हंस रहे हो, कि देश जल रहा है और तुम हंस रहे हो, क्योंकि याद रखिए इसी हंसी को बरकरार रखने में आंसू उन्होंने भी बहाए हैं। इसी हंसी को बरकरार रखने के लिए आंसू उन्होंने भी बहाए हैं, क्योंकि हंसी तो बस चेहरे पे है, अंदर सबके लिए दुआएं हैं, सबके लिए दुआएं हैं। धन्यवाद दोस्तों, आशा करती हूँ आपको मेरी ये कविता पसंद आई हो। इसी तरह मैं अगले हफ्ते फिर एक नई कविता लेकर आप सबके सामने आऊँगी। तब तक के लिए शुक्रिया, गुड नाइट।
The poem goes like this. The first wave of COVID-19 at the beginning of pandemic terrified us to live each moment in panic. In days it reached the crest, although we tried our best. Lost in the unknown quest, then started hiding in our nest. It was just to console the lost soul, like someone denied after playing for. What scared us most, standing close to anyone in a row, seeing the mask lie on the jaw, disobeying the hand washing law. A breath of relief when we flew off the cage. Cases were low, post peak, so is our inner sage. Sad, we took it for granted. A wicked witch enchanted. Our path again got haunted. We did everything unwanted. Before we celebrate came the second wave, reminding the forgotten lesson we have. Things will never remain same. Nature will find ways to tame. We humans are just a name. She's the one playing all the games. What we can do is abide by the rules, understand the dark side of the jewel. Living with it is not a choice but very essential. Needs contribution which must be substantial to fight the crisis that could be of existential, to avoid the waves which could be exponential. Make physical distancing a norm, hand washing to kill all the germs, wear the mask and do not roam, practice social solidarity to deal with the storm. Thank you so much.
I was 15. Worlds of smoke rose from father's lips. But my first smoke